Ronnie.
Yeah. So, good morning, everyone. So, we are into our newborn week celebrations. And on this auspicious occasion, it's a privilege to welcome you all for our NNF Kerala Newborn Summit 2020. First, I welcome our chief guest, Dr. Rati Balachandar, ma'am. She is the Additional District General of Nursing for MOH Government of India. Welcome, ma'am. Next, I welcome our guests of honors, Professor Dr. Armida Fernandez, ma'am. She is the founder and chairperson of the Society for Nutrition, Education, and Health Action, called SNEHA. She was the past NNF president, and ma'am started the first human milk mag in the country at Sion Hospital in 1989. Welcome, ma'am. I welcome Professor M.K.C. Nair, sir. Sir was the former Vice Chancellor of Kohas University. I then welcome Dr. Vivek Singh. Sir represents UNICEF India. It's our privilege to welcome the guest faculty from outside state, Professor Dr. Somashekar Nibalka, Dr. Suman Rao, and Dr. Mangala Bharti. It's my honor to welcome our National IAP President-elect 2021, Dr. Ramesh Kumar, sir. I welcome all other senior faculty members and leaders from IAP and NNF Kerala. Last but not the least, I welcome all the nurses, doctors, and other healthcare worker fraternity to our webinar. And I hope you all will have a wonderful session ahead. Thank you. And now I welcome Manoj sir. He is the President NNF Kerala. He will take over the session.
Chief guest, Dr. Reddy Balachandar. Guests of honor, Professor Armida Fernandez, Professor M.K.C. Nair, other dignitaries, respected seniors, and my dear friends. Now, we straight away go on to the first session. This is on neonatal resuscitation. As we all know, the outcome of neonatal resuscitation is the first step in improving the outcome of neonates. So, I will not waste much time. We are going to be, the biggest challenge for us today is going to be time management. So let's go on straight to the topic. Neonatal resuscitation protocol has been originally formulated by the American Academy of Pediatrics, American Heart Association, subsequently adopted in India. Now we have an IAP NNF first golden minute project, NRP, the first golden minute project, and we have two of the key persons for that to lead the discussions on this symposium. So I welcome both of them. Dr. Sachidananda Kamath, he is the chairman of IAP, NRP, FGMP, and I also welcome the speaker for the day, Professor Dr. Somashekar Nimbalkar, who doesn't need any more introduction for all of us. He is the national coordinator for the IAP NRP program. I also welcome the chairs for this session, Dr. Professor Dr. PMC Nair and Dr. Krishnan Indulmadi. So now may I request Dr. PMC Nair, the chair, to take over the session. Okay, there is some glitch. We will go on to the chair. The discussions can be moderated by the chair. Now, may I request Dr. Sachidananda Kamath to kindly introduce the concept of neonatal resuscitation, and then let's go on to the topic. Thank you.
Good morning to you all. President Dr. Manoj, our chief guest Dr. Reti, guest of honor Dr. Armida Fernandez, my mentor Dr. Professor M.K.C. Nair, chairpersons of the session Dr. PMC Nair, Dr. Narayanan, first speaker of the day Dr. Indu, first speaker of the day, and my dear friend Professor Somashekar Nimbalkar, and the convener coordinator of the NRP program. Indian Academy of Pediatrics started a project named Neonatal Resuscitation Program, first golden minute in 2009. Since then, it has been a flagship program of IAP with the objective to help in reducing the neonatal mortality rate in India. Government of India also has recognized our module, which was formulated by the IAP as well as NNF, and the project involved the training of healthcare professionals and workers in the neonatal resuscitation and also the essential newborn care, which Government of India has taken as NSSK program or the training of 2 days for throughout the country. The mission was to have deal with birth asphyxia and reduce neonatal mortality rate. The objective which we formed at that time was at least one trained person at every delivery in neonatal resuscitation. We plan to complete 2 lakh healthcare workers, which involved during and immediately after the delivery. With this in mind, we started the program 2009, and so far we could complete 3,313 courses, in which includes the basic NRP, BNRC full, advanced NRP, district TOT, which we are contributed to the trainers of the trainer, that is the trainers for the throughout the country, in which 3,800 trainers are there throughout the country. Regional TOTs were conducted and government NSSK program. With this, we could complete 1,21,000 healthcare workers trained throughout the country. But we have, with this, we have achievements like MOU with state governments. Government of Kerala has accepted, Government of Karnataka, Government of Gujarat, Chhattisgarh, those governments also accepted IAP as their partners and started programming on the NRP program. And we could create a master trainers, more than 3,000. Still, we are having challenges. That is reaching to the unreached areas, especially for the state with high MMR as well as IMR as well as NMR. Conducting training in the remote areas and coordinating with the state and the IAP officials is our challenges. And there are various updates which is also happening in the NRP in outside India as well as in our scientific academic body also. With this, our flagship program of NRP through the IAP NNF program, there are some of the changes which is going to happen, and I would request Professor Somashekar to have some of the neonatal resuscitation introduction to the what is new in NRP guidelines in 2020. There are slight changes are there. So I would request Professor Somashekar to enlighten on that and that topic on what is new in NRP. Over to you, Professor Nimbalkar.
Thank you, Kamath sir, and it's a pleasure to be here. It's a pleasure to be here at the symposium on the Neonatal Summit organized by NNF Kerala. And I would like to share my screen. Can I be allowed to share my screen? While I share my screen, I would like to thank Dr. Kamath and others for their leadership over the last decade or so, during which NRP has increased or expanded across a lot of places. I remember 2 or 3 decades back, we used to hardly get any training in neonatal resuscitation, and it was not available to in many places. But over this last decade or so, anyone who wishes to get trained in NRP can actually just visit the website of the NRP FGM program and log in and ask for a course to be done, and courses do get done regularly. Unfortunately, due to COVID, there has been a drop in the number of courses being organized due to distancing, etc. But we are going to be starting again, and we have already done some courses in this particular month. of IAP NRP. I would like to thank Dr. Manoj and others for also allowing me to speak at this occasion, and I will proceed with my lecture, and I hope to do it in a short period of 15 minutes or so, because as we see, and the flow of the, as we see, there is not much changes, but it just depends upon how the changes are being made. We'll have a look at the algorithm and the various parts which are there, and then we'll see what are the gaps in the knowledge at the end. So why newborn? We have roughly 2.4 million deaths occurring across the world, of which roughly 0.7, 0.6 million happen in India. While the NMR currently is 22 live births, which is almost 75% of NMR, unlike other parts of the world where it is almost 50% of the IMR. Neonatal encephalopathy due to birth asphyxia and trauma. This is the second highest cause of neonatal death in India in 2017 after preterm births. And if you just look at the first 2 days of life, then birth asphyxia contributes a major part for neonatal deaths. What it indicates is maybe doing trainings in neonatal resuscitation can improve mortality, neonatal mortality figures. So in a systematic review published in 2017, it was found that training birth attendants in neonatal resuscitation does reduce birth asphyxia as well as neonatal mortality. It reduces stillbirths, because a lot of stillbirths are actually neonatal deaths are classified as stillbirths because it reduces the amount of paperwork that needs to be done by the healthcare workers. There's a drop in 7-day neonatal mortality by almost half if training in neonatal resuscitation is done, and a 28-day neonatal mortality by almost 50%, and overall perinatal mortality by 37%. So what it tells us is that doing training in neonatal resuscitation does improve mortality. Most of the babies require just simple newborn care, around 85%, while 15% will need stimulation, and only a few will require bag and mask ventilation, and less than 1% require advanced care. So this is your neonatal resuscitation algorithm in 2015. This was published in October 2015. And what was published last month is this particular algorithm. Apart from the fact that I'm telling you it is 2015 and 2020, if you look at it in detail, I don't think there is a single word that is changed in the algorithm. There's hardly anything that has changed in the algorithm. So basically, the algorithm is the same. There has not been major change in an algorithm in 2020. In 2015, there was a change of meconium that happened, where intubation for meconium-stent amniotic fluid babies who were non-vigorous was removed, and it was asked that you could bag and mask ventilate all those babies straight away instead of intubating them. So that's changed majorly in 2015. But so in 2020, nothing much has changed. So what has changed? What is the advantage of the algorithm remaining the same? The training per se does not need to change much. The steps of training, all that we need to do does not really need to change much. I'm saying that the algorithm has not changed much. There is going to be a new textbook that is going to come out next year from the American Academy of Pediatrics. And what has changed is there is more evidence that has been gathered for various changes that have happened in the last few editions. What changed in 2015 is also the delivery of the curriculum. Curriculum has moved online and has become more and more app-based, where people do case scenarios on the app and give exams online. So that is what has changed in the last decade or so, and that almost remains the same. Just to give a brief overview as to how these changes do happen. In 1992, there was this committee, what was called as ILCOR, which came together, which brought together resuscitation organizations from across the world, and it has major organizations, and they look at guidelines every few years. So almost every 5 years or so, the guidelines are relooked at, and if anything, they do change. Somewhere in 2017, the 5-year cycle was interrupted, and they said that they will release guidelines whenever something new comes up. So some changes did happen in 2019, where they released things related to oxygenation at birth, and which has been re-emphasized in the 2020 guidelines. prior to that, most of the resuscitation that used to happen was based on experience and what was considered as best practice at that point of time. But over the last 2.5 decades or so, we have more and more evidence being put into resuscitation. So how does this evidence come up? If you remember reading older guidelines in 2005 or 2010, we used to have something called as LOE1, LOE2, or class of recommendations. So as more and more guidelines are following systematic reviews, there has been change in the way in which evidence is being presented. So across all my slides, you'll see these colors, and they look at the strength of the recommendation, and they look at what kind of evidence is there. So you have a class of recommendation where the authors of the guidelines tell you what do they feel about the recommendation. They strongly believe in that recommendation. They have a weak belief in that recommendation, or and so in that way they kind of stand by the recommendations. There is actually detailed literature on what words should be used while drafting the recommendations. Okay, so that's pretty important. Plus also is the level of evidence. So level of evidence is what kind of quality of evidence is there. So class 1 is strong. You can see it put up in green. Class 2 would be moderate recommendation, class 2A. Class 2B would be weak recommendation. And as you go down to class 3, there is no benefit. And if you go to class 3, there is harm. So there is class 3, no benefit, in class 3 harm, which is put up in red. So class 3 is actually again a strong recommendation for which the risk outweighs the potential benefit. So this is how your class of recommendations follows in the new guidelines. Again, the levels of evidence is level A is very high quality evidence based on RCTs or meta-analysis. And then level BR, which is based on randomized studies, and level BNR, which is based on non-randomized studies. And then there is LD, for which there is limited data, and for level C, EO, which is expert opinion. So if you look at the way, unlike the previous recommendations where it came in a single paper and there were references at the bottom of the paper, in this particular ILCOR guideline, what has happened is they have cut down resuscitation into various parts, and for each part, chunks of evidence has been presented. So you have something, then there is evidence for it given, then there is more write-up given, and there is references given. So it's written a different kind of way across all guidelines. As of now, the American Academy of Pediatrics has released the guidelines along with the American Heart Association. The European Resuscitation Council has not yet released their guidelines. It is still in the draft stage and available for comment on the website, and it will come out soon. So these guidelines will get done by the end of the year across major societies across the world. And I think it is important for IAP and NNF to come together and also formulate similar guidelines for Indian newborn babies. While there are this class of recommendations and level of evidence, they are quite independent of each other. So you can have one level of evidence for a weak class of recommendation and vice versa. So it reaffirms major concepts. So these guidelines mainly apply to newly born babies who are basically transitioning from the delivery room to stabilizing in the postnatal ward. So that's what is called as a newly born baby. The guidelines also apply to babies in the neonatal period up to 28 days of life, but most of the evidence is actually related to the transitional period and not related to what happens after the transitional period. But because there are no separate guidelines, these same guidelines apply across the neonatal period. Okay, so again, it establishes lung inflation and ventilation as being crucial. Another thing that is emphasized is while most of the guidelines initially looked at ventilation and establishment of adequate lung inflation, more and more evidence is coming together that even the transitional period is related to mother-infant bonding and breastfeeding. And so these are also having more the actions that we do in the transitional period or in the immediate 1 hour or 2 hours after birth have an influence on infant bonding and breastfeeding as well. And so these are also being emphasized. So there's anticipation and preparation. So this is what is identified, that we need to have at least one trained person in all delivery areas whenever a delivery is happening, and have more than one if a high risk delivery is anticipated. It is important to have anticipation for high risk deliveries because if you fail to identify high risk deliveries, then it is likely that there might be a poor neonatal outcome. So it is important to understand as to what high risk factors that we are supposed to ask for in preparation for a delivery. Another thing that has been identified is unless you resuscitate as a team, even though individual people might be well qualified or well skilled, if they don't work together as a team, then neonatal outcomes are supposed to be poor. Hence, it is important that people who attend deliveries work together as a team and even train together as a team. So when they actually attend a delivery, there is not much confusion among them. Cord management. So there has been, as evidence grows, delayed cord clamping is more and more emphasized, and this is usually done after the baby is placed on the mother, dried and assessed for breathing, tone, and activity. And this also applies for preterms. Over the last 5 years, the evidence for having delayed cord clamping for preterms has increased. Also, placing these babies on the maternal abdomen has also increased. Initial actions are, this is not initial steps, this is just the actions. Babies should be immediately placed on the mother's abdomen after delivery. So you deliver the baby on the mother's abdomen. Radiant warmers and other adjuncts are only required for babies who are very preterm or very low birth weight babies. So it is important to note the words used. It just says very preterm and very low birth weight babies. What in other words it means is babies who are late preterm or moderately preterm can be placed on the mother's abdomen and can undergo delayed cord clamping. Just the fact that the baby is 35 weeks or 36 weeks does not mean that you shift the baby to the radiant warmer. So this is what it actually indicates. Heart rate assessment initially is to be done by auscultation or by palpation, but usage of ECG and oximetry, pulse oximetry is also to be emphasized. Positive pressure ventilation, everyone knows, is important, and an improvement in heart rate and establishment of breathing is a sign of effective PPV. So that there's not much change there. Oxygen therapy, this changed in 2010 mainly, where people shifted from 100% oxygen straight away to 21% oxygen in term babies and in late preterm babies. For the last 10 years or so, research has gone on, and there is not much change as far as what oxygen should be used at birth for babies who are born preterm. But the current evidence says that you could go from 21 to 30% oxygen, and based on the saturation readings that you get, then you can change the oxygenation that is done for the babies. This is essentially because most of the studies that have looked at low oxygen or high oxygen for preterm babies have not suggested much differences between the outcomes. So it's okay to start with room air to 30% oxygen in preterm babies. Unlike adult resuscitation, where there is, once you intubate a child or an adult, there is no connection between chest compressions and ventilation. Both can proceed independently. In the neonate, unlike other kinds of resuscitation, there is always needs to be coordination between chest compressions and ventilations in a 3:1 ratio. Vascular access, again, umbilical venous route is preferred, and if IV access is not feasible, then the intraosseous route may be considered. Medications, again, epinephrine is one which is sustained, and other drugs are not really much mentioned apart from volume expanders. And volume expanders is especially if there is no response to epinephrine and if there is known blood loss, or if blood loss is suspected based on history or examination. A little bit of change has occurred as far as withholding and discontinuing resuscitation is considered. Up to almost 20 minutes of resuscitation needs to be done before discontinuation of resuscitation. It clearly does not mention whether it is 20 minutes of asystole, but what it actually suggests is that you have to spend at least 20 minutes in the resuscitation area doing resuscitation, and preferably you should have done good positive pressure ventilation. You should have done adequate resuscitation for you to consider withdrawing resuscitation. As far as ethics go, withholding resuscitation as well as discontinuing resuscitation, both are considered equivalent to each other, and it does not matter whether it, like suppose it's a 25-weeker baby or a 24.5-weeker baby, and you're not sure what is to be done. If you decide not to resuscitate, it is as good as trying to resuscitate and then discontinuing resuscitation after some time. Both are ethically considered to be equivalent, so it does not matter which way you go. So this is one of the major changes that has happened if you consider, and this is based on research where they looked at outcomes of babies who were resuscitated beyond 10 years of 10 minutes of asystole, and they found that many of these babies actually had a good outcome later on when they were evaluated later on in childhood. One of the major factors which we really don't know much about is actually training. Now, as I mentioned earlier, training has shifted online in terms of apps, etc. What has been found over the years is whenever you do trainings, Dr. Kamath mentioned that we have trained 3,000 plus providers, trainers across India, and I think around 160, 170,000 providers across India under the IAP NRP FGM program. But what happens is many of these people forget the resuscitation skills over a period of time, and it is common, and it is not it is across the world. It does not change, and most of the skills are lost after 3 to 6 months after training, especially if the skills are not practiced on a regular basis. So while currently when you do a NRP program under IAP, NNF NRP, the certificate mentions that the certificate is valid for 2 years. It is well known that you could lose the skills within 3 to 6 months of life, 3 to 6 months after doing the course. What it indicates is you need to get regular training. Regular training is not mentioned. There's a new concept called as low dose high frequency simulation, where and we do it in our NICU. What we do is we have a warmer, we have a mannequin and a bag and mask kept, and everyone is expected to practice once in a while under the Helping Babies Survive program carried across India in 2016 and 2017. People were asked to do weekly simulations practically every week and report that they have practiced one particular skill. So in this way, it is expected that if you practice the skills on a regular basis using simulation, you are likely to maintain the skills. So this is as far as human factors and systems are concerned. I think I've reached at 9:30. I have a lot of slides, but I'll just skip through them because I've described most of the things that has happened. And I will just point out to the important factors that are there. Okay, so this is what I talked about: anticipation of resuscitation need, that every birth should be attended by at least one person. And so there is a standardized equipment checklist should be there. If there are more high-risk births like twins or triplets, then you have to have more and more people attending. If you look at over here, there is the class of recommendation, the level of evidence. So this is level B non-randomized, level B non-randomized. So this is level C, low level of evidence, which is there. So based upon, so this is what it says. I will skip this slide. So coming to umbilical cord management, again, minimum that you should be clamping the cord for 30 seconds to 1 minute, not earlier than that. So every unit can decide whether they want to do it 1 minute or 30 minutes, and this can 30 seconds or 1 minute, and this can be a unit policy. Again, the level of evidence varies. It is expected that when the guidelines come in 2025, and I surely expected that we will have what is called as intact cord resuscitation. So when the baby is born and the baby is not breathing, the cord is actually not cut. The baby is kept next to the mother, the intact cord, and the baby is resuscitated. There is quite a bit of evidence coming in that when you resuscitate a baby with an intact cord, which is still attached to the placenta inside the mother, the chances of survival are more. So there are equipment, there is equipment available which allows you to manage this. I think there are 2 commercial equipments available in the UK and US, while there is one that has been made in Chennai by one of the professors there, and it's been trialed in Chennai. So we have that possibly is going to come up next time. So delayed cord clamping is important, and cord milking is definitely not indicated. Temperature at birth. So it is important that baby's temperature should be maintained well, and it is very important to prevent hyperthermia. So this is not changed much. Again, you can see this is very good class of recommendation. Class of recommendation is 1. Okay, and temperature management for newly born babies as to whether you can warm rapidly or warm slowly. it really doesn't matter much. Coming to this is an important significant point which is stressed more and more. It was stressed last time around, but this time this is received more stress. Clearing of the airway and tactile stimulation of newborn infants. So clearing of the airway is not really very important. So one should not really routinely do tactile stimulation or suctioning, even if the amniotic fluid is meconium stent. So this is something significant because a lot of people do this and it is actually not indicated. So we should try and avoid this. Okay, so avoiding unnecessary suctioning prevents the risk of induced bradycardia as a result of suctioning of the airway. People who have been in this field for many years would remember that when the babies, especially during cesarean, baby is really hot, baby cries, and we have taken 2 decades back baby to the warmer and done suctioning because we were told that we should suction, and then the baby becomes bradycardic when somebody is auscultating, and then we end up doing bag and mask to the baby. That this would probably be because we had done deep suction at that point of time. Nowadays we don't do it any longer. Okay, so let's again tactile stimulation. There is more research that is going around in tactile stimulation, but we should try and avoid it if apart from cleaning the baby. So coming to meconium stent amniotic fluid, when the last recommendations were presented that we should not be suctioning non-vigorous newborns by tracheal suctioning, there was only one RCT which was utilized, that was from India, from JIPMER, but following that 2 or 3 more have been published from India, and this evidence is becoming more and more useful that we should not be intubating non-vigorous infants. But after you have done bag and mask, and if you feel that you need to suction the trachea, it is still appropriate to suction the trachea if you feel that there is obstruction. So if you feel that there is obstruction, then it is okay to intubate and suction the trachea, not otherwise. Okay. So heart rate is assessed by ECG, and initially you can continue to do auscultation of the precordium, and that's a preferred physical examination method, but having a ECG or saturation monitor is useful. Always remember that saturation monitor may not be useful for the first 1.5 minutes of life. Roughly it takes around 60 seconds to 90 seconds for the saturation monitor to show some saturation. So I will skip this. If you're doing chest compressions, you should be using ECG. So this is very clear-cut mentioned right now. Another thing is, if you start chest compression, then you should be starting with 100% oxygen. Ventilation. So we need around 20 to 25 centimeters of pressure initially when you start, and the rate of ventilation is around 40 to 60 breaths per minute. Okay. Any delay in initiating ventilatory support in newly born infants increase the risk of death. So this is the main reason why it was found out that if you delay ventilation, and that was one of the reasons why suctioning meconium stent amniotic fluid went out, because every delay in ventilation causes a 16% increase in the risk of death. Every 30 seconds delay increases the risk of death by at least 16%. Okay, and the adequacy of ventilation is mainly by finding out a rise in heart rate, either by auscultation or by ECG, and less reliably by chest expansion. I'll skip this. What was done was something called as sustained inflations. Sustained inflations was utilized in, I think, UK for some time, but following the SAIL trial, sustained inflations are avoided currently, and you don't need to do sustained inflations in the initiation of bag and mask ventilation. CPAP can be used for preterm babies, and this is recommended more and more, and it has been found to reduce the risk of bronchopulmonary dysplasia in very preterm infants. Oxygen, as I told you earlier, I will skip this because we have discussed this. Chest compressions. Now, chest compressions, again, there are various methods of chest compressions, and the ones encircling the chest with the 2 thumbs is the preferred one. And when you start chest compressions, you should start with 100% oxygen. So I have discussed this in detail earlier too. Intravascular access, again, as I discussed earlier, we should be having IV access. If IV access is not available, intravascular access can be done, and it is quite easy. You can use a needle, a wide bore needle to do it. Volume replacement I have discussed earlier in my few slides. Post-resuscitation care. Now, if you look at the NRP guidelines of Indian Academy of Pediatrics, it is very important to understand that there is a slight deviation what IAP NNF does as compared to AAP. There is something called as observational care, where if the baby receives bag and mask ventilation for 30 seconds to 1 minute, less than 1 minute, you shift the baby to the mother side and observe there. And the AAP algorithm does not have observational care, and it has what is called as post-resuscitation care, where all babies go to the NICU. The difference is because in India, everywhere where the babies are delivered, there may not be an NICU available, and we don't want to transfer a baby who might anyways improve. Okay, so we have to mention monitor glucose levels because that can also go low and can cause damage to the brain. You could do either rapid warming or slow warming, and there is not going to be much difference. I've discussed withholding and discontinuing resuscitation earlier. I just want to emphasize that if you look at each of these slides, there is this class of recommendation of level of evidence, which is given more prominence in this particular guidelines as compared to the previous guidelines. And what I have not shown in the slides is for every particular point that is made, there are specific references made that this evidence comes from this particular studies. Okay, so I think that's that, and we can go to what is called as gaps in our knowledge. So these are a few slides, and this is important for especially us. We really do not know how often should we be getting regular training. So this is something which needs more research. What is the effect of briefing and debriefing on team performance? Briefing is when you try and explain before the delivery area who's going to do what, and we discuss the resuscitation in advance. And debriefing is after that particular resuscitation is done, it is discussed with the entire team. This is important because this leads to learning and improvement in performance next time. So how often this should be done is not really known. During and just after delivery, various things like cord management strategies for non-vigorous infants or those with congenital heart or lung disease, we do not know. Optimal management of it is still okay to do RCTs for babies who are born through MSAF because we don't have a lot of RCTs as yet. So what it specifically says that we need to improve our understanding even in that area, despite there being guidelines. Hypothermia, how to manage. Then early resuscitation, which is the most effective device for providing positive pressure ventilation. So most people nowadays prefer TPs. There are people who use bag and mask with a PEEP valve. There are people who use flow inflating devices. So which of them is actually better? There is no particular evidence with respect to that, and more evidence needs to be generated for that particular thing. Whether using ECG improves the outcomes, we do not know. And other devices can be used for finding out the heart rate. Again, optimal oxygen management during and after resuscitation, there are still gaps. Novel techniques such as sustained inflation come when it is done along with chest compressions, doses of various drugs. Okay, what are the indications of volume expansion, and what to do with pulseless electrical activity, and various populations such as various preterm babies, what needs to be done, and if there are congenital. So there are various gaps in our knowledge which need to be looked at. We should also look at many of these things from the Indian point of view and see what is feasible in our setting. Okay, and so as I mentioned earlier, resuscitation of newborns in other settings, because this guidelines mainly is for the newly born infants and it is extended to the other newborn areas. Post-resuscitation care for various other administration techniques. And of course, therapeutic hypothermia. So this is going into neonatal intensive care. But again, when should therapeutic hypothermia begin? At what point of time, etc. Yeah, I think that's comes to my this. I'll stop over here, and with a summary that we have made a lot of progress since 1992. There's not much change since the last edition, but we expect more evidence for these strategies. A lot of questions remains to be solved, and it is important that we do our own research, because if you note, the meconium and amniotic fluid research has almost all the RCTs have come from India, which has brought the change in guidelines from Delhi, from JIPMER and other places. Much of the evidence for training also has come from systematic reviews and trainings done in India, in Nagpur, Belgaum, and many other places. So India has contributed to a lot of neonatal resuscitation research. In fact, one of the papers that we had published from Karam sir is referenced in the education section of resuscitation guidelines this year. With this, I would like to stop here and invite you for a webinar on 19th, where we have the people who began Kangaroo Mother Care, Colombia, Dr. Natalie Charbak speaking, and Dr. Niels Bergman from Sweden speaking. We have our Indian competitors, Dr. Nanavati, Dr. Udani, and Dr. Ghosh also will be joining us. Thank you very much, and I am sorry if I have exceeded time by about 10 minutes. Thank you.
Thank you. Thank you, sir. Thank you, sir.
Thank you, Dr. Thank you, Dr. Somashekhar Nimbalkar, for the good presentation. It's a bit disappointing that NRP 2020 is same as NRP 2015. I was expecting more changes. Only change they said is about discontinuing registration after 20 minutes. Earlier it was 10 minutes, but this seems to be more reasonable. At the time you do everything adequate, it will reach up to 20 minutes in no time. Then there are some areas which are raw areas, as you said. 100% oxygen sudden shifting during chest compression is a bit confusing, because from till then we are saying about 21 to 30% oxygen, and chest compression suddenly you are making to 100%. So it's a level of evidence and all is a bit confusing. Then most of the situations where class of recommendation and level of evidence, they are given so much importance for that, so it's making it difficult for the postgraduates to study. Anyway, and both of them are not tallying also. Then there are, between the lines, they said about risk stratification tool into low risk, moderate risk, and high risk. I think that is a good issue. That is a good plan. And now I think there's one question from Dr. Bennett Silem asking about stomach wash in meconium stained amniotic fluid. Dr. Indumati, she's the president of, and you want to answer that question, Indumati?
Sir, Bennett's question. Usually we are not doing stomach wash unless it is really necessary.
We don't, it is not a routine for us at all. It is not a routine for us at all. And there's a question from Dr. Praveen Venkatagiri, I can see, is about high frequency training. So I agree with him. One, there is not much evidence. There is evidence, some evidence published from Nepal by people in the US, where they have looked at high frequency, low intensity training. They have found that doing low frequency, low intensity, high frequency training is useful in maintaining skills. One of the things that we found, because I work in neonatal pain as well, so when we did training for neonatal scales in NICU nurses, we found that their knowledge actually improved when we did assessments later at 3 months. The reason why their knowledge improved is because they were practicing neonatal pain prevention in the NICU after they got trained. What happens is when you train people for neonatal resuscitation, and if it is a PHC or if it is a CHC where not many deliveries happen in a year, so there are at times in a year maybe 5 to 10 deliveries happening. Okay, and if out of those 10 deliveries, none of them required resuscitation, you will definitely, by the time next year when a baby comes, you are going to forget it. So it's difficult to retain those skills. Even if you know, like many of the faculty members who are very senior do not attend resuscitation after like 10-15 years into practice. If they are called, they would definitely say, let the senior resident or the AP resuscitate, I will stand and give advice rather than do the actual skills. So it is just a question of practice on a regular basis. So unless people practice on a regular area, regular time, then only we will be able to maintain skills. The main thing that we need to practice is actually bag and mask ventilation, because that is something which everyone should know. I have seen ASHA workers and nurses do very good bag and mask resuscitation if they're trained adequately. It's not something, it's not really rocket science, but maintaining the skill on a regular basis is important.
So one
I saw a question by Dr. Balachandar, which he can.
Yes, sir. I think some person has asked for a website link for the website training. One person has asked.
I'll post the link in the chat, and Dr. Binesh has asked some question. Yeah. I will send him my mobile number. He can contact me on my mobile number.
Yeah, because we are crossing the time.
Yes.
Today is a very tight program.
Stomach wash and meconium. I don't think gastritis can occur because of meconium. Usually we don't give stomach wash.
No, we don't give.
Thank you, sir, for enlightening us those guidelines. And Our aim is to improve the neonatal mortality, reduction of neonatal mortality and improve neonatal outcome. I think as a team we should work. I think that's what is very important.
Yeah, that's true. Okay, thank you.
Thank you very much, and I hope to listen to rest of the presentations. Thank you very much. Bye.
Thank you.
Thank you, sir. Thank you for the update so much. Yeah, next talk is about the single-digit IMR and beyond. Now, what are the strategies and what are the challenges we face? So I call upon Dr. S.S. Kamath, sir, to start the session. And to chair the session, I call upon Dr. T.P. Jayaraman, sir. Sir is the President-elect IEP Kerala for 2021. And Dr. Balachandra, sir. Sir is Secretary for IEP Kerala. Can take over session, sir. Thank you.
Respected Dr. V.C. Baloj, President NNF Kerala, Dr. Ramesh Kumar, President-elect IAP 2021, Dr. Vishnu, Dr. Ravi, President NNF Kerala, Dr. Bala, Dr. Kamath, Dr. Somashekar Nimbalkar, Dr. PMC Nair, Dr. Binukutan Roni, and all the organizers and all the delegates. At the outset, let me thank NNF and organizing team for giving me an opportunity to chair this session by our visionary leader, Dr. Kamath, who crafted the steps to single-digit IMR as President of IAP Kerala, and who laid the foundation of a model of collaboration between a professional organization like IAP and Government of Kerala in achieving this important social milestone, which is an important sustainable development goal. And I'm very happy to chair this session by Dr. Kamath, who is the National Coordinator of NRP also. And having reached the SDG target, I think every numerical is important, and every infant death is important now for a state like Kerala in maintaining the IMR level. And the process of infant death audit and other measures taken by IAP in collaboration with IAP by Government of Kerala in auditing every single infant death and analyzing the root cause goes a long way in maintaining the single-digit IMR. And I feel a lot of low-cost interventions in reducing the perinatal and neonatal mortality, like improving the NRP booster training, as Dr. Somashekar Nimbalkar was telling, to the small hospitals also, and also exclusive breastfeeding, delayed cord clamping, and in popularization of antenatal steroids and low administration of magnesium sulfate, and awareness regarding the government schemes like Hridyam and pulse oximetry screening, and all those things goes a long way, along with the safe hospital and delivery room practices in reducing the neonatal sepsis also has to go a long way in states like Kerala in reducing the IMR further and maintaining the IMR at a lower level. With these small words, with a few words, I ask our past national president, Dr. Kamath, to continue the deliberations on maintaining the SDG goals. Thank you so much.
Thank you, Dr. Jayaraman, my dear friend and President-elect of IAP Kerala State, Professor Dr. Sukumaran, Dr. Divakar, other dignitaries on the platform, Dr. Tony, others, PMC, Dr. PMC Nair, Verma, and others who have been working hard for the last so many years for making this dream happen. Every person of the Kerala, that is, mean it, who are looking after the children of this state are important, and they are the person who are to be credited for doing, with the help of the healthcare workers who have been other than the doctors, who had made our dream come true by making sure that it is single-digit IMR only. With these words, I would start my presentation. I would like to share the screen, please. Can you hear me and see the slides?
Yes, sir.
Okay, thank you. This is a single-digit IMR, which was our dream. That is around 8 years ago, when I was the president, and with my colleagues over Kerala, has started this journey. I would just go through that journey, how we could reach to a single-digit IMR, whether it's a right choice that we have chosen for making Kerala as the first single-digit IMR for the country, as well as show it to the whole over the world. And what are the strategies which we have, and what challenges we could face now in future. Infant mortality rate regards as the important sensitive indicators as the health status of every community, and it reflects the intervention for the improving the child and maternal health, which has been utilized as a healthcare indices in throughout the country or anywhere as the indicator. You can see that trend in IMR in India has been falling from 50 in 2000 last 10 years to 32 in 2018 SRS bulletin, which published 2020. A steady decline is happening in the world, in the state, in the countrywide also. And there are variation. We all know that India is a huge country where the culture, religious, political, various reasons that it is a diverse city, areas where we have in the area where it is more than average of Indian in the Madhya Pradesh, Uttar Pradesh, 48 and 46. And the other end, we have the single digits like Kerala, Goa, Mizoram, Nagaland, and the neighboring states which are picking up like the Tamil Nadu, Andhra, and the Karnataka. So the diversity is so huge that we have to have different strategies. Story of how we achieved in single digit IMR. You all know that this is the 20 years from 1971 to 2011, when we analyzed that, when the India, in the first 20 years, you can see that first 20 years from 2011 to 1971 to 1991, when the India had dropped by 40%, Kerala has dropped by 72% with the various strategies by the private public participation. But from 1991 to 2011, can you see that when the India dropped 48% of the infant mortality rate, Kerala would achieve only 25% from 16 to 12. We all know that it is not an easy job to bring down the IMR from a level after the 20 mark of infant deaths. So what has happened in the last 10 years, 2004 to 2014, this is stagnant with 12, that 12 or 13. This is what has happened and taught us what to be done for the Kerala. This has made all our pediatricians all over the state to sit together with the neonatal colleagues of ours, to neonatologists who join together to make sure that what will happen. See, this is another graph. When from the 2003 to 2013, 10 years, everywhere there is a drop, but Kerala still remained the same with only 1 or 12 or 13 difference. Further, what to be done? So the slow decline with further reduction of IMR to single digits was a dream, and the rate at which almost stagnant for many years, for more than 10 years. We have a good government at that time, which had associated with through the Kerala government, NHM, NRHM, and IAP joint hand to make sure that whether is it true that our total reporting system where SRS and NFHS is right or wrong, or whether the actual infant deaths occurs or not. We have chosen the 4 districts where Ernakulam, which has the metropolitan, Kollam, which has both the tribal as well as the urban, Wayanad, which is a backward, and Kannur is a mid area. These were chosen for a study which was 1 month long, incentivized. Every death was reported and analyzed, and this was the exact method to develop. And we could find in that 3 causes for the death was prematurity, congenital anomalies, and infection. This was and you can see that infant dying in the Kerala in the three things was prematurity, congenital anomaly and sepsis. While comparing with India, the 63% is prematurity. Pneumonia, that is post-neonatal period pneumonia, contributes to them as a India, overall India, and birth asphyxia and birth trauma, which is also important as far as Indian studies are concerned. This has led to us to formulate a complete guidelines how to go about without having a common thing which will have the all India level. So we should have planning for the reduction. That is, we have seen that more than 70% deaths were neonatal, and to take care of the neonatal. With this background, we have reported, we have planned, and we have submitted a report to then Health Secretary and the NHM Director, what to be done for the Kerala. And since then, for the last 6-7 years, various programs have been implemented, like newborn metabolic screening program throughout the state, all over the state. It is currently for the public sector, but it is involved in the private sector too. Now they are willing for that. Sepsis management, AMR, recently it was published that sepsis management is very, very important. NSSK training program for the birth asphyxia, I'll come to that in the next few slides. Infant death audit, which was mentioned by our President-elect, Dr. Jayaraman, which was formed 3-4 years ago, that a committee on the district level to find out we will choose the few deaths in that district and audit that whole in a particular method, how it was audited and why the death has occurred, and go to that. It is not the fact, it is not the thing which has to be complained, or nowhere it has been medico-legally has been tangled. There is only the fact what has happened. So every district had 3 or 4 IAP members with the district administration, RCH, with private public participation. Every 2 or 3 months, infant death audits have been functioning. So this has been due to the corona problem, we could not have for the last 3-4 months. Hridyam project, which we have submitted. There were only one institution, public sector, that was in Sri Chitra, and the private institution in Amarta was doing the neonatal or the infant surgeries for the heart case. But later on, it was, but the operation in the private sector was not being incentivized or not being implemented for the public sector, that's the poor patients. So the Hridyam project, which has started, then there were other units also started functioning, Lisi Hospital, Aster, then in the Malabar area, also in the Calicut also, the congenital diseases have been started operating in the Hridyam project, where government will take care. And we have seen in the papers that the transport of the newborns to the nearest place, that is running in 200 or 300 kilometers with this program. JSSK, which is the free of cost treatment for every child. Asha Kiranam program for the free treatment. Free transport of this newborn babies or the transport. Management of disability, DIC, which has been formed after the post. Immunization campaign for the post-neonatal also has been through the web, and the current president also, Dr. Narayan, also has been instrumental in making an app and to increase our immunization status as well. Dr. Somshekhar has written that what benefits and other things. We have done an independent survey on NSSK program, which done in a most structured manner, out of which 125 trainers were trained for conducting throughout the state, with around 4,580 members, that is doctors, as well as in the private, public, nurses, as well as the healthcare workers were trained. The external evaluation summit was after having done in the 3 phases, that is immediately after the training program, after 6 months or 8 months, within 1 year, then after 2 years. This is the conclusion which has formed. That is undoubtedly generated the best possible result by the NSSK. Skills became confident. Those people who have trained become the confident, and healthcare workers involved were not only the pediatricians, house surgeons, birth attendants, as well as the postgraduate. Immediate care, what has happened? That 45% of the respondents now deliver the baby on the mother's abdomen in Italy. 35% in the study participant expressed that give prime importance to keep the baby warm, not switch off the AC and fan at the time of. These are the knowledge which we could pass on. Vigorous cry does not permit to go for a suction. And the changes which has happened in the neonatal resuscitation program, that is, 82% study participated revealed that give systematic resuscitation program which they have studied in that course of the program. 18% helped them to correct their previous wrong procedures which they were doing. Changes in the previous prevention of infection and early need. 42% revealed that adopt sterile precautions, and 32% hand washing was necessary, and they trained and they followed that. 61% had promoted early initiation through. Still we are not up to the mark of 100%, which we have to do something about that. These are the new skills which they have formed in that training program, out of which you can see that systematic resuscitation in 88% have assumed that they could achieve this skill training in this. Barriers in the transforming the knowledge. Gynecologists were not trained before, 28% responded to that. Not practicing as KMC because of the culture, 27% have trained. Very few staff are trained, 45%. Staff shortage was one of the issues, that is 44%. And the trained staff posted elsewhere in the duty rotation, 12%. They started, already trained persons were started changing their rotation duty. With all these things, we have the infant audit every month, which has been functioning. One of the pictures which is happening in Cochin. This has led that NFHS as well as SRS to bring out that actual fact sheet. This is what has happened. The infant mortality rate in 2015-16, 4 NFHS has reported that, 6 as the urban and 5, and total of 6, and under 5 for the 7 by the NFHS, and it has been authenticated by USAID, UNICEF, all the organizations. Look at this at the 2014 to 15 of our data which is collected in the government of Kerala. Still we have around 6 as in Kerala, from ranging from Wayanad 9 to the 4 at some of the districts like Kozhikode. But we should see that we are still having 3,000 deaths per year in our state, which we should be focusing now onwards. No infant should die in Kerala. That is what our aim should be. With that, the achievement start functioning, start propagating through the media. You can see that international medias as well as the state and the national medias covered that infant mortality rate scores better than the US. You can see here also the changes which has happened in the 2013, 5 and 16. That is 10 years difference. You can see that 75 to 85 immunization, all the parameters have increased in this, including the immunization practice from 66, from the below BCG is also increased. All the parameters which has increased from the last 10 years to that level. What have we achieved as far as the SDG targets are concerned? We have all over the India, we missed that MDG goals, which was set on 2000, but now again, WHO, UNICEF, all the other organizations have put in SDG targets as 2/3 reduction of 2020 and 50% reduction 2030. Assuming that, and the 2/3 reduction of IMR, that is from 12 to 8 by 2020, 6 by 2030. NMR from 7 to 5 by 2020, 3 by 2030. Under 5 from 14 to 20. Target 3-2 by 2030, preventable deaths of newborn and under 5, less than 12 and less than 25 for the all India. But we have achieved these targets by now itself for that 2030. When the nation goes right, we go left. That's the different matters, because the interventions need to be catered from state to state. It is not the same interventions which is to be carried to the Maharashtra or to the Madhya Pradesh or to Bihar. It is one shoe does not fit all state. We should have the programs which is to be catered to that state, including the states also. We should have different for the vulnerable children as well as the mothers. Like for example, no endemic malaria as far as the prematurity concerned. There is to improve the institutional delivery, JSY. We have 99.9% are in the institution. So we don't have to go into the JSY or the other. So we have to fix up our own programs for the state. Still, strategies for the vision are 4 things we should think over. That is the now focus on newborn survival. We should not have even single death in the Kerala. Scaling up the evidence base as mentioned by the previous speaker. Address to the prematurity congenital anomalies, which is still a gray area which has to be, and specific state health initiative to look forward for a more and more program to involve private-public participation, which is still there, and the 70% of the deliveries, 60 to 70 deliveries are in the private sector. We should not forget this, which was published in Outlook, 58 deaths in Attapadi. This happens in Kerala also. We should also have this kind of things also to be looked into, not only as a state, making nutritional rehabilitation, screening anemia, increasing the access to the link workers, and support the native members who are more influential in that area to take care of the tribal and the vulnerable population. 4 steps which we should move forward, that is policy breakthrough for filling the critical gaps. We have critical gaps, analyze it, upgrade the skills, and make sure that updated versions are also available. 3-cornered approach, that is professional, that's academic initiative, administrative, through the private, public, as well as the government sector initiative, where we should act all together. Demand initiative, that is from the patient side, we should look into and make sure that they are also taken care of their demand from their side to be looked into. Attaining the achievable through willful and concerted effort added to the work. We have to keep on concerted effort with the government, because everything works with the government, with the public-private partnership. And whatever we have achieved, we have to ensure that it is sustained for throughout our life, and no child should die also we should have. With these words, I thank all the pediatricians, neonatologists, all the healthcare workers who had made our dream come true, and every effort by all the healthcare workers in our state to make it possible. It always seems impossible until it is done. The famous quote from Nelson, I am quoting, and thank you very much for giving me an opportunity for present this program, this dream. Thank you.
Thank you, sir. Thank you, sir. That was a wonderful journey of IMR and IDA story in the last 1 decade by Sajid sir. No wonder he's called the single-digit IMR person. Actually, this story starts in 2013 when Kamath sir took over as the president of IAP Kerala State, and we were in a stagnant mode. And sir's action plan was single-digit IMR for Kerala. And in 2015, he became the national president. And in between 2-3 years, we again went back. And actually this IDA review meetings, everything started when Sach sir became active in the state from 2017, when we had regular review meetings. And last 3-4 years, we are doing well. And according to the 2019-20 statistics, I have with almost all the branch districts, our IMR is 5.21, very close to our presidential action plan of Narayan sir of 5 by 2020. And according to statistics, the maximum IMR is with Kasaragod and Alappuzha, 7.76 and 7.68, whereas the least IMR is with Cochin, 3.38, and Kottayam, 3.61, and very closely, one more district is there below 4. So our IMR, we can happily say that it is 5.21, even though the SRS data is 7. And regarding the causality assessment, what Sach sir said was correct. We have prematurity, congenital anomalies, and infection as the leading causes. But I am sure our NNF President Manoj will, Dr. Manoj will disagree with that, because asphyxia also will come very close to the fourth in the list of causality assessment in infant death. So with these words, I again thank Kamal sir for giving the wonderful lecture, and we'll go for discussion. I think there are not much questions in the chat box, only comments from Professor Someshwar sir, that Kerala is a model state which has ensured some of the best newborn care in India to its newborns, and advocacy for the newborn needs to be continued. So thank you, sir. Any discussion, any queries, we can discuss.
Thank you. I see that all our senior members, Dr. Divakar, others also who have also, and Dr. Raj Mohan is not there. Raj Mohan, Vandram persons, everyone has put in their effort to formulate that module to be presented. Dr. Indu Madam, all are there. Dr. Sukumaran sir is there.
Thank you, sir.
Actually, sir, the infant death audit, two drawbacks for us here is regarding causality assessment as well as the uniform line listing. And there should be a team at the state level to discuss complicated cases, because there is overlap of diagnosis in many cases. So at least 10% of the cases we have wrong diagnosis, and which has to be discussed at the state level by a team, expert team. Over to Manoj.
Thank you, sir. So from neonatal resuscitation and infant mortality to the major areas where we need to be highly proactive in our advocacy, we go on to another symposia which is equally important, or probably one of the problems that we face all starts with there. So this is comprehensive lactation management. The problem exists right from the primary care up to the tertiary care. So we had two sessions for this. First is a panel discussion on challenges and the way forward as far as comprehensive lactation management is concerned, exclusive breastfeeding is concerned, and all the related issues. And to moderate this session, we have none other than Professor Dr. K.K. Divakar. I welcome you, sir.
Thank you, Manoj. Am I audible?
Yes. Kindly take over and then introduce the panelists and then start the discussions.
Am I audible?
Yeah.
Okay.
You are.
Thank you, Manoj, and the rest of the galaxy of teams sitting there. I have really been privileged to take over the session with so many luminaries. I was wondering how to introduce them. So that's a problem, because each person is a higher designated person. So I thought the most diplomatic way would be to go as the alphabetical order. So I will start off first by starting with K, Dr. Kishore. Dr. Kishore Kumar is a consultant neonatologist at Cloud9 Jayanagar. That's a very small way of saying that. but he's also the founder chairman of the Cloud9 group of hospitals. So he's not a small guy in that sense at all. And also he's a professor at Notre Dame University in Australia, Perth. He's a visiting professor at the Indira Gandhi Institute of Child Health. And to top it all, he's got an executive MBA from Harvard. So now we all know how he managed to start Cloud9. So, ladies and gentlemen, once Kishore is done with, we felt that nothing can be complete without having the obstetrician with us. And with us, we have none other than Professor Lalitampika, Professor and Head of the Department of Government TD Medical College, Alleppey, who brings with her torrential amount of experience. She was a past president of FOXI of Kerala State and an interest in fetal medicine, obstetrics, ultrasonography, high-risk pregnancy, and other interests. And then comes Professor Nair, Professor PMC Nair. Perhaps I could say the senior most practicing neonatologist today in the state. I won't like to go into any of his qualifications other than he is Professor Emeritus of SAT Hospital, Trivandrum, or the Trivandrum Government Medical College, Professor and Head of the Department of Gokulam, huge amount of publications, and also consultant in the Kerala Institute of Medical Sciences, as well as at Anandapuri Hospitals. And personally for me, I have no hesitation in saying that I would not have been a neonatologist if Professor Nair did not give my reference to Professor Elizabeth John in Australia. It was because he gave the reference that I was selected to become a neonatology trainee under her. So I owe him a lot more than just respects.
Thank you.
And then we have none other than Professor Nangia, Professor Sushma Nangia, the ever dynamic person. She likes to call herself the vice president of NNF, but I think she's this takes up vice president of NNF and all are small things for her. She's a neonatologist, a preeminence in this country who has been in the field for the last 25 to 30 years. She's a director, professor, and head of the department of Kalavati Saran Children's Hospital, the wing of the Lady Harding Medical College, Delhi, which is one of the largest obstetrics and pediatric hospitals of this country. Welcome, Sushma. Thank you for waking up in the morning in Delhi. I was worried the polluted airs of Delhi would have kept you sleeping for a longer period. And none other than that, we have Professor Subramaniam, Professor Namita Subramaniam, who's the Professor Head of the Department of Obstetric Nursing of College of Nursing of MOSC Medical College, my institution at Kolancheri. Namita is one of our very dynamic nursing persons who has hands-on experience every time. I find her always in the labor room. So I felt she's probably the best person to go ahead with this series. Without too much ado, I would like to start off the sessions. And the pattern we have followed is very straightforward. The order of presentation is slightly altered. We'll do the obstetric points of view first by Professor Lalitampika. Experience from Northern India with all the problems coming in Dr. Sushma Nangia. Then experience from private and corporate hospitals with Dr. Kishore. Experience in government, private, and corporate hospitals and 40 years of neonatology experience by Dr. PMC Nair. And nursing points of view and the experience from the real ground zero level, because this is where the problem actually occurs. And none other than we have Professor Namita Subramaniam to help us of all these patterns. I wouldn't like to waste any more time, and I would like to just hand it over to the speakers. But I have been told by Dr. Manoj that I have about 3 to 4 minutes to be allotted for each speaker. I'm running with a time clock. So those who are sharing their slides, please remember, after 3 to 4 minutes, you'll have me interrupting in between. So Dr. Lalitampika, over to you, and let's get the ball rolling. Go ahead, madam. All queries, please put into the the question and answer box. Thank you. Dr. Lalitampika, please go ahead.
Madam, you have to unmute.
Okay. Am I audible now? Yes. So regarding exclusive breastfeeding, as obstetricians, we always advocate exclusive breastfeeding, but there are always some impediments. And the advantages the mother has from exclusive breastfeeding, we always highlight. And involution of the uterus is promoted by exclusive breastfeeding starting from soon after birth. It will prevent PPH or controlled blood loss due to better contraction of the uterus. It will establish bonding, prevent excessive weight gain to the mother. It acts as a contraceptive if it is exclusive. And the economic aspect is very important, but if mother has to give extra feeds or supplementary feeds, she will have to spend 2,000 to 3,000 rupees at least per month extra. Then long-term benefits also highlight regarding because of suppression of ovulation and hypoestrogenism during feeding. It can prevent breast cancer, it can prevent ovarian cancer. Then regarding benefits to the baby, always we highlight regarding benefits to the baby also. Screen is not moving. So I'm not going into details of benefits to the baby. Only one thing I want to highlight is it will improve the mental health through the childhood and adolescence, which we learned only recently. Maybe I learned only recently. If the baby is breastfed exclusively for more than 6 months, there is less chance of depression, delinquent behavior, attention issues, and other psychological problems. And all the other benefits, all of you know. To the environment also, breastfeeding is beneficial. It saves energy, plastic-free, biodegradable, and so on. So during antenatal period itself, we talk to the mothers regarding benefits of breastfeeding and promote them or motivate them to initiate breastfeeding as early as possible after delivery and continue. And coming to the impediments and limitations I have observed is during immediate neonatal period, unavoidable obstacles are there. In many high-risk pregnancy units, as we have many referred cases, 2 preterm, 2 sick mothers, many babies are immediately transferred to neonatal unit, so they cannot initiate breastfeeding within 1 hour due to medical reasons. Very often, intravenous fluids or formula feed is initiated before breastfeeding because of the various reasons. Then one is retracted nipple, cracked nipple, painful feeding. All these also create obstacles to continue exclusive breastfeeding. Then when mother is sick, now in the era of corona, actually initially we were separating, mothers were not at all willing to feed the babies and all babies were separated from mothers. Now we have succeeded in motivating these mothers to feed. During feeding, with all precautions, mothers are feeding, then baby is kept at a distant place. Yet another impediment I have found is inadequate quantity of milk. One is real inadequacy in conditions like diabetes, especially pregestational diabetes, where there is definitely inadequacy of breast milk. Then mothers who have undergone breast surgeries is a real problem. Then other situations where the mother and grandmother feels that breast milk is inadequate in spite of proper counseling. When baby is crying, they think breast milk is inadequate and they resort to supplementary feed. Then sometimes the pediatrician will find that the baby is dehydrated and feeding is inadequate and supplementary feeds have to be given. Then baby has hyperbilirubinemia. Then also baby is given extra feeds. Then real contraindications to breastfeeding, we have no other option. After discharge from the hospital, many mothers do not continue exclusive breastfeeding, even if they do it in the hospital. This is because of various social factors, working mothers, non-availability of leave, lack of crush near the workplace. Then attitude of the mother and grandmother is very important as far as I have observed. Because some grandmothers say, I have not breastfed my daughter and there's no problem for her. Then why my daughter should not sleep during night? During night, I can give her a baby a supplementary feed. So the attitude of the grandmother and husband also don't want to get disturbed too much at the night. And after 3 months especially, they start supplementary feeding. Then lack of family support. Poor ladies, they have to do all the household activities and they are not able to feed the baby in time. Then maternal anxiety is yet another important factor. And the most important is the lack of awareness of concept of exclusive feeding. They think they can feed the baby will get all the benefits, but they will also give supplementary feeding. They are not aware of the benefits of exclusive breastfeeding. Then when they are traveling, discomfort about nursing in public, aggressive marketing by companies on formula feeds, all these motivate mothers to start supplementary feeding. And what I observe is usually after 3, they start supplementary feeding. At least till 3 months, somehow they give only breast milk. But after 3 months, they start giving kurukka and other things. Now, what I suggest is we give antenatal classes.
I think we'll have to now speed it up a bit.
Yeah, the last slide, sir. Antenatal class is the most important thing we find useful to promote breastfeeding. Each expectant mother with the mother-in-law or mother is encouraged to attend the class. And during these sessions, we tell them all about breastfeeding and motivate mothers and family members to follow injection. And after delivery also, you spend some time with them to elaborate on breastfeeding. I think this will help in establishing exclusive breastfeeding. Then during third trimester antenatal visit also, we will encourage them and talk to them about, and retracted nipple if present should be corrected after 36 weeks. Thank you.
Thank you, madam. Just a query, if there are question and answers, please mark it. I wouldn't like to waste time. We have exceeded by about 1 minute. I hand over now to Sushma to take off, and Sushma, lead us where you would like to go on this question. Go ahead, Dr. Sushma.
Yeah. Good morning, everyone, and thank you so much, Dr. Divakar and the Kerala NNF for inviting me here. So I don't have any slides to share. May I request Madam to stop sharing her screen? So I'll just be talking about the first and foremost thing is Divakar. It appears very bad from when you see it on the media, but actually when we are staying in Delhi, it's not as bad. So we can breathe. And we've celebrated Diwali last night very well without much crackers. I mean, personally for me, no crackers, but around also the crackers have come down a lot. So it's quite breathable and it's nice, sunny, bright morning. So breastfeeding is something which is very, very close to my heart. And I will begin by saying that I, being a doctor, a pediatrician, when my baby was born and by cesarean, managed to feed my baby. I had insisted on my younger sister that they should not give anything to my baby. I have to breastfeed. I was under anesthesia. She supported me to give the first feed, and thereafter actually exclusive breastfeeding for the 6 months. That was ensured with the help of my mother-in-law, my younger sister, and the family. So what helps you is your people around who will be there to support you. So my concept of exclusive breastfeeding is that obviously we all know it is for the first 6 months that the baby should receive nothing else apart from his or her own mother's milk. And we really know that it does everything that is required. It saves lives. There is economic implications. The baby's IQ is better. Physical, mental, and non-communicable diseases all are taken care much better when the baby is breastfed as compared to when the baby is not breastfed. So, I mean, it is on us to ensure that we pass on the relevant information and the evidence that is there, which is supporting all these aspects. The impediments really are that currently women are getting married later, then they are producing babies at a much later age, and these are nuclear families and women are working. So with nuclear families, there's no real support from the other family members who might just visit her while during her delivery and they soon leave thereafter. That is about the women in the family. So they are single people, and as my previous speaker said, the woman has to also look after her household work as well as look after the baby and do all that. So there is very little support from the family because of nuclear families. Then the impediments are that duration of maternity leave. In organized sector, in government, there is still something called as maternity leave, which is 14 weeks, 18 weeks. In India, of course, it is 6 months. But rest of the world, 53% of the countries only have 14 weeks maternity leave. This needs to be ensured. Then healthcare professionals like us, we have very little time to talk about breastfeeding. I'm glad our obstetrician colleague here is saying that she is looking after breastfeeding aspects so much, but not many obstetricians. It's really the domain of the pediatricians and the neonatologists wherever they are. And then our IMS marketing, which has to be really curtailed and looked at because infant milk substitutes, they are all over and it's so easy to dissolve that and make the milk and feed it to the baby as compared to making an effort in the night to get up, sit and feed the baby. My suggestions really are that both the institutions and the communities have to come together to support breastfeeding. There has to be a breastfeeding culture which has to be inculcated. And we have to disseminate the true knowledge and the evidence that is there regarding breastfeeding and its benefits. Of course, IMS industry has to be curtailed. So we have to have workplace interventions. How many of our institutions have a place where a lactating healthcare worker, be it a nurse or a resident, can actually, or even a support worker, can actually express milk or can actually take care while she's a lactating mother and she's started working? So that doesn't happen. At least I can say I've been trying, but I have not been able to have a place where it's more than 1,000 bedded hospital and there is a staff which is 5,000 staff, all included from faculty on to the Safai worker. But that doesn't happen. My personal experience in trying to augment this process is in the labor room, what I have ensured is that no mother baby is wheeled out of the labor room unless the first feed has been ensured. So the obstetricians want their tables to be cleared, the OT operation table, the labor room tables. But our insistence is unless the baby's had the first feed on the labor table, the baby and mother are not moving. Ours is a public hospital. It's a huge hospital with something like 15,000 deliveries. So things don't happen. They are in a hurry that, okay, shift this to postnatal ward. So the first and foremost thing that we ensured is breastfeeding on the table. The first feed has to be there, which syncs very well with the routine care and the breast crawl and breastfeeding. So that is being protected. The second is, as I'm a neonatologist in the NICU, we ensure that the mothers are coming to the NICU. In fact, we promote them to come. If they don't come, we even tell the family that if the mother is not coming, if she's not giving her milk, if she's not expressing milk, we will discharge the baby because they are getting free treatment here. In private, they will pay 50,000 rupees per day for her baby's care in the NICU. So that also works in our favor. And our nurses are very, 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 very gentle with the mother. They welcome the mother and they ensure that the mother is treated in a manner that her oxytocin reflex is not affected. She is motivated to express milk, and that's how we ensure
Sushma,
that the baby is.
I think we need to leave something for discussions also.
Okay. So that's where I was actually going to finish. So we have a good mental tuning. When you stopped me, I was already going to stop. Thank you.
Thank you, Sushma. Old tuning. So many, कितने साल से जान पहचान है? अभी कहाँ जाने वाला? Okay. So Kishore, the ball is in your court. The corporate man, the chief of the corporate world, and so many things have been told. And many of the initiatives you have done, because I just had a granddaughter in one of your hospitals. So I have first-hand information of what all you're doing. So go ahead, Kishore, all yours.
Congratulations, Divakar, for being a grandfather. And thank you, Divakar and Manoj and NNF Kerala for having invited me here. And Dr. Kamath just mentioned that India is a huge country. We have a variety of states, and that's why, in fact, I confirm that Karnataka is one part of the huge country called India. But Bangalore is a very cosmopolitan city, and Cloud9 caters mainly for upper middle class families. And Indira Gandhi Institute of Child Health, where I go once a week, caters mainly for lower class or financial, I'm talking about not the class system, and BPL families. So I do see two different classes of population here. But I'm going to be talking mainly about Cloud9 statistics, but I'm happy to pitch in with the Indira Gandhi statistics for comparison whenever is required. At Cloud9, we cater for everyone with antenatal classes. Breastfeeding is one session covered very well during that. Postnatally, all mothers are seen by a lactation consultant and breastfeeding classes are conducted. Counseling is given every day in the postnatal ward. Follow-up is arranged with the lactation consultants for who we need help. All babies are put to breast within 30 minutes of birth, irrespective of whether they are born by normal delivery or by C-section. And Bangalore, as I said, is a cosmopolitan city. And we see people from different states, from different preferences. And most of them try to secretly feed the baby despite education and antenatal classes. Example, many Bihari families prefer to feed donkey's milk in the first 2 days. Bengalis give honey. Western Indian people prefer to give buffalo milk. Most South Indians prefer to give cow's milk. But these are all routinely, rigorously discouraged and explained that they cannot be doing this. 90 to 95% of our mothers are exclusively breastfed. And recently we published our data, and we also got the feedback from most mothers that the lactation consultant helped them to a great extent. And that was their positive feedback they've had in most of the feedbacks. We have nearly 5 to 10% of mothers using formula feeds by 6 weeks of age on occasions, and sometimes even at birth. In most Cloud9 hospitals, we do use bottle feeds to help feed the babies. Some indications like babies less than 1.8 kgs and not in the NICU, babies whose weight loss is more than 6% within 36 hours and so on. If babies are admitted for phototherapy and they are in the exchange level or near exchange level, we do use the triple phototherapy with the nasogastric tube feeds on continuous. And we haven't done exchange transfusion since we introduced this policy for over 8 years. So we do use nasogastric tube feeds on those occasions with the formula or donor breast milk, whichever the parents choose to. Donor breast milk is offered to all the babies in the NICU or any baby who is not getting enough breast milk for whatever reason. Choice is left to the parents after appropriate counseling. So we do have a rigorous system where we encourage the breast milk, but I must admit that it is definitely not possible for 100% of the mothers to breastfeed. And those who say that 100% of the mothers will be able to successfully breastfeed means that they have not worked in maternity ward or they have not seen a variety. So clearly we have 95 to 96% of mothers successfully breastfeeding, and we do have one of the highest success rates of breastfeeding. The problem initially we had was getting enough lactation consultants. Becoming a lactation consultant should be easy, but it's not easy in India and it's very expensive. So we actually started a program in Cloud9 by offering a certification course to the nurses and using them as lactation consultants for our internal purposes, not for accreditation. And that has made a huge difference. So with that thought, back to you, Divakar.
Thanks, Kishore. I didn't have to clock you at all. I mean, as usual, you're right on the dot. And I think Professor Nair, PMC Nair, sir, with so many years everywhere. I think SAT Hospital and Gokulam and KIMS, and we are just awaiting to hear your experience with it before we open up the session for discussions.
Okay, shall I the screen?
Oh, yeah, sure, go ahead. But please remember the timings.
Okay, starts now. Okay.
Yes.
Thank you, Diwakar. Okay, and the NFHS survey shows that 55% of babies only are exclusively breastfed till 6 months of age. So let us see what are the impediments to exclusive breastfeeding from purely neonatologist point of view. I'll say 10 points. Number one, breastfeeding is not easy. Problems in latching, positioning, sore nipple, especially the first 3 days for a primary mother, and the relatives forcing her to give formula milk. Second important point is colostrum. We all call it as liquid gold, but how many of us know that only 30 ml is produced on the first day? Even educated people, including doctors, have come and complain to me that this my wife is not having a single drop of milk, and they switch over to formula. First 3 days are crucial time for establishing breastfeeding, reiterated by Professor Hartman. And lactation assistance, especially the first 3 days, is very important. It was earlier easy with the joint family, but now we need a lactation counselor. And the latch score is beautiful. It should be pasted in the postnatal ward, in the OPD, in Taluk hospital, district hospitals, government hospitals. It is very good to avoid lactation failure. Then another important point I would suggest is more prolactin is secreted at night, so should not omit night feeds. Usually say, this girl is so tired, let her sleep, should not be there. Then I think breast pumps should be made available, especially in the first few days, primary, sore nipples, working mothers. It is so useful. And we should also know there is a substance called feedback inhibitor of lactation. If the baby sucks or the milk is pumped out, then only more milk is produced. So it's very important that milk production supply should go on. And the battery operator, the electric breast pump, I found it very useful. Those a bit costly. KMC, of course, for stable babies less than 1.8 kg. And Mada also mentioned about inverted flat or retracted nipples. We see a number of cases nowadays. It's more increasing. I don't know why. We use the double syringe technique for inverted nipples. Similarly, cracked nipples or sore nipples, the commonest cause is incorrect positioning. See, nipple sucking, very typical. So unless you teach the mother or somebody helps the mother to properly position the baby, it's not going to be a success. Then, of course, these are some of the devices can help. And the 8th point is baby crying too much, not enough milk. That is a common complaint mother comes to the OPD with. If there is adequate weight gain, 20 to 30 grams per day, I will not be worried. Then the other important thing is the 4 milk syndrome. The mother feeds on the breast, and then the baby feeds on the mother's breast, and then goes to sleep very soon. So this should not happen. The mother should be able to feed on the one side for at least 10 minutes before shifting to the opposite breast, because the hind milk contains fat, which is important for satiation, weight gain, and to prevent constipation. Then for working mothers, I think they should all use the breast pump and the EBM stored in liners in the refrigerator, and government fees can be given. And workplace, if you have a daycare nursery, that will be ideal. Exclusive clean feeding rooms in public places, and the BFHA can work towards that. This I saw in Guruvayur temple. They have kept a feeding room that is very encouraging. So the important points I would like to strengthen in our approach to improving breastfeeding is: one is antenatal training of pregnant women should be strengthened. Lakshya, that is the new labor room quality improvement initiative, is wonderful, very good, but I don't know how far it will be successful. Then baby should be roomed in with mother as early as possible. Mother's absolute affection program. There should be undiluted focus on breastfeeding promotion. We hardly see any activities going on here. Training of Anganwadi and ASHA workers, mainly the basics. They are the people who should go into the community and improve. And revamping of BFHI. We did a lot of work in the first BFHI phase with Dr. Elsie Philip and Kurian Thomas, but then we didn't go into the community. So that is the second part is very important. Thank you, Divagar. Thank you very much for the.
Thank you, sir. As usual, on the dot, on the dot, on the dot. Thank you so much.
Thank you.
Now we have so many answers and questions, and we have people like Dr. Sachi. I hope he's around still, in which we'll need his help. And before we going, let's come down to the brass tacks. So many questions were asked about feeding establishment, and I think the best person to go for the next session would be Professor Namita Subramaniam. Namita, go ahead. Your obstetric experience is unbelievable, and I see you always in the labor room and the obstetric wards. Though you are a professor, you should have been in an air-conditioned office sitting there. But thank you. Go ahead, and we need all your feedback. You want to share your slides? You're welcome to. No, unmute yourself.
Please unmute.
Please unmute. Namita, unmute yours.
Am I audible, sir?
Yeah. Okay, go ahead. Clean.
Okay, sir, good morning. Good morning, everyone. Many doctors here, they all acknowledge that nurses can contribute much to support breastfeeding. Yes, definitely, because of the nature of work and their constant presence with the women during the labor, during the antenatal period, and during the postpartum period, and the vital roles they handle in the clinical settings, they can do much to support breastfeeding. And it is a common assumption that if nurses are equipped with knowledge on exclusive breastfeeding and baby-friendly hospital initiatives, we can improve breastfeeding, or we can support breastfeeding. To some extent, it may be true, but I would like to point out a study here that was conducted in a tertiary care hospital in central Kerala.
Are you sharing your slide by any chance, Namita?
Yes, sir. One second.
No, we are not seeing it. So please share screen.
Okay.
At the bottom, you will find something written green share screen.
1 second, sir.
Go to share screen.
Go to share screen and tap it. Yeah.
Yeah, it's coming.
Okay.
It's coming. It's coming. It's coming. Hold on.
Okay, sir. Even though we believe that if we equip nurses with the knowledge, we can improve the breastfeeding support initiatives. But the study in a tertiary care hospital states that if it was conducted among 30 nurses who were working in obstetric and pediatric care units in a tertiary care hospital, around 80% of them had satisfactory knowledge regarding breastfeeding initiatives and BFHA guidelines, but the optimum practice adherence was only demonstrated by 49% of subjects. So it is a false notion. I should say that it's a false notion that if you equip nurses with knowledge, everything will be fine. So there are some other factors that that hinder effective breastfeeding promotion initiatives. So we'll see what are the gaps, what I observed in the clinical setting. Usually nowadays it is an era of social media. So we health professionals has a false notion or a misunderstanding that social media can provide all the necessary information for the clients. So we are a bit passive, I think. So we believe that it is there in the internet, it is available in YouTube. So they can refer to internet or YouTube and they can learn things. It's not like that. Whenever it is provided, whenever the information is provided primarily by as a first-hand information by a healthcare provider, that cannot be replaced by any other media. That is one thing. And another problem that impedes or interfere with the effective breastfeeding promotion is lack of coordinated antenatal counseling and breastfeeding counseling services. In most of the hospital, I believe in our state or in our locality, there is no coordinated breastfeeding counseling services available. And there is no specific persons who are responsible and accountable to provide breastfeeding counseling services. And during the antenatal period, no activities or no initiatives are taken to correct the nipple abnormalities. That is a great problem that is observed in clinical practice. And another thing, what I observed, it's a qualitative observation from my side, that is women using tight, inappropriate sized breast support braziers, for example, padded braziers, that ultimately results in flat nipples. Prolonged use of padded braziers can result in flat nipples. It's a qualitative observation. I don't know whether it has to be studied scientifically. So, and another aspect is improper management of immediate postnatal period. So, the first and foremost thing, there is lack of open communication between the women and healthcare providers. Even though we give some information, they are most of the time, no, I'm not blaming anybody. I'm not blaming obstetricians. I'm not blaming neonatologists. I'm not blaming nurses or whoever is handling or breastfeeding consultants. We are giving vague or incomplete instructions, believing or assuming that they know things. Actually, they don't know anything regarding breastfeeding. So we are giving, for example, we are informing them, you have to take adequate fluids. You have to take nutritious diet. What they have to take or how much amount of fluid they have to take during a day. That is not specific. We are giving incomplete instruction to them. And another important aspect that we have to acknowledge, improper comments and advices from family members. So we all have discussed and everybody has acknowledged the importance of emotions on breastfeeding, effectiveness of breastfeeding. So when everybody is advising and criticizing the mother's performance on breastfeeding, that itself will influence her competency and her confidence in breastfeeding. And that itself may create stress for the mother, and that negatively influence the production of milk and her lactating ability. And another aspect is stress creating environment. Even in the hospital, it can be in the hospital, if it is in a general ward, no privacy and no support person and no comfort devices like pillow, chair, etc. In many hospitals, as you all know, in general wards, we are not providing much support devices. Additional pillows cannot be provided because of the scarcity, or it may
Yes,
not
Namita,
have a back supported
you will
chair.
have to speed up.
Yes. Okay. Okay. So what we can do is it's a teamwork. We have to consider it as a teamwork, and we have to set up a team in every unit to identify and handle breastfeeding issues and make sure that this team should have voluntary willingness to be the part of the team. And I believe that there should be a standard operating protocol for breastfeeding counseling. And another idea what I can contribute is a nurse-led clinic that should be integrated with antenatal and postnatal counseling services, where breastfeeding counseling, nipple correction measures, breast care advices, practical remedies, and appropriate referral, everything, these measures can be done by a nurse. And convince the relatives on breastfeeding issues, because if you convince the mothers, if you are not convincing the family members, it is in vain, I think. And frequent assurance of mothers about her competency is another aspect we have to think about, and ensure availability of additional pillows, footrest, and such comfort devices, and discourage routine prescription of formula feed from for every neonate. That is observed in some hospitals. I have personally observed these practices in some hospitals. And breastfeeding counseling, a patient satisfaction survey at every discharge may give some clues about their needs and their concerns about breastfeeding counseling services. So thank you, sir. These are the points.
Thank you, Namrata. You can stop sharing your screen. I think we can go straight off to a lot of queries that have come up. Unfortunately, we are not. We don't have anything in the Q&A, but we have the doyen of breastfeeding initiative in India, Professor Armida Fernandez, who joined us. All salutes and welcome to you, ma'am. It is indeed an honor to have you with us. And I think the entire team of Kerala is so proud to have you join us in this session. And please feel free to comment whenever you feel like, and comment. And I can assure you that I won't time you. So,
my pleasure. Thank you.
I think we'll just quickly run through some of the queries that have come or which arose, starting with Professor Lalitambika. You had told about looking for the nipple status by around 36 weeks. I got a bit concerned about it. Is it you go to the last trimester, or we used to be told that it should be done in the second trimester or something?
So the main problem is many patients come to us, especially in the medical college, we get referred cases. We see them only in the last trimester. So before 36 weeks, we don't start correcting because nipple stimulation can lead to preterm labor. So if we see them in late trimester for the first time, then we will start correction only after 36 weeks. If we, in the first antenatal visit, if we are lucky to see them early, we will examine the breast in the first antenatal visit itself, and we can ask them to try correction.
Okay.
The third trimester, we don't do it before 36.
Please raise your hand and go ahead, sir. So we know the other.
Can I also add to this? What she said is very true, because I always tell my juniors that if you stimulate the breast before that, this oxytocin release will cause oxytocin. Hello, can you hear?
Yes.
Oxytocin release will cause preterm contraction. So that is why it should be started only around third trimester, preferably around 36 weeks.
Okay. So that is clarified out, because this was a query which was always asked to us. And I was very impressed by what Sushma was telling, the fundamental thing about communications. And I think everybody is commenting about communications, including the last score, which has come from Professor Nayar's presentation, and the amount of communications that has been Cloud9. So is this communications, in your opinion, restricted only for conferences, or is it actually being practiced in hospitals? The floor is open. Any one of you can take off. And let's be honest about it.
Yeah. So, I mean, it should ideally be that it should be done in the hospitals in whichever places it's required. You are very right in saying that in conferences, we have great deliberations on breastfeeding and issues related to it. But Divakar, when I open up a workshop saying that this will be where we'll talk about breastfeeding and related issues, believe me, there are hardly any postgraduates who want to register. So they will all scuttle away. And if I open a workshop saying that we are talking about mechanical ventilation and high frequency ventilation, they'll be like, ma'am, I also want to join. I also want to join.
You call these postgraduates back after 3 months after they've gone into practice. They'll come running. The problem
let me try that.
After 3 months into practice, they'll come running. Maybe before that it's not dynamic enough. And this is where, using Sushma's lines, I wish Dr. Sachi is somewhere around here, because we need to track him. See, she has told about breastfeeding corners and facilities for childcare in large institutions. Now that has to be governmentally made mandatory. Otherwise, it will not work, because even this exclusive breastfeeding up to 6 months. I was recently clearing up my cupboard. I found the IAP conference which we held in 1983 in Trivandrum, 82 or 83 in Trivandrum, I think. Those brochures came to me. We are talking about exclusive breastfeeding even there, and we are talking about that even now. So there is something missing. So this thing about 6 months breastfeeding, is it a practical solution? One. Two, if the patients would like to breastfeed, are we providing enough facilities for them within institutions that employ more than at least certain percentage of lady employees? You put any cutoff. You say, okay, more than 30% lady employees, fair enough. Put more than 20% lady employees, fair enough. I can assure you all hospitals will definitely have much more lady employees. You must have some facility. Now that should be a governmental order. Otherwise, I finally find it very difficult to push, especially when the rules and regulations are there. So would you be able to comment on that? Is it possible to push?
Yeah, very pertinent point, Dr. Divakar. We have been trying, you know that we all know scientific part, I am not coming into that. Exclusive breastfeeding is exclusive breastfeeding itself. There is no doubt scientific part and the academic side, I am not looking into that. But the logistics which is going to work out, that is where we have been pushing. At least we could make that 6 months leave, then crush, then move on to the all corners. Now we are moving to the bus stands. Every other places we are planning to keep at least a breastfeeding room. That somehow in at least that breastfeeding week celebration, not in this year, till last year, every time there is a August 1st to 7th, there will be every district will have some of the centers, where public places and other areas, a breastfeeding room, which is maintained or not.
Sorry, Sachi, my contention is that we need established places to take care of these babies, so the mother can bring those babies here, like crushes.
Crush, that's what I am coming to. Yeah, crush. Crush is a different thing. We have to move around, move with the government. At present, it is not at all functioning.
That is why you have been called. You are the only person who I found has made even a sleeping government rush to bring the infant mortality rate to this small level is not a joke. So
we will definitely push that. It's the whole thing that is the basis. We should promote that crush at least for where there are delivery. We should put something like a cutoff point when there are number of lady or the women workers in that institution or wherever the working place. You should have minimum this one, and they should be given. These are the one of the criteria to recognize that institution or wherever, healthcare or the other sector.
Just to comment to Sushma, sitting in Delhi, is it possible for you to push it now?
It's being tried, but it doesn't come easily, because this is not something where people are affected. If you go something for cardiology or for something for orthopedics, the people sitting there in power corridors have those problems, and they will push that. So but this is not being done.
I have a standard argument for this. I say the newborn baby pays the taxes to the government for the longest period of its life, from birth up to next how many years. So he's a perpetual taxpayer. Whereas anybody who's 70 years like my age, I go for a bypass, maybe another 20 years I'll be able to pay taxes. Newborn, you take care.
Dr. Armida
Dr. Divakar.
Madam is there. Madam wants to comment. Dr. Armida is.
Yeah.
Yes, madam.
I just want to say that at least in Maharashtra, they have a regulation in the government that if you have more than 30% women, that they should have a creche. And this has been there for the last 20, 30 years. I don't know if it's a national thing, but you need to find out if there is a regulation.
No,
but
madam.
all of them don't follow.
Now Sachi and Sushma are there. Now we will make it national. See,
the second thing I want to tell you is that the creche is difficult because can you imagine working mothers, carrying their baby in crowded trains, and they don't have cars, they don't have their own vehicles. How will they carry their baby to work? So it is easy to say, but difficult to carry your baby to the creche.
Yes, madam. This comment I wanted to come from you because my issue is not where the mother who's carrying by bus, because she can actually be at home. She's getting 6 months off. The person is our Dr. Kishore's type of people who come from the corporate to deliver, and there is no great leave for them. Kishore, your comments on that?
Yeah. Divakar, that's a good thought. See, 90% of our staff are women. We don't
Not
have...
your staff. I'm talking about patients who come to deliver in Cloud9.
Correct. We did try the creche aspect initially. I mean, we are infants in compared to a lot of other corporate hospitals. Cloud9 is only 15 years, but we did try creche in the initial stages. It was not very successful because people generally didn't use the creche in the hospital. They prefer to have a nanny at home or grandparents at home looking.
Sorry, Kishore, you didn't get my point. I'm not talking about your hospital. I'm talking of, say, a TCS employee is coming to your place to deliver. Can we as a group say TCS in this office should have a creche? Because you can't tell the mother you come home or you work from home. That's policy there for some companies. Some companies actually ask the mothers to come home. You get 2 months.
Yeah.
And at that juncture, I also felt with this nuclear family that was commented upon by Sushma, whether you should request for paternity leave if they're nuclear family for breastfeeding purposes, because after all, only 2 of them are there.
Yeah. That point, I think, see, we started the certification course and approving as a breast-friendly companies in Bangalore. Certainly, a lot of multinationals like IBM, Infosys, Wipro, they all have creche in their within their campuses, and they do provide the services.
Okay, thank you. I think we should give it more publicity. Yes, go ahead, Sushma, for a minute. Go ahead.
Yeah. So one was regarding these creches. These places are not maintained well. We had one in our institution which had to be closed down because people were not using it, because there was nobody who was maintaining it clean enough for somebody to get their baby there. The second thing that I wanted to say was, rather than making a creche and letting people get their babies, even if we provide a clean room, not a washroom, a clean room for the mother to express her milk and take it back, she can store it and take it back, that also would be a good enough service. Your comment about taxpayer, that was what I used as my argument to get surfactant in the hospital, because they would say it's very expensive. No, we cannot get it. I said, these are if we give them life, they will stay for 60 years. So please get us surfactant. And finally, we could manage to get surfactant in a government hospital. And now it is there in free supply.
Thank you. I think, Namita, you were talking about pillows and rests and how they can be told, how can be taken care of. I want to ask you honestly, how many of the nurses themselves are comfortable breastfeeding?
Sir, actually, if I talk about nurses who are familiar to me, they are getting 6 months maternity leave after childbirth. But when they come back to the hospital setting, they find it very difficult to manage breastfeeding. So many are complaining of engorgement, and many express breast milk and they just throw it into the wash basin, and these things happens. Even though we know things, we can store it, we can preserve the expressed breast milk.
So there is definitely a slip between the cup and the lip, and we need to work on that content, because what is missing is something we all have to have a think and how it can be done. Just a couple of questions and we'll wind up. I see Mother Manoj squirming there. One is about the social media, which was very well raised by you. And that is something which we have to understand, because with the WhatsApp University going around, it's unbelievable what all comes out. So which is probably you tell something and advice is given, somebody else will come out with another message, which has to go ahead. Before I try to wind up here, I have just a very significant thing in which I need to know Dr. Kishore's and everybody's opinion. Dr. Nair very specifically told that there is a very good role for breast pumps. There's no doubt about that part. Kishore says they use breast pumps. I say many people use breast pumps. I just want you to see, can the cost of breast pumps be rationalized? If we can rationalize the cost of stents in this country, a cardiovascular stent is being rationalized in this country. I know a certain pump which a few years back, about 8 or 10 years back, used to be sold for about less than 600 rupees, is costing more than 3,000 rupees today. There's no great change in mechanism. So isn't it time that we, Kishore, how much would you be paying for a breast pump and how much is that's available in the market with different things? And do you think this can be rationalized and brought down? Because obviously the popularity of breast pump has increased. In the past, it used to be that nobody used to use it. Now numbers have increased. This is the only place where I found when the popularity of an equipment is increasing, the cost is simultaneously going up instead of coming down.
Well, I'm glad you raised Divakar, because see, a lot of luminaries are there, and in fact, I'm glad Sachinanand and Ramesh Kumar are here. IAP policy towards breast pumps should be changed, because breast pumps is considered as something else, and they don't support. The cost of breast pumps can be anywhere from 2,000 rupees to 60,000 rupees. And if you look at what is there, it doesn't warrant that cost. Clearly, it's not being given priority because it's manufactured elsewhere and brought here, and taxes and everything adds up to the cost. So even if it is made tax-free, the cost will come hugely down. And the only way that can happen is if IAP and NNF lobby together and make it a tax-free and an essential equipment, just like ventilators. Ventilators are tax-free because it's considered life-saving equipment. So breast pumps should be made similar to that, and it can become cheaper.
This is something I personally feel we should work on it. I have 2 or 3 questions that have come here. I'll read them out together. Anybody can answer. One is LSCS gynecologist resistance start early breastfeeding? I don't know. I don't think so, because nowadays with epidural going on, people can be fed very early. Am I right, Dr. Lalitha? Because I don't think LSCS...
Even without epidural, we never resist. We ask them to feed the baby as soon as the mother is in the recovery room itself, we start feeding.
Fair enough. So
baby is kept prone on mother's chest. Mother cannot turn around. She cannot sit up. So baby is put prone on mother's chest and we start feeding.
I think that's a very, very self-explanatory topic. Then other thing is some very senior person has put up a question. How does one counsel when other neonatologists have started formula? Now, there is something which none of us can do. There's no answer to it. Because everyone was blaming, but everybody gives formula. So these are very, very dicey discussions. But only thing is, if somebody finds something successful, automatically the facility for that will go away. So breastfeeding initiative has to be done. There are so many queries that I have managed to write down, but I'm sure we've got positive time. I'll give 10 seconds each to the participants to go ahead and give your winding up comments.
Can I just start? I just want a question actually. Will exclusive breastfeeding, will it increase or decrease with the milk banking to Professor Armida Fernandez? Because I don't have much experience.
I think we should encourage lactation consultant course for the nurses. It needs to be made simpler, and we need to encourage the nurses to become warriors of breastfeeding. And the only way you can do that is giving a certification that they're lactation consultants, which will boost their confidence and improve breastfeeding rates.
Yes, Sushma.
Professor Nair, very good to see you here. Sir, I run a milk bank since 2017, last 3.5 years now. And I have ensured that in my NICU, the PDHM, the donor milk usage is between 5 to 10% only, that too in the initial 72 hours. So our nurses ensure that the mother must have full EBM by 72 hours. That's our outer limit. The sooner they have, the more patted the mothers are, the more the nurse gets patted on her back, our NICU nurse. So with the milk bank, we have ensured that it is not donor milk which is taking over formula. It is actually the mother's own milk which is taking over. And before winding up, Divakar, I would just like to say government has mandated 15 days paternity leave for the fathers in government setup, but it does not get translated into any other setup, whether it is corporate or it is unorganized sector, but there is 6 months for the mother, 15 days for the father.
Okay, so the mother has to be supported for 15 days to ensure breastfeeding. That guy has got the job up, including cooking, including taking care of the house. Good, I think good training for guys, very good. Now, who's our, yes, now go ahead, Namita. And then last comments with Professor Armida. Yes, Namita, you got any winding up comments to make?
Sir, actually, I feel that there should be a collaborative approach from neonatologists, obstetrician, and from the nurses. And if the antenatal care services along with the, if it is integrated with the breastfeeding counseling services.
Namita, you are running an obstetric service when you have classes for mothers regularly.
Yes.
So during
Sir,
the classes, are you taking regular breastfeeding classes for the mothers who come for antenatal visits?
Sir, actually, we have two types of session. For, on the second Friday, we conduct for the antenatal care. Antenatal care session is conducted on the first, second Friday, and on the fourth Friday, we are talking about the labor management and breastfeeding. So, preparation for labor and breastfeeding is detailed in the second session, where the mother will be demonstrated how to hold the baby and how she has to.
Thank you, Namita, because this is the session which she had started. That is why I wanted her to come. This is a regular program going on in our hospital, and she conducts the whole show. It's a regular session on 2 Fridays of the month for all mothers who are there who are antenatal, and they are told about this. Madam, over to you, Madam. Armida, Madam.
I just want to say it's wonderful to listen to all the seniors talking on breastfeeding. They're really a pleasure. I think the most important thing is to prime the mother in the antenatal period on the importance of breastfeeding and the things that she will go through. So this is in Sion Hospital, we had it in the obstetric antenatal, gynec antenatal clinic, where every day they were showed a film and there was a social worker talking about the problem. So that is the important. The second is the role, you're putting everything on the nurses. The doctor, the pediatrician, the neonatologist, they are the biggest culprits. I'm a doctor myself, but I want to say it is ancillary. They don't have time for breastfeeding. What they want is they want intensive care where whatever the reason, but they don't stop and they don't encourage. And when neonatologists say, we just started one bottle, a little bit of formula, the important thing is, have you tried breastfeeding? They separate the smallest thing, they separate the mother from the baby, keep in the NICU, keep in this specialized unit. When you separate, stop separating the mother and baby unless absolutely necessary. If separated, get the mother there to express the milk. Try and get every mother, if supported, if encouraged, every mother can get breast milk. And that is not the nurse to tell. Who will the patient listen to? Will the patient listen to the nurse? They will listen to the obstetrician who has been looking after. They will listen to the neonatologist. So I think they should undergo the lactation management course first. Then you teach your nurses, because if you don't encourage them, they will not tell us. So you be the force, then the nurses join in because they spend time with it. They play a very important role, but it is ancillary. The patients listen to the doctors first. I think that is the important thing. And these cracked nipples, engorged breasts, in Sion Hospital, after we had lactation management nurses without degrees or things, just helping mothers, we didn't have cracked nipples, we didn't have engorged breasts. So if you have mothers being seen by nurses and no degrees, labels or anything, we don't want to make it another specialization, refer, and someone else earns. It should be part of everybody's practice.
Thank you, Madam. As usual, your comments are always a cherry on top of the dressing. And with all, thanks to all the panelists. I'm sorry the session could have gone longer and longer, but then Manoj would have stopped calling me to moderate any other session. So thanks once again to all my colleagues, my friends, my seniors who have been here, Professor Submaran, who has been my teacher right from Kotte Medical College. Nice to see everybody here. Thank you very much. Thank you for a very live time. And over to you, Manoj. I think this is all that we can do for you now this time. Thank you.
Thank you. Thank you.
Thank you, Sushama,
Thank you, sir.
Kishore, Somasek.
Challenges there, finding a way out is a problem. One of the biggest challenges we face when we go for exclusive breastfeeding, as was discussed, is in the case of preemies, high-risk infants, and mothers with lactation failure. What do? We don't have a breast milk bank in Kerala. We have been saying this for the last so many years. So in 2019 January, when we planned our NNF Kerala action plan, we decided that we can't keep saying this and doing nothing about it. So we went on a planned strategy with ample help from our like-minded friends, from obstetrics, and finally, as a saver of the day, Rotary International came to your rescue in June 2019, and rest is history. Friends, we are about to inaugurate the first two breast milk banks in our state. One in private sector at Jubilee Mission Medical College, Thrissur, my place, and one in government sector at District General Hospital, Ernakulam. But having the banks alone is not good enough. It should benefit all the babies, not only in that hospital, all the babies in our state. For that, we need a planned strategy. The banks are going to be, the breast milk banks are ready, going to be inaugurated anytime. The dignitaries are ready, and because the Rotary wants to have it inaugurated in a grand way, but everything is ready. But we are not stopping with the inauguration of breast milk bank. We need something more. We need to, have more and more babies benefiting. So today, NNF Kerala is happy to inaugurate the breast milk banking activities in our state today, of course, with our most valuable partner, IAP Kerala, KFOG, and all because of the financial support by Rotary International. To inaugurate our breast milk banking activities, we have a very special person whom we have just now heard, Professor Armida Fernandez, the mother of breast milk banking in our country. Welcome, madam. In fact, all of us know that she is credited with being instrumental in setting up the first breast milk bank in our country. To chair this inaugural session of breast milk banking activities, may I welcome Professor T.U. Sukumaran, past National President of IAP and State President of NNF Kerala, and also our dear present President of IAP Kerala, Dr. T.U. Narayan, M. Narayanan. So over to you, Divakar sir. Over to you, Sukumaran sir.
Okay. Dear friends, am I audible?
You are.
Manoj?
You are.
Am I audible? Okay. Okay. Beloved friend Dr. Manoj, the Dean of breast milk banking and the mother of breast milk banking in India, with the beloved Professor Armida Fernandez, Madam, Dr. Narayanan, other dignitaries on the dais, of the dais, and my dear friends of IAP and NNF. It gives me great pleasure and privilege to be here with you to chair this most important session on breast milk banking. And I should congratulate the NNF Pathanamthitta, IAP Pathanamthitta, IAP Kerala, and NNF Kerala, especially Dr. Manoj, for organizing this wonderful CMB program here. And again, hearty congratulations to Manoj and others for starting two breast milk banks, one in the government sector at District Hospital Ernakulam, and second at Jubilee Mission Medical College, Thrissur, for starting this with the help of Rotary Club. Hearty congratulations to Manoj and his team. And as you all know, breast milk bank is going to revolutionize the management of feeding practices in preterm and low birth weight babies. When the biological mother is not available, the milk of choice may be again a donor milk rather than infant milk formula. And as you all know, in Kerala, the number of NICUs are more, it is increasing day by day, but there is no facilities for breast milk banking in Kerala at present. It will be implemented soon. Dr. Divakar was just mentioning about the WhatsApp University. You must have read a news in the WhatsApp that a lady in Bombay has donated 40 liters of breast milk during the last COVID lockdown period. So the awareness among the public is also increasing about breast milk banking. As you all know, the guidelines for breast milk banking was put forward as early as 1985 by the American Blood Bank Institute, way back in 1985. And as you all know, the first breast milk bank was in Asia was started in Bombay by a madam in probably in November 27, 1989, maybe the probable date. And IAP has taken a leading role even in breast milk banking also. And IAP has proposed the guidelines for implementation of breast milk banking in June 30, 2030. It is published in the June 30, 2030 Indian Pediatrics. The guidelines are published by IYCF India. And you'll be coming with more blood bank systems in Kerala also. With these words, I have great privilege to introduce the Professor Armida Fernandes to you. He is the founder chairperson of the Society for Nutrition, Education, Health Action, SNEHA, for the welfare of health workers and those women who is working in urban slums who are undergoing violence also. This association is called SNEHA. Madam is the chairperson of this SNEHA. He is the professor and HOD of pediatrics, Lokamanya Tilak Municipal General Hospital and Medical College, Mumbai, for more than 25 years. And he has retired as the Dean of the Medical College. Later, she has worked as a medical director in Holy Family Hospital, Mumbai. Madam was the past president of National NNF, and her main industry is in breastfeeding and breast milk banking. And he has done a number of research work and also a number of cost-effective techniques for improving childhood morbidity and mortality in babies. And his main industries in SNEHA. With great pleasure and privilege, I introduce the doyen of breastfeeding, the mother of breast milk banking in India, Professor Armida Fernandes, to you. And I request Madam to start his talk on human breast milk banking. Madam, please.
Thank you so much for the introduction. Thank you for inviting me, Manoj, and for the whole group, NNF and IAP. I think it is wonderful that you all are finally starting a human milk bank in Kerala. Actually, Kerala is a different state in the country. You all should have been the first. And you know, I'm surprised that they haven't started. But I know once you start, probably in the next few years, every hospital in Kerala would have a human milk bank. So let me start with my talk.
Madam, please share the screen.
I'm trying to share. It's not sharing for some reason.
There's a button lower down, green button.
It's not green.
Share screen, green button is there. Lower down, bottom.
I'm looking at that, but it is. It's not showing in green. I don't know why it's not coming in green. Is there any reason?
Please,
is it basic?
No, madam. Yesterday we did not have it.
Okay, that's what. Okay, there it is. Fine. Finally, thank you. I start with the last slide, is it?
Last slide. The last slide.
That's the trouble with sorry. You know what happens as you grow older, you are learning new things, which is difficult. You're seeing all my slides to start with. Okay, this is the Human Milk Bank, actually the same board that we started in on the 27th of November, it will be 31 years that we started the first Human Milk Bank. So it was long, long ago that we started a Human Milk Bank. And obviously, there were a lot of challenges, and some of the challenges persist even today. I was asked to talk about challenges and way forward. But you know, in between in the last 31 years, there have been a lot of successes in human milk banking. And I said I must mention some of them to say that things change. Even if it takes decades, things change. So we'll talk of challenges, successes, and finally the way forward. I must start with, this is Lokmanya Tilak Hospital, Sion Hospital, where I spent over 3 decades of my life. It is a large hospital. It has over a large number of beds, and it is famous because it's next to the largest slum of Asia, Dharavi. And I always say the dying and the desperate patients all flock to Sion Hospital. So we have a large number of very ill, very poor patients coming here. And because of that, we have a large number of deliveries, up to 10, 15,000 of mothers delivered in our hospital. And about 1,000 babies came for preterm neonatal care were transferred into our hospital. We're dealing with large number. I showed this slide to say that we had patients on beds, between beds, under the beds. The only innovation we didn't find out is how to stick patients to our ceilings, but maybe the next few years we will. And what we did was, and in the 80s, we were trying to make sure that, we would exclusively breastfeed our babies. And why was that? There was a reason. Reason was the mortality rates were extremely high in preterm and sick babies, but also that many normal babies developed diarrhea. And then we said diarrhea, sepsis. I said the cause must be in our lactation management. And therefore we stopped pre-lacteal feeds, we stopped bottles, we started babies on exclusive breastfeeds. But how to ensure that you'd always get human milk for babies, a continuous supply, and how to ensure, first we used to give one mother's milk to another, and that was really not safe. And therefore we had to ensure a safe human milk, and that's why in 1989, we started a human milk bank. So what were the challenges? And I can tell you there were plenty of challenges. First, the concept of a human milk bank. People used to say, milk from one mother to another baby, the thought of it only, it was, such a scandal. Even amongst some doctors, leave aside lay people, we had to convince them. Actually, we had to tell them stories of Lord Krishna also. He was also a wet nurse by his mother. So, and then we had to say that this can, so convincing them about another baby receiving was very difficult. Second is banking of human milk. That thought itself was unheard of. So it took a lot of time. So that concept has changed today, and you're lucky. And this is what we were telling them. If you can give from one species to another, can't you give in the same species? Look at blood. Would you give cow's blood to a human being? So it took a lot of time in convincing, but it has happened. The second challenge was administrative support. Remember, Sion Hospital is a municipal hospital. And in a government municipal hospital, human milk bank, which hospital has, the first thing is, what are you thinking of? They thought something was wrong with my head, actually. No one else has it. What are you thinking about? So that government institution, it became a big problem. Second, departmental support. I'm saying it now here. My department, Dr. Tavli, were very supportive. He said, go ahead. But I know even now, if the head of neonatology wants to start and the head of pediatrics is the head, he or she may have objections. So you must get departmental support. It can be a problem. It has been, I've seen that. Administrative support, because it's not local administrative, not the dean, but administrative support at the MCGM, at the government to change them is tough. And this was the big challenge. Other challenge which you all also faced, like Manoj said, finances. Where do you get the money? You will spend millions on an intensive care unit, bring the latest of ventilators, look at our CAT labs, look at our neurology, you want robotic surgery, fine. If you say few lakhs for milk bank, everybody make a big noise. So for newborns and for milk banking, there's never money. So we had to go to donors. We are lucky the Taj Group gave us donation, and like you said, you all are getting you all got donors now. You didn't have the government, you didn't have your hospital to put it up. Second, as usual, space. You never have space in an institution. For other things you have, but not for a milk bank. And let me tell you what I did in my own department. I waited for vacation. When most of the people were on leave, I got the head of department permission, occupied a partly empty room, got the stuff out. And once, like in Bombay slums, once you create a milk bank, it's difficult to throw you out. So that's how I got the space. The third is staff, which I'll talk about. Equipment. You know, we had to get equipment, and remember, first time we were starting it. Today it is easier to get equipment, and there were no protocols existing for our country. So what were the challenge we had? How to modify a human milk bank to suit local needs? Donors. When the bank I saw in Oxford in UK, mothers, when they left the house, they said, not on alcohol, not smoking, not on drugs. A blood tests were done. She signed. She went home, collected the milk, put it in a freezer, and then it was either collected or brought. But what about our mothers? Where did they come? They came from the slums. In that one room, where will she collect the milk? There are no fridges at home. So we had to change the type of donors we would have. So we had to modify equipment, I'll talk about, and protocols. So what did we do? We were lucky to have thousands of mothers. So every mother who qualified became a donor. So all these mothers in the ward. Second is we made a rule, and therefore I think there must be collaboration. Every preterm and sick baby that was admitted in an ICU was admitted, the mother was admitted in the obstetric ward. That was kind of the obstetricians to allow this. Because remember, normal mothers, third day she goes home. You don't have enough milk to give. So the ones who are with their babies, then they become milk donors. Second is that we said that once the mothers go home, the milk increases. She comes back for follow-up. So with our Well Baby clinic, we also had a lactation management clinic. They came, they were checked for, fed properly, and then they were, milk was also collected. Modifications, the banks that we saw, Pyrex collection bowls, polypropylene. What would we have in India? Pyrex breaks, who will replace that Pyrex? So I thought, why not the dabbas that you have? They are wide mouth, they are easy to clean, easy to sterilize. So I said, why not use stainless steel dabbas? And that's what mothers can also have at home. So she is used to this. She can collect milk, so we use dabbas. Equipments, they talk of the cost of equipments. Manual collection takes too long, so we used hand pumps in those days. And then the equipment, remember in those days, it was to get equipment from outside is very difficult. So locally made pasteurizer was a problem. In UK, I saw a big pasteurizer, which was very expensive. So I wrote to the Human Milk Bank Association of North America. We are starting a milk bank, can you donate one? And they told me, madam, we don't have funds to run our own milk bank, and we don't have a pasteurizer. But there is scientific evidence that you can use a shaker water bath, and that's how we got a shaker water bath made in India. What are the protocols we use? There was a difference. When one mother collects the milk, she gives liters of milk. One lady in India gave, but here our mothers gave 20, 50, 100 cc's. So we couldn't do samples separately. So we had to collect all the milk, pool the milk in one container, and then we used to send for microbiological testing, and then we used to freeze it. So we had to change the protocols to suit our conditions. Of course, in those days, again, collaboration with the microbiology department, but we couldn't send lots. We used to do random collection. Today it is, of course, changed. And staff is the most important. Like you said, for lactation management, you need nurses. Our doctors were all for it, but we had these wonderful lactation management nurses who took rounds every day, who helped mothers to position their babies, latch their babies, and then if they had engorgement, express the milk. And like I said before, if you do good lactation management practices in the hospital, you don't have engorged breasts and fissures. So these are, and you need to have, so for all of y'all who are starting a human milk bank, please get the staff in place. Don't start it. Equipment is easy to buy. Staff is a recurring expense. You need a technician. You need lactation management nurses. Make sure that you have it. It's a huge challenge. Other challenge is scientific evidence. Why wasn't another milk bank started for 15 years? The second milk bank started in 2005 in KEM Hospital. You know, Dr. Ruchi Nanavati, Sandhya Katse, JJ, but they had to be convinced. But because there was not enough scientific evidence in those days. And second, legal issues. People thought there might be legal issues. We believed in trust. He said if we trust the mothers, maybe they will not make a noise. And government regulations. Do you know that for 3 or 4 consecutive years, a question was asked in Parliament about our human milk bank? Can you believe it? I don't know if it was the baby food company, but we had someone from the ministry, Dr. Malhotra, who came to visit our milk bank. And they said it's a question. Actually, when he came and saw what we were doing, he was most impressed. But the government was asking us why questions were being made. It was not the government, questions were being asked in Parliament about milk banking. So those were the challenges that we faced, some of them. What are the successes now? And I have to say that from that human milk bank, one in 1989, to second, after 15 years, the second. Now in the last decade, it has become a movement. There are milk banks opening practically once a month or once in 2 months. Individuals are starting human milk banks. Institutions are starting. But I want to give credit, and it was PATH, the PATH organization PATH, and Ruchika is the one who pushed human milk banks across the country. She was in Delhi, she was with the government, formed groups and pushed it. And donors, Manoj mentioned that the Rotary Club donated. The Rotary Club helped the KEM one, the JJ one, Rotary helped other human milk banks. So Rotary in a big way. So there are donors who are helping in milk banks. Second is that we have WHO endorsement of human milk banking. See, in 1992, finally, the WHO said that you can use donor milk, and that it is, if you get biological milk from the mother, the first alternative should be milk, human milk from other sources. So you had endorsement from the biggest people. The other successes are national guidelines. Today we have national guidelines for human milk banking, and they've started the Human Milk Bank Association of India. You have enough human milk banks, you start the association. And look at the guidelines, and they changed the name. Instead of calling it a human milk bank, they called it a comprehensive lactation management center, which is important. Human milk bank is not about banking alone. It is about lactation management to make sure that the hospital is first baby friendly, all the rules are being followed, and they also have banking. Other dimensions are ethical considerations. We never thought about it in those days. And quality control, which we did to some extent. So today there are ethical, you have to prescribe, like you prescribe drugs, you have to prescribe human milk. Even the baby has to receive it. You have to say which baby receives it. You have to take consent from the mothers. We never took consent, but you have to take consent, and there are forms to fill before you consent for human milk. And safety, today there are safety rules, donor screening. We always did donor screening. We are more empirical. Sterility of milk, how you collect it, how you store it, how you pasteurize it, testing is there. And this big word, which I hadn't heard of before, Hazard Analysis Critical Control Point, HACCP, that is looking at quality. Today, quality, you heard about quality of labor room. There is quality being pushed in everywhere. And really, if we have to have milk banks, we must ensure quality. And remember that the human milk bank that I started today, it is in the topmost quality, following all the guidelines. It's a zonal center, and they have laminar flow when they are mixing the milk. They have a safety cabinet. They follow all this. Now, the other thing that we successes is that, donors now are home based. Even in Bombay, we have mothers collecting, but not enough. It's not like blood donation. Some of them come forward and give milk. And private hospitals have started milk bank. In Bombay itself, many of my students actually have, started, neonatal units have started, big hospitals, private hospitals have started. So private hospitals have started milk bank. So what is the way forward? I think the way forward is taking it to scale. Every hospital in the country with a large NICU, if you want to ensure that every baby gets human milk, must have a comprehensive lactation management center. The current status is 70 and we are still counting, so we have to have more and more milk banks. The second is accreditation, extremely important. NICU, there are people in private practice who say, oh, I have an NICU. They have two warmers, may not have a ventilator, but they become an NICU. That's not correct. People take it for granted that you have a good neonatal intensive. So milk banks, you just start collecting, storing, that's not correct. So to ensure that, you must have standardizations and safety. And fortunately, the government has formed a group and they are looking at accreditation of human milk banks. The next thing is research. I think I made a big mistake. 1989, we started a human milk bank. Every alternate student of mine did research. Their thesis was on human milk banking. And all those research theses are collecting dust somewhere in Sion Hospital. You need to find time. We were so busy working for breastfeeding, milk banking, lecturing, looking after babies. We had no time for research. Today, a message I would like to give to all pediatricians, all neonatologists, those having, please make sure you have research. We need research from our country. We don't want to listen to people all over the world. We need research from India. Today, you have people training you in research. You can plan your study well, and you can make sure there is enough data coming from India. The other thing I need to warn, and this is important, so human milk is not a commodity. Prevent commercialization of human milk. There's a lot that has already started. How expensive, a few drops of milk and all. We must make sure this does not continue. People want to breastfeed. We say you must promote breastfeeding. Say, no, we can buy that milk. So this must stop. And also that, fractionation, that should be a part, protein separate, fat separate, which you can give your preterm babies, but it should be in-house, not as a commercial project. And finally, we must remember that what we are trying to do, you all have been talking about lactation management. We want every mother to breastfeed a baby. The biggest gift in life one can give, a mother can give a baby, is to breastfeed that baby. And we know that breastfeeding is a low cost-effective measure for child survival. You will spend ventilation, you'll spend on surfactants, but if you give donor milk bank, it's an important tool for survival of preterm and sick babies. And therefore, I think that Kerala is doing a wonderful thing, started it, human milk banks. Next year, probably maybe in a year or two, all hospitals in Kerala will have a human milk bank. Congratulations and all the best, and thank you for inviting me. And I met so many of y'all after a long time, maybe it is across looking at each other. It was wonderful to see all of y'all. Thank you.
Thank you, ma'am, actually for sharing your experience for last 31 years after starting the first human milk bank in India, and the obstacles that you had to face and the challenges you had to face, how you overcame and remained the only breast milk bank for nearly 15 years. And now when there are 70 breast milk banks in India, and when Kerala is going to start 2 breast milk banks, your words of wisdom are real encouragement to all of us. And even though Kerala was the first state in the country to become baby friendly. Somehow the requirement or the need for breast milk bank has not stuck us so far. And now when the preterm survival is increasing and there are certain occasions where the mother has to be separated from the baby, definitely more and more hospitals will require breast milk banks. Ma'am, thank you for, actually you have inaugurated the breast milk bank activities of Kerala, which is partnered by NNF Kerala and IAP Kerala, which is in the action plan of both these organizations for the year 2020. Thank you very much, ma'am. Now you have we have a couple of questions in the chat box. One is for human milk bank, do you need laminar flow?
You know what? Like I said, when you're looking at quality control, ideally, it's like, when you're preparing TPN, you will have a lamina, the things that you take. But here, it is better. It is not part of the accreditation process. So because they wanted quality, the highest quality, Sion Hospital has included that lamina flow. But it is not necessary in every human milk bank. Stage 2.
Yeah, thank you, ma'am. And I think the next question is, I think you have covered it, because during the initial 2-3 days, the expressed milk itself will be small, then will it be sufficient to donate for the bank? That I think you have covered that topic.
Yeah.
Yeah. Now, if there are no more queries, once again, thanking ma'am for your involvement, your presence today for the talk on breast milk banking. I hand over the mic to Dr. Sumar, the chair.
Yeah. Beloved Narayanan and friends, once again, I congratulate Madam for the excellent presentation, and I congratulate our NNF President, Dr. Manoj, and IAP President, Dr. Narayan, and Secretary Bala for initiating this human breast milk banking in Kerala also. Hope that within few months we'll have these banks in Jubilee Hospital and Government Hospital, Ernakulam. Thank you very much. Thank you, Madam, very much. Thank you all for the patient listening. Thank you.
Thank you, sir. Thank you, ma'am. And now next we have our inauguration of our NNF Kerala Newborn Care Week celebrations. I invite our chief guest, Dr. Rati Balichandra, ma'am. And to chair the session, I invite our Dr. V.C. Manoj, sir, President NNF Kerala, and Dr. Vishnu Mohan, Secretary NNF Kerala. Screen is yours, ma'am.
Respected Chief Guest of the day, Dr. Rati Balachandar, Guests of Honor, Professor Armida Fernandez, Professor M.K.C. Nair, other respected seniors, and my dear friends. Newborn Care Week is celebrated every year, we all know, in the country from 15th to 21st of November. The aim for celebrating this week is to raise awareness about the importance of newborn care for child survival and development. And today, we are inaugurating our activities for this week. We are proud to say that we have an array of at least 10 activities being planned back to back, including seminars, the nurses training modules, case discussion, meet the parent sessions, etc. this week. So it's going to be a very busy week for us. To inaugurate our newborn activities, we are fortunate to have with us Dr. Rati Balachandar, Assistant Director General, Nursing, Ministry of Health, Government of India, with us. Hearty welcome, Madam. It is so very nice of you to find time to join us despite your very busy schedule at Ministry of Health. I know how busy you are. Thank you so much for joining us. Now, may I request my friend, co-chair, Dr. Vishnu Mohan, Secretary of NNF Kerala, to formally introduce the chief guest before the official inauguration. Over to Vishnu.
Seniors and my dear friends, very good morning to all. It's my proud privilege to introduce our chief guest for the day, Rati Balachandran. Priti Balachandran is the Assistant Director General, Ministry of Health and Family Welfare, Government of India. Has completed her in Community Health Nursing from the University of Calicut, MBA in Human Resources, and PhD in Nurses from the Rajiv Gandhi University of Health Sciences. She also has done a postgraduate course in Healthcare and Management, the Global Program 2018 from Global Nursing Leadership Institute, the International Council of Nurses. She has more than 25 years of experience in the field of nursing and public health. She's a well-known researcher with various publications in various English journals. She's also an ad hoc inspector of the Indian Nursing Council. I request Madam to kindly inaugurate the Newborn Week celebrations and our summit and deliver the inaugural address.
Thank you very much. Good morning, the dignitaries, experts, and the participants. Greetings from Government of India. It's a proud privilege to be with the eminent speakers and the experts of neonatology in this morning. Thank you, Dr. Manoj, NNF, Kerala, and IAP also, and all the other experts. Before starting, let me pay tribute to all the healthcare professionals who have paid their ultimate sacrifice in ensuring healthcare to us across the world. I'm happy to be a part of this inaugural session of Newborn Week, where the multi-professionals are all there, and we are all working towards saving the life of newborn and bringing the healthy newborn to the nation. Each newborn is tomorrow's citizens. So by ensuring healthy newborn, we are investing to the future of our country. From the beginning of these 2 days, all the sessions were highlighting that how important it is to work together, and right from the antenatal period also, all our investments are, the result is as a healthy newborn. There are 2 flagship programs like community health officers as well as midwifery, and various efforts are being done at the national level to ensure that the mother and baby will be taken care so that they can enjoy the respectful care during delivery and afterwards. So in this inaugural session, I would like to congratulate the organizers and the participants and all healthcare workers in putting their efforts to provide care, even with putting their health at risk, ensuring the services to the people. There are lots of opportunities we're getting as this professional organization has given. In the middle of COVID, people become more and more techno savvy, and the online training program has been started by this organization, so that knowledge and the competencies are providing to the healthcare professionals. Let us commit in this day of first day of Newborn Week celebration. Let us commit that we will ensure at least one competent person in every newborn corner to save the life of the baby with the knowledge of neonatal resuscitation. The long efforts have been there from these associations, but along with that, I commit that the nurses are also a good resource available in our country, provided an enabling environment to them. Together we can make changes. So for considering the significance of nursing, the year 2020 is considered to be the year of nursing and midwifery by the WHO, as it is a cost-effective solution for sustainable development goal. So we, the healthcare professionals, will join together and ensure that each and every SDG goals are achieved in our country, as it is explained by the previous speakers. India is a wide country with a wide differences in its culture, as well as health indicators, health resources available, and the health workforce available. So through these things, through these platforms of online and the other efforts of various organizations, let us join our efforts and reach the people, and every baby should be protected from preventable problems. And I wish all the participants a great success, and this newborn week also a great success. There are few opportunities where the nurses can contribute. First and foremost, as Madam was mentioning about the research evidence, there are lots of PhDs and nurse scientists available. Let them, I request them to take this type of studies where they can show, bring the evidences and bring changes in the policies as well as the healthcare delivery systems. What works well and what works not. And at the same time, like Professor Namita, there are many nurse educators available. Also provide their competencies to the mothers and babies by conducting antenatal clinics, as well as empowering the mothers and baby in healthy behavior, how to protect their life, because nurses are available 24/7, 365 days. They are close to the mothers and the families, be it a center in a healthcare services or in the community. Utilize this opportunity to partner with the families and educate them about the healthy behaviors and the impact of breastfeeding in the baby as well as mother, and make as natural as possible in their life to be healthy. As I mentioned, the flagship programs of community health officers and midwifery are two opportunities which is at the national level. The two opportunities released by the government of India. The other things are like lactational counselors. So there are various levels in which we can contribute towards this noble cause of protecting the newborn. So in our country, around 17 to 20 lakh nurses are registered, and every year around more than 2 lakh registered nurses are passing out. So this is a great resource for us. So I wish that with the newborn, each newborn born in our country are our brothers and sisters, or our children of our brothers and sisters, or the grandchildren of our brothers and sisters. When we have this much health professionals available who are willing and committed, and there are health policies available, resources available, the courses available, we could not justify that babies die in our country. So I wish there's a great success to this be a spark. All those participants who are undergoing this sessions may put it into action. And I also hear from many nurses that after undergoing the similar trainings, they could survive the mother and the baby, and they had less referrals. So that's also, this experience was shared by nurses from Bihar, Rajasthan, Chhattisgarh, MP, etc. in the rural peripheral areas where they work as a community health officers or as a midwife. So there are lots of scope by collaboration and multidisciplinary trainings. We all understand that we can supplement each other and collaborate each other so that our babies in our country will be healthy, so we can invest, and a healthy nation will be there ahead. Recently, as a part of this this year, Indian Nursing Council has released, and they will be in Gazette notifying very soon, that the neonatal nursing course of 1 year is considered made into a residency program. So I request all these leaders, neonatal leaders, to take effort in starting such courses in your places, so that more and more competent neonatal nurses will be available in our country, so that the quality of care will be better, quality respectful care will be better. Thank you very much for the organizers, and wish you a great success.
Thank you, madam. It is truly an honor to have you with us, and we look forward to future associations with you in the online training module for nurses. In fact, when we launched our the 3-month training module for nurses in September this year, you were a real pillar of support, and we had almost 1,700 nurses from all over the country doing the course. Some of them are attending this today's summit also. So thank you so much for joining us.
Thank you, sir. Thank you, ma'am. Now we invite Dr. Vivek Singh, sir, to felicitate this event. Sir represents UNICEF India. Sir, the session is yours.
Thank you, Dr. Joseph, and a very good afternoon to all seniors. And I would pick from what Dr. Shushma Nania ma'am said, to the doyens of our fraternity, Dr. Fernandez, Dr. Naik sir, and others. It's a proud privilege to be speaking in this session, and special congratulations to NNF Kerala for thinking of an event where I'm picking up from your brochure, where you mentioned that it's coming together of doctors, nurses, and all fraternity. And why this is important and must, it deserves a congratulation, is I'm picking up from the theme of the World Prematurity Day, which happens on the 17th of November, which says, "Together for babies born too soon and caring for the future." So I've been listening to all the deliberations that we were having, that unless we now move from, especially in states where we are moving towards single digit, not just NMR, but IMR, that unless we move from the survive to thrive agenda, are we making the most of this demographic dividend by making more children to survive? But are they getting the environment and the right that they have to thrive also after survival? So I think it's the states like Kerala and others which will lead the way for the entire country, that how to move from the survive to thrive agenda. Now, coming to the importance of the National Newborn Week, what we learned is that this is a week, for those of us who were not aware of this, that this is a week dedicated to enhancing awareness, advocacy, and also some actions for newborns. And as we said, caring for our future. This was an event which was started by Government of India in 2000, very unique to India, one whole week where we celebrate and do this. And it was inaugurated by the then Prime Minister in the year 2000, Shri Atal Bihari Vajpayee. And incidentally, it was the NNF which had taken a representation to Government of India that if the major cohort of our birth cohort that we lose to preventable causes, if they are the newborns, then we must commit ourselves at the highest level of quality. And again, congratulations to NNF for this representation that now Government of India celebrates this 1 week for the last 20 years. And in fact, in these 20 years, the national newborn mortality rate has dropped from 44 in the year 2000 to 23, which is about a 57% decline, as against the global drop from 28 to 18. But what we would also realize is that as our mortality rate, neonatal mortality rates drop, then it becomes more difficult to attain the reduction. And that is where most of the states, as they move towards the single digit NMR, which Kerala has already achieved, will look up to states like Kerala for solutions, because it's easy to reduce from 44 to 23. but it will be difficult for states to go from 20 to the single digit NMR, which the country has set itself in the India Newborn Action Plan targets. And referring to the India Newborn Action Plan, so Government of India, in response to the Every Newborn Action Plan in 2014 after the World Health Assembly, it had enacted its own India Newborn Action Plan, which had certain key strategic interventions throughout the life course of a mother, from preconception to antenatal care, to care around birth, to care of the normal newborn, care of the sick newborn, essential newborn care. And what India added was care beyond survival. So even in our newborn action plan, you see the sixth pillar of care newborn survival. And it is so heartening. I was listening to the discourse on the breastfeeding. So heartening to hear that it was a well thought through move to include in India's newborn action plan the sixth pillar of care beyond survival. And we have states like Kerala and others in the country that can lead that sixth pillar support for the other states. There's another important point, and again, I'm picking from the topics that I saw in the symposium here. And one of them, very important, is setting the standards of care for small and sick newborns. So as we all would be aware, that India started building these nurseries that we call the special newborn care units at the district level. And I hear from my seniors, many of whom who are present here today, that it was almost like a dream where, you know, seniors like government officials and the representatives of many UN organizations, when this was being conceptualized from Purulia and other places in other states beyond Kerala and Tamil Nadu, that this is possible in the public sector to have a SNCU like set up in every district. From that positive skepticism till today, where we have SNCUs now in more than 80% of the districts. And India is the first large country to have SNCUs in more than 80% of the districts. So in terms of coverage, we have achieved some target of making sure that there is this essential care for small and sick newborn babies at the public sector hospitals. But now we need to move from just coverage to quality. And that is where the agenda from Survive to Thrive gets supported. And when we talk of quality today for newborn care, I think we have to be fully mindful of the provision, not just the provision of care, but also the experience of care. And experience of care in terms of the theme for this year's National Newborn Week being ensuring quality, equity, and dignity in newborn care at every facility and everywhere. So it stresses the importance of the fact that we have to think of quality of care. We have to think of equity and dignity, which takes us beyond just the provision of care to experience of care. And also the fact that at every facility, but also everywhere. And that is where the symposiums like these, where we are able to congregate stakeholders beyond just the doctors and nurses, are very useful, because even the families play a very important role in making sure that newborns not just survive, but they thrive to their fullest potential. One last point that I want to make, and again, congratulations to NNF, is that we have seen as a fraternity how NNF has grown along with, of course, the IAP chapters. We know it's a subset where the NNF has not just kept the advocacy agenda high, but is also now supporting the health workforce development. Because if you look at the recently released WHO quality standards for small and sick newborns, there are two overarching within the thematic areas, there are two overarching areas, and one very important is that competent and motivated and empathetic multidisciplinary human resource available for newborn care. And that is where we see courses like the one started by the NNF Kerala chapter, where more than 4,000, I believe, nurses are engaged through Telegram and other technology means, where we are getting some of the best experts from across the country to train a workforce. And similarly, we have noticed that there's another package in preterm started by NNF. So these are critical interventions which will lead to attaining the newborn goals, not just for the country, but will also make sure that we have competent health workforce throughout the country to be able to do that. So that said, I again congratulate NNF Kerala chapter, not just for this week-long events that they have planned, but for a very systematic newborn action plan, as they have mentioned, to be able to do this. So with congratulations to the entire team, over to you, Dr. Manoj, please.
Thank you, Dr. Vivek. Now we move on to the keynote address. To deliver the keynote address, I have great pleasure in inviting the guest of honor, our own Professor Dr. MKC Nair, former Vice Chancellor of Kerala University of Health Sciences. Sir will be talking to us about the importance of follow-up and neurodevelopmental issues that we face as we follow up the babies. Over to you, MKC sir.
So, good afternoon. Already lunchtime. First of all, congratulate Kerala NNF for doing such a beautiful program. It's covering almost every aspect. Dr. Manoj told me that there will be more of nurses and other interested people than dedicated neonatologists in this group. So what I'm going to talk, I'll talk in Malayalam. Is okay? Is it okay?
Sir, actually, there are people from outside state as well.
Okay, then I will say in English. Okay. So first of all, let me start with paying homage to my, Guru, Dr. S. Jayam, late Dr. Jayam. Amida Fernandez would agree with me that we can call her the mother of community neonatology. Her experiments with, Tanjavur experiment with early neonatal care is excellent. And as a governing, at that time, as a governing council member of NNF, I had visited it. I was enamored by the whole work that she has done. So my dedication to late Dr. James. Now, when you talk of high risk, the word high risk we use very often. High risk for what? High risk for mortality versus survival. We are interested in survival. And then comes intact survival. Impairment versus well-being. You don't want a child with impairment. We want the well-being of the child. Disability versus normal development. Normal development means achieve something. Not only he doesn't have bad thing, but you need to achieve. Handicap versus achievement. But the gap widens as we move forward. Newborn period, you may not find that there are a lot of problems. Your baby has a little problem. But as the baby grows to be a young adult, there's going to be a lot of problems the next 10 years, 20 years, 15 years, 20 years. So that is what the whole concept of high risk as well as follow-up. So then let's understand what are the risk factors for poor growth and development. There are biological risk factors. We know, we will talk about it. So there's a neurodevelopmental program is the answer. There are genetic metabolic problems, which are the severe mental, what you call intellectual disability or old mental retardation. Then we need a lot of lab facilities. The problem is we don't identify all this. We just say it is a group, but we are not able to pinpoint. Then there are a lot of environmental factors that needs awareness, particularly through the ICDS. That's the biggest, area that we need to focus on. So neonatologists need to be in love with the Anganwadi workers. That's a huge concept in India. And now the 45th year, we are going to celebrate the 50th year, another 5 years. Unknown, there's a lot. Okay, and that needs more research. Then what I would let us see, one of the things that I have done years ago was India Cleanse CDC Neonatal Health Research Initiative. It was done mostly focused in Nagpur. In India, neonatal mortality has remained static for quite some time. Now it has come down, definitely. When you talk about it, the static period, that was the time this research was done. And what do you say? What are the causes of neonatal mortality? Umpteen number of causes the neonatologists would say, but I will say essentially only 3. The majority is taken care of this. Just look at the number. Infection 52% in the community setting, asphyxia, and just being low birth weight. So 3 things we should know: infection, asphyxia, low birth weight. Now, if you look at nursery, neonatal nursery graduate, not necessarily NICU itself, all type of SNCUs, where the special care is given, then the multiple regression analysis of Bailey score at 2 years clearly showed that birth weight is the #1 factor, followed by intrauterine infection, which we understand naturally, neonatal seizures, occupation of father representing the socioeconomic status, occupation of father and residence represent the socioeconomic status. There is a lot of unknown, but all these we cannot straight away remove. Birth weight, if you have to control, improve the birth weight, you need to improve the height of the mother, and to improve the height of the mother, we need to focus on pre-adolescent, pre-puberty girls, give them a lot of food for rapid growth spurt. So it's a long drawn out process. But if all this has happened, there are few things we can do. Intrauterine infection, of course, now we have rubella vaccination, most preventable. Okay, but ultimately it comes to early stimulation. That things have happened, but can you pick it at the beginning itself? So you have a whole lot of intensive care has come. When I was NNF president, one of the rules that I made compulsory is, if you want to accredit any NICU, they need to have a neonatal follow-up, they need to have vision testing, they need to have hearing testing, and of course, the chronic lung diseases. So this is something which was made very compulsory, and I think it has its effect, because even our own SAT last year, we got a DM accreditation. And the first thing the person said was, you have the CDC next door, and 1 month, minimum 1 month compulsory posting has to be there before we will agree for the DM program. Now, prevention of brain injury following perinatal asphyxia, of course, the resuscitation program, I think way back in 80s, I spent my life going across Kerala with a bag, neonatal resuscitation. Names have changed, NALS, then whole lot of names have changed, but the concept is same. We started the first, neonatal corner in a city hospital, major, medical college hospital. Resuscitation can be followed by a latent phase characterized by transient recovery of cerebral energy metabolism. Lot of information is coming now. Okay, even what I say, maybe someone will say, no, we have gone beyond that. It is true. We have gone much beyond this also. Before secondary deterioration occurs with seizures, cytotoxic edema, and cerebral energy failure 6 to 15 hours after birth. The most important part is the damage to the neurons comes after the whole hypoxia has set in. Hypoxia per se is not the one creating problem, because brain takes a lot of hypoxia till a particular point and then it just leaves. You can't take anymore. That we know. That is why the cooling has come. That's why the initial few hours become so important, that cooling has come in a big way. But there is a lot of cytotoxic edema. There is a lot of energy failure mechanism, which actually destroy the nerve cells. Now, intraventricular hemorrhage, a small IVS limited to subependymal region is associated with only slight increase in major sequelae, whereas large bleeds with ventricular dilatation has 30 to 40% sequelae, and accompanied by intraparenchymal injury, white matter damage. 80 to 100% survivors have major neurological impairment. Volpe's original work. We have moved further from there because it's 30 years down the line. Now we have moved much better that if you have a good ultrasound, you can almost predict whether the baby will have problem or not. The brain damage would be, you don't need a MRI scan. A good ultrasound and a good sonologist experience can actually pick up all the damages from ACNS to having the white matter damage to the holes that is there, 1, 2, 3, 4 holes, all that can be picked up so easily. So that means every baby in the intensive NICU, before discharge, if you have a good quality ultrasound, you can almost predict whether he has a brain damage and will have a problem later. Then, of course, we have hypoglycemia as a brain injury factor, something we don't understand or we don't still are not clear about. You have asymptomatic hypoglycemia, symptomatic hypoglycemia, hypoglycemia in a diabetic mother with a higher blood sugar. You have a very small baby where it's so difficult to control all this because without keep on pricking the baby. Get the point? So hypoglycemia is a big issue. We may not know exactly cellular level what all damage happened, but we know that earlier detection of hypoglycemia, such as in the delivery room in this population, could modify subsequent. So for a term baby, a baby who can take blood, the immediate breastfeeding becomes so important. For babies who can be tube fed, the blood banking become breast milk banking becomes so important. And even after that, if we can use the mother as the developmental simulation in the nursery, then she also can be giving breast milk even if it is drops. That gives a lot of importance. Now blood sugar, how to measure, heel prick, lot of methods are there. Of course, WHO recommended this. That was in 2003. Now when you are talking of NICU with very small preemie, we still have gone further than that. Now seizure associated brain injury in term babies, clinical seizures in 37% of cases. Severe seizures in human newborns with perinatal asphyxia is independently associated with brain injury. Now, it is not limited to structural damage in MRI. I have my own follow-up, now they are 24 years old, of post-asphyxial encephalopathy babies. What we have known at the age of 14, 15, we did the last evaluation. At that time, what we said is, the mild variety post-asphyxial encephalopathy has almost normal performance. The severe ones, 50% is damaged, they have problem. The moderate one, somewhere around 15 to 20%. So a simple clinical post-asphyxial encephalopathy in a term baby can predict what will happen. I'm not talking about NICU with a huge setup. I'm talking about usual SNCUs where you don't have everything there, but you have reasonable services. That's what majority of pediatricians or neonatologists, so-called part-time neonatologists would be working on. There are few NICUs where much full-time neonatologists, many neonatologists and full-time ventilation going on. There things are little different. You may need further. That we have put in the book called High-Risk Newborn. Now, hyperbilirubinemia is very important, and Dr. Bhutani's name comes. And he has come out with the zone, different zones, high risk zone, intermediate, low intermediate zone. And all his papers suggest that after discharge, if you go by this, it really do wonders. But one of the problems that has happened is, it doesn't work almost as good when it comes to lower premature babies. So from Kernicter's days, we have gone to bilirubin-induced bind neuronal damage. So a preterm baby, very preterm, at a very low bilirubin, can have neurological damage, and how to pick it up becomes a big problem. because we cannot predict it. Term baby we can predict. So the zones work, but even then there are problems. So we have a at-risk concept or high risk. I don't like to use the word high risk because it's threatens the parents. Now, what is a high, mild, moderate risk? Very simple words, we will say, what are the concept? If every factors we take, 1, 2, 3, 4 factors we take, and say the birth weight, gestation, you have the complication 1 by 1, days of ventilation, which are minimal interventions, that is a mild one. And you have a scoring on based on that. NNF also has agreed to that scoring. Then you have moderate and you have severe. Suppose the baby is on ventilator for many days, that critically will go into the severe because of the fact that he had multiple complications developing. And then this simple risk scoring, we have actually found that if the mild group variety is getting 3%, the moderate is getting 7%. Naveen Jain in Kim's hospital has proved this. And if you are severe one, 9 to 10% abnormalities at 1 year. And now we are doing a multi-centric trial. Initially there were a lot of NICUs participated. Now only few are sending the actual data, but we are continuing to do that follow-up. Naveen is coordinating the plan. Now, retinopathy of prematurity. Neonatologists, I don't have to talk about it. You know everything about it. I'm talking basically for the nursing people, because that's what I was told. There's a wide audience and everybody need to be taken on board. Now, retinopathy of prematurity, of course, we know details about all the zones and all that. I won't go into all that. The message is very simple. You need to have, if you have a very premature baby very sick, have sepsis and have multiple complications, in spite of having reasonably good gestation, can develop retinopathy of prematurity. And the way to manage this is having opinion of a well-trained ophthalmologist, not a simple ophthalmologist, somebody who has been specially trained. And this is probably the only condition where earlier is not the better. If you go early, you may not find anything. So for each gestation, NNF has come which day or which week the baby should go for ROP. And all this have been summarized into what is called a blue book. And this is coming as a special an article in Clohartis new edition. Now, this is a different zones that we are talking about. Essentially, what does it mean? Hypoxia stimulate vascular growth. Vascular growth disturb the whole atmosphere there. It pulls on the items and then destroy the vision. So that's probably in simple words that can be done. Now you talk about newborn hearing screening. Dr. Abraham Paul has to be remembered when you are talking about any neonatal, because he's the one who was obsessed with, I say he's obsessed. He cannot survive without neonatal screening program, because the Kerala is almost completely, and India also most parts having neonatal. Initial days, had SAT data, normal newborn 5,000 or 5,500 screen positive 706 and confirmed hearing defect 14. And Cochin IAP initial data I'm talking, high risk newborn 400, screen positive 25, confirmed hearing 7. Why I'm bringing some of this earlier one is just like Madam talked about initial days of breast milk, banking. Now it's easy to say we have all this. But where did you start from? The effort from Cochin, that was the most important part. Now, then we have early stimulation. So the whole question comes, what is the early stimulation and how early the question comes? So we have developed certain models. And the most important, the first one was, of course, we have the module on early stimulation. CDC, KIMS, myself and Naveen have come out with beyond neonatal survival. At what stage, what all should be done? My contribution was more developmental stimulation. His contribution was more of the medical management part. And the whole thing has come out now as a blue book. That is something used all over India now. Now, what does this mean? You know, if you did we did a randomized controlled trial of a mother-oriented, structured early stimulation program. And what did that do on 800 babies? And what has happened to them? What we find is in the control group, if 44.6, that means 45% has poor performance. Poor performance means performance below 25th percentile. The intervention group has only 26%. What a difference it has created. Okay? Almost 20. So much can be brought down. Early stimulation brings down the percentage of children with poor performance or markers of developmental disability. And this was a paper I presented in Global Forum for Health. And that was widely appreciated because it is practical. And now, after this randomized trial, now it becomes unethical that nobody can do the same study because it is unethical. Now, one of my problem was development. Okay, we all talk about it, but how do a busy neonatal unit organize a developmental program? And what tools we will use? We use American tools, foreign tools. You are supposed to pay for everything. Every baby you use, you are supposed to pay money. So I don't believe in that. I thought I will go by Indian standards. So we developed what is called prevalence of development delay at 12 months. Let's see the comparison of things. Screening tool, CDC grading for standing. You know, a grading for head holding, sitting and standing has been made. Amil Tyson passive angles, it is 24%. Denver development 2, Denver 2 gross motor 24%. So look at all of them are coming 24, all the three screening tools. But when you do a diagnostic test of Dasi, which is a Bailey's Indian counterpart of Bailey, 13.3. And Dasi is available and lots of girls are now getting trained, officially trained for Dasi. If you are going to use that, you need to get it trained from Pune group, they are doing. And together, all this had high specificity, net negative predictive value, and accuracy against Dasi motor data. So if you can do even one out of this, you can have a follow-up program. If we can do all the three, even better. If we can confirm at 1 year, that's what we do. Now I work in NIMS Medicity. We have a new child development center I showed in the first slide, which has a policy that no child with disability need to pay. You are given a bill, you want to pay. If you don't want to pay, don't pay. That is a principle. You don't want to pay anything, it's okay. Nobody will say anything. Just go. But there also, what we are doing is every baby will be followed up at 1 year using Dasi or Bailey scales of infant development. Now, one of the other problem, these children, every newborn follow-up we need to think about is the question of autism is coming big. There is a suggestion that low birth weight babies are at increased chance for autism. And in fact, that statement was put into the Cloharty, the new book by Naveen Jain. And we had some discussion. I said it may be too premature to make a statement like that, because once it comes in Cloharty, it will be like association of rubella vaccine with autism. Then you will have to spend a lot of energy to say it was not true. I said, don't make statement like that. We will say there are some suggestions, some reports coming, we need to, which means every newborn follow-up, we must do a screening for autism. And autism, of course, MCHAT is available. It can be conferred by SCARS, okay, childhood autism rating scale. We are comfortable using all this. So I develop a simple tool because I don't want complicated. It only has 20 questions in 4 domains and 1, 2, 3, 4. That's all. Okay, 20 questions. And the total score is less than 35, no autism, 35 to 43, mild, moderate, above 44, severe autism. Okay, is it good or not? That's what we should do. The negative predictive value against CAS is 98.6, 99, which essentially means if you use a simple tool instead of the CAS, your chance of missing is 1 out of 100. And that also may be a borderline case. That means almost as good as that. So why go for the bigger test unless you are doing a research? A clinical, we need people to help the neonatologist do all this because he cannot or she cannot do all this. So that girl has to be with lesser education and she should be competent to do the test, but she cannot be a, like a full-time faculty like doctors. Now let us do, is early intervention effective? Okay, just look at the last severe all. 27 has become 13. 3 months intervention, systematic intervention, severe from 27 has become 13 or 45% has become 21%. If severe can come down, where did they go? Either they became mild to moderate or become normalized. So look at the non-autistic. When we started the intervention, there was only 4 normal. Now after 3 months severe, intensive intervention, the normal has increased to 19, severe has decreased to 13. That means early intervention is definitely okay. Now, let's see what happens in a developmental clinic. This is only one message I want to give. In a development clinic, what we see is either some few normal babies. Out of 2,100, nearly 350 was normal. 1,053 had only development delay. And then 293 had speech and language delay. If you focus only on this, development delay, speech and language delay, and autism, though not so common, but because it's severity, we need to focus on that. If you focus on these 3, I think we will be able to get result because these are the ones which give results. Development delay with therapy, it will give result and we have proved it umpteen number of times. The language delay, now the second one is the language delay. 455 babies less than 3 with language delay, assessed by less, I will talk about it. What has happened? The pre-intervention language quotient was 60, the post-intervention became 70, almost 10-point improvement in language, which clearly shows beyond doubt that early language intervention. This is a critical period that we miss. We wait for the child to become language delay, then refer to a speech therapist, then start doing speech therapy. All late. This early language delay, just like early stimulation, can be done by the mother. You can teach the mother what to do and she will be doing that. So this is completely proved. This book I am talking about, developmental disorders, is the simplest book you can think of, in which said what is this 10 developmental disorders, what the mother can do, what the Anganwadi worker can do, what the simple therapist can do, what a specialized center can do. So in a simple language. Okay. Now in the autism evaluation, one of the things that we need to understand, this actually my former assistant, now the director of the Child Development Center, Dr. Babu George PhD thesis, what he has proved beyond doubt is that the most important significant risk factor for autism, we don't know why autism occurs. So naturally, we do not know the cause, but what pushed the child to autism, the odds ratio 19.57. That means 20 times. A child with autism has 20 times more chance of not playing with the children of same age. Mark my word, I think this one slide is superb. It's very important. If your child doesn't have children to play with, that's a huge risk factor. If you don't have outing for the child, that's a huge risk factor, particularly in COVID time, 4 times, 3.6 times. Do not tell stories, sing songs to the child, again 3 times odds ratio. Breastfeeding, not given breastfeeding below 6 months, again 3.4 times. So just remember 4 things. When the baby is born, if you don't breastfeed for first 6 months, if you don't take the child out and show the environment, if you don't tell stories and sing lullaby with the babies, and if you don't have children to play with, surely that he's a candidate for autism. These are the preventable things. We don't know what are the others. Now, looking at the developmental disorder for a national perspective, we did a huge study with the support of NIH, National Institute of Health US, Autism Speak India, and our trust, National Trust, all supported in this one. What we have found is, here what we did is 1,000 children from 5 areas, 5,000 children, ordinary children selected at random by the best methodology from the community. None of them were brought by the parents. Nobody complained of a problem. Just pick up the child, put them through 10 diagnostic tests for 10 neurodevelopmental disabilities. Some of them we developed, some of them was already available. Okay. Normally what we do is a screening test, and from the screening test you go for confirmation. Here every child got everything. And what did we find? 2 to 6 years, 9.2% disability, developmental disorder, 6 to 9, 13.6, average 11.4. Forget about 11. Say below 10 years, 10% of children have one of the neurodevelopmental disabilities in India. That's something which you can remember. We cannot manage all this. That's why we have the RBSK program, Rashtriya Bal Swasthya program. We need the parent to understand. Parenting is so important. That is where the nurses have a huge role to play. And these are the 4 new tools that we have developed. England tool for autism, England tool for ADHD, for epilepsy and neuromotor impairment. I won't go into detail, it's all available. Okay, now effectiveness of early stimulation, let me say the summary. After nearly 50 years of research, there is evidence that both quantitative database and qualitative report of parents and teachers that early intervention do good. In what way? Number 1, increases developmental outcome of at-risk babies, reduces poor performance among low birth weight babies, increases the developmental education gains for the child with development delay, improve the functioning of the family. This is very important, because if you have a child with autism, it completely shatters the family, and we do something called partner assessment scale Trivandrum. Simple 13 questions. We identify if they have a problem, we counsel. This is all being done. But we need somebody to do it, and especially a female. So that is something I'm working on. So reaps long-term benefits for society. And this is exactly the answer that I have found. Years ago, 30 years ago, I started the PG diploma in clinical child development. We have trained over 84 persons, and they are working in many NICUs. But what I found is that it's okay to train them, but in a national perspective, this PGDCCD is not, PG diploma in clinical child development is not going to work, because everywhere under the RBSK, Rashtriya Bal Swasthya Karyakram program, for which we have really given the input, maximum input from CDC, we realized that there is a post of a nurse, but that nurse has no idea about development or something. So we started a new course thanks to whole neurodevelopmental chapter of IAP. We have been allowed 4 candidates this year. They have joined. The training has started. The whole thing, I am planning it, systematically implementing it. If it works out well, which I am sure it will work out, next year we are going to offer this to 15 centers where already we have developmental pediatrics training. Already they are conducting. I also have 2 doctors, senior pediatricians, one from Thrissur, one from Rajasthan, who is doing the developmental training. So what happens is, these doctors also can be a teacher for these people. And whatever you want to do, whether it's breastfeeding, whether it is developmental appropriate care in the nursery, whether it is neurodevelopmental follow-up, early stimulation, think of whatever tools you want to use. Then these girls are fantastic, because they have learned biology, they have learned psychology, they have learned sociology. So a bio-psycho-social model, which I am sure Amita will agree with me, is the most important part, because she has been working on such concepts for last so many years. All the neonatology leaders have thought. In fact, we used to blame them that you only talk community. No, community is so important, because even the minor things you do, small things you do for a child, because the number is huge, the impact will be great. So in 1 year time, I will present 4 girls well trained in all this, including counseling, parental counseling. If the parents have problem, they are the ones who will counseling. So I am sure within the next 5 years, there will be a quantum jump. And that quantum jump, as the Honorable Prime Minister said, we don't want incremental jump. We want quantum jump, and this will happen. And thanks all NNF leaders who have taken so much trouble, not only to organize this, but to bring in the nurses along with you. That is the most important. This is one place. 2 places nurses are most respected. One, the theater nurse, scrub nurse, and second one is neonatal nurse. If any neonatologists don't listen to the nurses when she say, I think the baby doesn't look good, don't ask why you say it. You felt, okay, I am accepting discharge only tomorrow. That's a good nurse, even if that's a good neonatologist. Thank you. Thank you very much.
Thank you, sir, for that wonderful talk. The newborn, the Journal of NNF Kerala, has been in circulation since more than 10 years. So one of the objectives of our action plan, the newborn, was to index our journal. So I request Dr. T.V. Ravi, President-elect of NNF Kerala, to launch the action plan, and Dr. Jayashree, the editor-in-chief, who has kindly consented to become the editor-in-chief of the journal, to give her vision for the journal. Ravi, sir.
Ravi, send the audio.
Hi,
Dr. Ravi, unmute.
Hi, Sachi.
Hi.
Ravi, sir, please unmute. Sir, audible alla.
Headphone മാറ്റേണ്ടി വരും. Headphone, some issue with the headphone. Could be that.
Jayashree, madam, can you take over and give your vision for the journal?
Okay. Am I audible?
Yes.
Audible. Okay. Good afternoon to all the senior members and my colleagues. I thank Divakar sir, Dr. Manoj, Dr. Vishnu, and the whole NNF team for having entrusted with me the responsibility of rejuvenation of the journal of the NNF Journal of the Kerala chapter. So the NNF is planning to publish on a regularly basis the newborn, which is the NNF Kerala chapter journal. And previously it was being published as a print version on a quarterly basis. And what we plan to do from now on is to publish it as an online journal, maybe quarterly to start with, and later make it bi-monthly as we progress, as our work progress. And it will focus on updating all the practicing pediatricians, the neonatologists, the other academicians, and the postgraduates about the recent updates in the field. It will include topics from perinatology, the neonatology, and all the neonatal subspecialties. So the team will, the NNF team will create an editorial board, which will include maybe the faculty, all the faculty from within the state, and we'll try to include some senior faculty from at the national level and also at the international level. And the journal will try to include all the original articles, the review articles, recent management guidelines on specific conditions, the interesting case reports, interesting x-rays, spotters, and information about the upcoming conferences, courses, workshops, and job opportunities, and also some advertisements. So this is what we plan, and we plan to, and that all articles that will be submitted will be peer reviewed, and I hope to include at least 10 articles per edition. So once we start moving on and start publishing the journal, we can initially apply for a free online indexing, and then once it's done, and then once we proceed further, we can apply for a more recognized paid indexing. And then in that, if that happens, that our faculty and our postgraduates can publish in this journal as part of their course or their career. And we need to raise funds, which we assume to, or we hope to raise from advertisements and maybe sponsorships. So with the blessings of the seniors, with the blessings and guidance of the senior members and the support from our faculty, I hope these proposals will materialize in the near future. Thank you.
Thank you so much.
Thank you.
Thank you, ma'am.
Thank you. Thank you.
And next we have honoring of our National IEP President-elect 2021 and address by Dr. Ramesh Kumar, sir. Welcome, sir, to our webinar. I also welcome Dr. T.U. Sukumaran, sir, past President, National IEP, Dr. Narayan, sir, President IEP Kerala, Dr. T.V. Ravi, President-elect NNF Kerala, Dr. Joseph, Central IEP EB member and President NNF LP, Dr. Shimi Paulo, sir, President NNF Ernakulam, and Dr. M.K. Santosh, sir, past President NNF Kerala. Kindly take over session, sir. Thank you. Ramesh, sir.
Yes. Can I proceed?
Yes, sir.
Okay. President NNF Dr. Manoj, President-elect Dr. Ravi, President IAP Kerala Dr. Narayan.
Sound is not clear, Ramesh. Sound is not clear. Something problem with the sound, Ramesh.
You have to stop the car. Ramesh, you have to stop the car for 5 minutes.
You are traveling. You are traveling.
He's traveling.
So stop. I think something with audio.
Audio.
Ramesh, stop the car, open the window, and then do the program.
Still not audible.
Hello.
Yeah, sir, I think Sukumaran sir can start, you know.
Okay.
Go in that.
We can support. Suman sir can start.
Start
Okay. Can I start? Okay. Beloved NNF President, Dr. Manoj, my beloved friend, Dr. M.K.C. Nair, other dignitaries on the dais, my beloved brothers and sisters of Indian Academy of Pediatrics and NNF and dear friends. It gives me great pleasure and privilege to be here with you to participate in the felicitation function of my close friend, Dr. Ramesh Kumar. I'm very, very happy that Ramesh Kumar has won this election by a mammoth margin of 3,000 votes. My hearty congratulations to Ramesh and all the IAPNs of Kerala who worked very hard for his election success. And as you all know, I have got a very, very good personal connection with Ramesh. I know the growth and development of Ramesh in Indian Academy of Pediatrics from the beginning, starting as a medical student at Medical College Kottayam. I had very sweet memories of teaching Ramesh and that batch of MBBS students at Kottayam Medical College. Later, we have participated in a number of conferences at district level, local level, state level, national and international conferences. We have stayed together and we have worked together. And later he became a member of the IAP Pathanamthitta branch. Later the secretary, president of the branch. Then he became the editor of Pediatric Companion, then the state secretary for 2 years. And this is followed by, he became the EB, Executive Board member, 2 or 3 times of Central IAP. And he was the chairperson of the environmental chapter of Indian Academy of Pediatrics. Later, he was elevated to the honorary Secretary General of Central IAP. I think Ramesh is the only person, is the first pediatrician to be elected as the honorary Secretary of Indian Academy of Pediatrics and National President of IAP at pan-India level election. So he has won the secretary post in a pan-India level and president also in a pan-India level. After the secretary post, he was the most dynamic and most powerful, most aggressive Secretary General of Indian Academy of Pediatrics. And after the secretary post, he has become a national leader. And the margin he got for this election shows the magnanimity of Ramesh and his popularity as a national president. Ramesh has won the election because of his capabilities alone, not because of the support of IAP members like us. Our support was there, but he has already become a national leader after becoming the Secretary General of Indian Academy of Pediatrics. Now, he is going to take over as the National President of the Academy, and I wish Ramesh all the best, and we, the pediatricians of Kerala, will be always with you, will be always supporting you in all your endeavors as National President, and I wish you all the best as the President-elect and the National President of Academy 2022. AIAP.
May I request Professor M.K.C. Nair, sir, to speak a few words.
I think we are going so late, so I won't say much. Just to say one word, not 3 words, only one word. Ramesh has always been a protege of Dr. Sukumaran, sir. Sachi was maybe mine. You know, we associated in his early days, most of the time he was associated with me. Ramesh was most of the time associated with Sukumaran sir. But later he became, his biggest success in life was because he became an IAP Kochi man. You cannot survive, become a national president without becoming an IAP Kochi man. So he has become IAP Kochi man. And we have a wonderful potential national president, Dr. Narayanan, who is the Amit Shah of IAP Kerala, who can strategize, who can do everything, pinpointed program, and the whole lot of us. Balendra is there. Everybody was there to support, and I'm proud that he has become the 4th president of IAP, national president from Kerala, All my best wishes. Ramesh, election time is over. Now you need to cool down and do systematic planning for the next year. The 1 year will go as president-elect like this, and everything should be just like you planned for the election. You need to plan for your 365 days as president. And once you are done it, and all seniors, Sachi is there, all of them, Suvanu sir is there, all of them who are very well experienced. And Sachi particularly I'm saying because he has gone through the real turbulence time of IAP. He knows inside out of how to operate. And I'm a bit old now. I'm 15 years ago only. Now the whole climate has changed, so he understands. Please plan, so that when you take over, it's not a number of activities, but whatever you do, you need to have a systematic plan. You need to have a verifiable indicator ISO technically. How will you show that your program was successful? So that in the end, come out with a document that is memorable document of IAP, which can have whatever has happened before, maybe even Kerala's contribution, and then you can go into your 1 year activity. Thank you very much. My best wishes. But I have one request. We want to see the first lady also. Is the first lady in the car?
We are just reached home, sir. My mother home. I will call her.
Okay.
1 minute. Jaya. Hello.
She suffered for you last 2 years. I think she should be told.
She's there. Yes, sir. She is there.
Good. She suffered for you all these years. So she has to be there. Thank you. Thank you, dear.
Thank you, sir. Narayan sir, a few words. Sir, unmute. So please unmute, sir.
Unmute, sir.
Respected National President Dr. MKC sir, Dr. Sukumaran sir, Dr. S.S. Kamath, Dr. V.C. Manoj, Dr. T.V. Ravi, my colleagues in IAP and NNF. It's a happy moment for all of us when we are honoring Dr. Ramesh Kumar. I think the best thing in democracy is that if elections are held properly, the deserving person will win. Dr. Ramesh is the best example for that. Actually, Dr. Ramesh is relatively a new president. According to age, he is a young president in IAP. Because I have been witnessing the saga of Ramesh Kumar. He's actually my classmate in the 1982 MBBS entrance batch. So along with him, if he is young, I too become young. That's my motive in that. So hailing from a very small town in central Travancore, Pandalam, with no rail or air connectivity, working as a grassroots worker of IAP in that branch, Pathanamthitta branch, making that branch a very strong branch, which later helped him maximum in his election campaign. Then later on, moving to the state IAP as editor, a secretary, and a person who was binding all the petitions through the family get-togethers and all. And gradually moving to the national scenario as a national EB member many times, then as a first elected HSG, and finally the national coveted post of president-elect of 2021. What is Dr. Ramesh? He's a leader. According to Mr. M.D. Arnold, a renowned author, a good leader leads the people from above them. And a great leader leads the people within them. So from this, I don't have to tell what type of a leader Ramesh is. He's always ready to help other people, a leader with no pretension, a leader with no selfish motives, I say, always ready to embrace new things and giving opportunities to everybody, and above all, appreciating the work of everyone. So that is the leadership quality in Ramesh, which has made him rise to this covetous post of National President 2021. And along with that, I should thank all the members of IAP Kerala for their unity, for their support during the election campaign. If it can be like that, me half, God half, like that, IAP Kerala half, Ramesh Kumar half. That is what has won the election for Dr. Ramesh Kumar. The 2 or 3 months work, I can say more than 200 IAPNs of Kerala IAP branch has put up, it cannot be paralleled in the history in future also. So here is Ramesh. He is there in IAP to fix up golden pages in IAP history. It was in November 2019 that we promised that we'll support him to become the national president. Now in this November 2020, as Dr. MKC sir has suggested, we all promise you that we'll support you in during your presidential tenure and after that also. Our support, IAP Kerala support, will always be with you, Dr. Ramesh. So wish you the very best in the future. Thank you.
Thank you, sir. Joe, sir, a few words from you.
Respected NNF President Dr. Manoj, IAP Kerala State President Dr. Narayanan, and past National President Dr. MKC sir, Suvarna sir, and Dr. S.S. Kamath, and President-elect of NNF Dr. V, and our dynamic President-elect, National President-elect Dr. Ramesh Kumar, our NNF Secretary Dr. Vishnu, all the NNF Kerala State office bearers, and all the participants. And I think this is the two great proud moment of NNF IAP Kerala. This first moment is proud moment is NNF Kerala and IAP jointly submitting the newborn summit for including the various newborn activities throughout this year. Another proud moment of IAP Kerala is the victory of Ramesh Kumar. I think last Dr. Narayanan mentioned the last 1 year IAP Kerala is working hard. In the all the members of IAP Kerala is working hard to support Ramesh Kumar. Whatever the capability, whatever their contacts, whatever their time spending throughout 24 hours for support for Ramesh for the last 2 years. The victory of Ramesh Kumar is not the victory of Ramesh Kumar alone. I think it's the combined victory of Ramesh Kumar and IAP Kerala. So IAP Kerala given a wholehearted support in the supporting the voting percentage and getting vote from outside Kerala, and all the members are worked from getting the vote from abroad from they are worked hard to support Ramesh Kumar. And regarding Dr. Ramesh Kumar's content, his capability is such he win the Central IAP election as because of a good academician, good organizer, and is a loving person for all of us. I have a seat memories. I worked as a Central IEB member as a 2 times along with Ramesh Kumar. Again, I have fortune to work as a EB member along with Dr. Ramesh Kumar as a Honorable Secretary General of IAP Kerala. When he took over the charge as a Secretary General of IAP Kerala outside Mumbai, I think everybody will have a lot of views that how we can work in as a HSC as a outside Mumbai. He proved his capabilities, working hard, and he's a person have incorporated all the views of during the EB meeting. He was very well coordinating all the EB members to incorporating their views to action plan, and he's motivating all the members for action plan for last 2 years for SSC. I think that is that makes him as a leader in the national level. I think that is the best time for him as to is involved in the IAP activity throughout India. I think he can do more active than any other president because he's know in each and corner of the IAP how to intervene, how to activate the members, how to motivate the youngsters. in the IAP activities. So I think he will be the very memorable president of IAP national level, I think so. So with this space in short timing, I am concluding my talk and support him all the activities. I think all the activities in IAP Kerala, along with him and along with IAP Kerala, he can do the best national president in coming years. All the best to Ramesh Kumar. Jai Hind, Jai IAP.
Thank you, Joseph. Aptly put. Shimi sir, a few words about Ramesh sir.
NNF President, State President Dr. Manoj, the President-elect Dr. Ravi, our past national presidents Dr. MKC sir, Dr. Suman sir, Dr. Sachi sir, State IAP President Dr. Narayan, NNF office bearers of the state, and NNF leaders as well as the IAP members. Definitely, 2020 was definitely a year for us. It got us many things. It brought in COVID. It got in academics for us. It brought in also good election result. And most important of all, I think, is the unity that IAP Kerala as well as the NNF members of Kerala showed during the elections. This unity should stand. And also one more thing that we learned during these elections is a right candidate at the right time, and most important of all is the unity to get it done. So I think so. As far as the IAP national level is concerned, we are marching good. I think so. At NNF level also, we should start marching. So we have a few, I think so, charismatic leaders among us in the NNF level, and I think so they should start preparing to start march forward. And to do that, I think so the key thing is to update our NNF membership list. And with that, I think so, with like how MKC sir said, the Amit Shah of Kerala, Dr. Narayan is there. We'll update and we'll hand it over to him, and then let us keep the ball rolling. So, wishing all the best for Dr. Ramesh. I think so. Sir will do a beautiful work the next during his term. So of course, we will all support you in that endeavor. And one more thing to put forward is also the NNF Kerala. Beautiful job. All the best, and wishing more for NNF Kerala to come forward, and also NNF Panandita for hosting this summit and also their activities. Thank you, one and all. Jai NF, Jai Hind.
Thank you, Shimi sir. I now welcome Dr. Santosh sir. Say a few words.
Hello, can you hear me?
Yes, sir.
Respected Chairperson, Dr. Narayan, and all the respected dignitaries on the stage panel, and my dear friends. This time I was wondering about the voting percentage. It was just because Ramesh was there and everybody, including Narayan, Shimi, Jose, and all the branch leaders, took it as their own election. And it was a prestige election for us, and we want Ramesh to win. Even in the midnight, we went to some people and made them vote. Ever since I was in IAP, active in IAP nearly 20 years ago, I have noted that he has got leadership potential embedded in his chromosome. And whenever he speaks or he talks to anybody, it comes from his inner heart. That I have noted long back. And I'm sure in one of the webinars I was saying, and later many people have criticized you should not say like that and all, because it is election time. I was during his tenure of 2 years as secretaryship, I was sure that nearly 30,000 people he might have talked to, or he might have discussed many of their personal problems during this his tenure. And it was true also. I contacted some people in Gujarat, Belgaum, Baroda, Mumbai, Karnataka, and all. And everybody knows Ramesh. And not even a single call hasn't identified Ramesh. That's his personality. And I'm sure that he will do wonders when he become president 2022. I'm sure. And I have a simple and a humble request to Ramesh that unlike other presidents, you should not retire after you are president. You should work for the betterment of the IAP, and you must be there in the key position, and you can do really wonders. We IAP want you in future too, and I wish you all success in your ventures as the president of Indian Academy of Physics. Thank you, and Jai IAP.
Thank you, sir. So now I welcome our President-elect 2021, Ramesh sir, once again to address. I think, is it clear now? Audible over there? Network?
Okay. Thank you, Ronnie. Am I audible? Okay.
Yes, sir. Clear.
Okay, fine. Respected President NNF, Dr. Manoj, President IAP Kerala, Dr. Narayan, my mentors in IAP, Dr. M.K. Nair sir, Dr. Sukumaran sir, and Dr. Kamath sir, Secretary NNF, Dr. Vishnu, Dr. IAP, Dr. Balachandran, President-elect Dr. Ravi sir, and Dr. Jayaraman sir, and my past presidents, Dr. PMC sir, our vice president, Central IAP, and my great friend, Dr. Andhakashavan, my EB members, and my close friends, Dr. Shimi and Dr. Vijos, who have been working with all along, Devakar sir, Dr. Varma, and Tony Mambali sir, and all the seniors around. A great morning here today when we have got the newborn summit of first of its kind summit of doctors, nurses, and other stakeholders in newborn care being organized here by NNF Kerala and IAP Kerala. And my apologies for the technical snag where because my mother is a little terminally ill and I was traveling to Changanashiri. I had no other options. I had another program finished at 11:30 and started at 11:30 only from Kochi. So, but I'm so happy that I'm all my great friends, my teachers, my seniors. I'm so overwhelmed and humbled at the way the IAP NNF has come together. You are all around for this felicitation, in fact, for me. It's us from the college days, from later on from the IAP Kerala and NNF, it was been a joyous journey for me. I really enjoyed the work with my friends, and it was all some emotional bonding, some passionate time with my friends. And the way we are pulled together in IAP and NNF, especially through Pathanamthitta, later on IAP Kerala, not me, the IAP Kerala, it's really amazing. And it's something like by keyword everywhere, you should be fortunate to be born in this IAP Kerala family. This is something like you don't have to ask for anything, everything comes on its way. And our seniors are there to groom us, our contemporaries are there, or they are there to travel with us, and youngsters are there to cheer us up. So the team is all blending together. And nobody, when Jaya was there with me, I was just telling about one of our youngsters, some of the Nisha and some few youngsters in IAP Kerala. She said, you are quite big for the youngsters to grow. You allow them to come up. You give them the opportunities. So this is why I am. I still remember the moment when there was a call from Central IAP whether I am ready to take up the HST elections as a candidate, and Dr. Kasachi remembers very well, Soman sir remembers very well how much we have discussed and deliberated over it, whether we take it up or not. But seniors, branches of me. So IAP Kerala is really guidance from the we ask now something all of you consider come and use you come together, you make it move together. So this is something which keeps us bonded and keeps affection to each other, and we
if you could switch off your video, it may work better.
Yeah, true.
Hello?
Am I audible now?
Yeah, right now, perfect. Please continue.
Huh?
Yeah.
Am I audible? Okay.
Audible, sir.
Yes, this is, I'm with the audible. Okay. So this is something where we are really we are blessed with such a great team, and our youngsters also. I am really overwhelmed by the fact that when even another quote from Jaya, she went to is going to a hospital in Kollam where she saw a technician was telling her, "Madam, sir is there in the elections this time," and I have seen sir's photo in our pediatricians here on WhatsApp. So his profile pic is Dr. Ramesh. See, this is something which nobody, any other state or any other group can claim up. We have the candidate or they are the person who is running for us. So this is amazing for our team. We can be proud that wonderful team. We are making it together, and I'm sure that this team will always remain blessed as a wonderful lot. And as the minister has rightly put it, we really for quality programs, we will have wonderful icon from our team in 2022 because we have got the 2022 is not as a tenure for me, it is a presidential tenure of IAP Kerala, I believe, with inputs from all of you. Am I audible, isn't it, Narayan?
Yeah. Audible.
Yeah, so, sorry, I'm not sure. I'm not. So with inputs from all of you and all my team around, I'm sure that I can make you all proud and keep IAP Kerala proud, and all our seniors, youngsters, and all should really are there to support me, IAP Kerala, and support me in the activities coming up in 2022. And we have got quite a long time to prepare and plan it ahead. And I'm so happy that the newborn summit has gone very well. Congratulations to the team, especially Manoj, Vishnu, as well as Dr. Narayan coming up IAP and NNF together. The great orations here, the sessions from Dr. MKC sir, Dr. Kamal sir, Suman sir, all around. And this is a wonderful initiative, and I congratulate Pathanamthitta IAP, especially Dr. Roni, Nelby, Jijo, and Binikutan, and all for my buddies there in Pathanamthitta for taking the initiative for organizing this. It's a one of its kind initiative summits here from IAP and NNF together. And I believe I'm so pray and hope that we continue this unity, our unity in IAP Kerala and all gate activities in IAP Kerala to come up good in a big way in the years to come. And I am sure, and again, I am hopeful that I will keep you all proud as your representative in the Central IAP in the year 2022 as the president of Central IAP. We keep going in a big way and make you all proud. Thank you so much for all my seniors, my teachers, my young buddy, our young tucks, and all being around for this function here. And best days are going on for IAP and NNF Kerala. And congratulations for the great summit organized here by the team from NNF and IAP Kerala. Always with you in IAP and NNF at your service. I remain.
Thank you so much, sir. Always there for you, sir. We have our Ravi sir back in action, sir. Sir, could you say a few words, sir? A few words.
Yeah, sure. Ramesh, very sorry for the technical snag due to which I got cut in between, but I somehow got back to the mainstream. So it gives me great pleasure to congratulate and facilitate Dr. R. Ramesh Kumar, whose well-deserved success at the National IAP elections 2020 with a thumping majority of 3,009 has not been a surprise to anyone. Having proved his mettle as a vibrant and efficient HSG of CIAP from 2017 to 2019 is definitely the right candidate to reach the helm of affairs of our prestigious organization, IAP. His leadership qualities, academic excellence, and camaraderie with pediatricians from all over the nation will enable IAP to scale greater heights of glory at national as well as the international level. We are truly proud of you, Ramesh, for your steady growth from the grassroots level to the coveted post of President-elect 2021, while assuring you of our wholehearted cooperation and affection in your onward journey, committed to betterment of children of our nation. We wish you all the best in your future endeavors. Thank you.
Thank you, Ravi sir. So now we are back into our symposia. Next is about preterm care. So recent advances in preterm care. We have a dialogue coming up. So I welcome our guest faculties, Dr. Suman Rao and Dr. Mangala Bharti ma'am. Welcome. And to chair the session, I welcome Dr. Anindakesharan sir. He's the Vice President, IEP South Zone, and Dr. Srinivasan sir. Screen is yours, ma'am.
Good afternoon. Respected NNF President Dr. Manoj, State IAB President Narayan, Secretary Bala, Dr. Vishnu Mohan, Past President, National President Dr. MKC sir, Subhana sir, Sachi sir, President-elect Dr. Jayaram sir, President-elect NNF Dr. Devi sir, and all other dear friends and IAP family members, NNF family members. At the outset, I would like to congratulate IAP NNF branch, Kerala State branch, and also Pathanamthitta branch for organizing a wonderful Neocon summit, which is covering almost all topics. So today's topic, which I am supposed to share, is that a preterm problem, challenges, and newer trends in preterm care management. As we know, already discussed by our previous speakers, single-digit IMR, also neonatal mortality, the main factor nowadays it is maybe preterm birth. 1 out of 10 delivery is preterm birth. Means a majority of them will lead to increased morbidity and mortality. And very sad thing is that over 50% of this preterm birth is in Southeast Asian countries. This is a tremendous improvement in the antenatal care regarding prevention of preterm delivery from the side of our obstetricians in the form of insecurity, examination therapy, fibronectin detection, estimation, and so many other methods. Of course, there's a wonderful improvement in the care of preterm babies in all aspects, early CPAP, surfactant, I think familiar to all of us. But the most important thing is that as MKs are rightly mentioned, follow-up of this patient. Because high morbidity, so many handicaps, 50% of them may have neurological handicaps. So I think to talk all about all this work, we have a wonderful speaker, Dr. Suman Rao from Bangalore. So over to Dr. Suman Rao.
Hello, good afternoon, everyone. It's such a pleasure to be on this webinar, and thank you, NNF Kerala and IAP Kerala, for this opportunity. When Dr. Manoj told us it's going to be a dialogue, both I'm sure Mangala and I were a little, wondering what we are going to do. But I think we have decided to do just what Manoj told us, that is to talk to each other about something which is relevant and recent in preterm care. And therefore now, Mangala.
Hello, good afternoon, everyone. I think nothing is as pleasurable as having an opportunity to chat with my senior and good friend, Professor Suman Rao. We both are from the same institution. If people you don't know, we did our MD both from the institution where I am right now, the Madras Medical College. Yeah, why not? I think, shall we just, even though the topic says that it is about recent advances, we understand well that the major years of the group, this is a mixed group. We do have a lot of nurses here and pediatricians and neonatologists. So don't be worried or about the topic, recent advances. we won't be boring you more with the statistics or numbers. It's more about trying to understand the directions in which the neonatal care is proceeding, and the new areas or domains where a change of practice is happening, or those areas where we still need to emphasize or put our focus more, especially when we talk about care of preterm neonate. Dr. Suman, shall we just take it in the way just like a baby is born? Shall we start something from the prenatal period before the baby is born and then take it along as the baby delivers?
Absolutely. And maybe, I thought maybe if we can get our own personal experience into this recent advances, it would be more worthwhile having us here. So I think both Mangala and I will be talking a lot about what we have been part of more than other recent advances, probably. I please do bear with us on that. Yes, Mangala, we'll start off.
I think we should start with you first. I know that you have been associated with WHO a lot, especially of late, being a consultant with WHO. And I think there has always been a little bit of controversy around this wonderful drug, antenatal corticosteroid. Especially, like there were some studies which made us wonder whether actually whether this intervention, which has been proven to have so much of a benefit in the West, is it the right kind of drug for a country like India? Can it do more harm? So we were wondering. I'm sure that you're part of these wonderful studies which have got recently published. So over to you about your view on antenatal corticosteroids from the Indian perspective.
Yeah, so antenatal corticosteroids is so important that whenever a baby comes into my unit, the first thing I ask my postgraduate, do you have the answer to this question? Has this baby received antenatal corticosteroids? Because that is something which saves lives, improves outcomes, improves neurodevelopment, so it's a wholesome package to improve the outcome of care. But then came this ACT trial, which many of you all may be aware of, which was actually an implementation research. We have something which is so good, but then when we scaled up, they were actually expecting a major decrease in perinatal mortality. But to the surprise of everyone and horror of many, it actually increased perinatal mortality, the ACT trial. And even India, that is the Belgaum site in Karnataka, was one of the sites of the ACT trial. And therefore, everybody, especially public health people, were in a dilemma whether we should scale up ACS, that is antenatal corticosteroids, or no. And that is where WHO came in. And who better than WHO to take up this very controversial topic? And this was a large trial called the ACTION trial. Maybe we could have the slide, Mangala. So this is just published very recently, last month in the NEJM. And this, thankfully, showed us that, yes, there is no doubt that even in low-income countries, even when antenatal corticosteroids is given correctly, it has benefit. And now, why is this so important? Is because in the ACT trial, they even gave it in the hands of, the community health workers and all to give the steroids and then refer. And a lot of babies whose mothers got the steroids were not actually born term. They were born term much later, and therefore probably this was the reason. So now WHO says there are 5 criteria which have to be fulfilled if you want to give antenatal corticosteroids. First is you have to know that the gestational age is preterm. So a good ultrasound is important. Even if you don't have a T1 or T2, a T3 ultrasound is good. The lady must be in imminent preterm delivery. She shouldn't have an infection. And very important, you should be able to give appropriate care. And appropriate care also means CPAP for the preterm who is going to be born. So once we fulfill these criteria and give antenatal corticosteroids, absolutely no doubt that it is beneficial. So the big challenge now for everyone is to ensure how we can scale up steroids, keeping all these in mind. This is the essence of the recent article in NEJM, which is published. I would also like to share that WHO is also looking at the other controversial topic, that is antenatal corticosteroids beneficial in the late preterm? We don't have an answer to this yet, but a large trial is underway. So let's wait for the results of that trial before we actually use steroids for all preterm. Currently, it is mainly for the early preterms less than 34 weeks. Thank you, Mangala, for allowing me to share this experience, which was over many African countries and also India, Bangladesh, and Pakistan.
Yeah, thank you. It's fantastic. It's great to see that we have definite proof now available, that too, especially from a study by WHO. Unlike other interventions like the FEAST trial, even the cooling, the results are yet to come. I think we have done the study. I think it's about the publication should come in a month or two, the HELIX trial. So some interventions don't seem to work well for our kids, but we're very glad that to have a very clear result from WHO that this is an intervention that saves lives and it's very crucial for preterms. So I think just as we touched upon antenatal care, I thought just we'll discuss a little bit about the facilities related to the role of genetics in neonatology, especially the antenatal diagnosis. We know that this is in general, whether it is related to medicine or not, genetics is a field which is just growing in leaps and bounds. Lots of developments are happening in this field. But as far as neonatology is concerned, gone are the times where we are talking only about evaluation. We start thinking about genetics only we see a child with various dysmorphic features. If obviously something is wrong. This fellow has got problems at multiple organ systems, spatial features are abnormal. So something should be abnormal genetically. Okay, but even for such children, the chances of reaching a precise diagnosis has vastly improved now with the advent of recent techniques in genetics. But one other most important domain where a lot of progress has been made is in trying to make sure that the fetus is genetically normal, especially when there are family members or other siblings have had an affected child, and for genetic diagnosis mean what we mean by a prenatal genetic diagnosis. And I think you all should be aware, you'll be aware that more and more actually now we do have non-invasive methods of making this diagnosis. That is the progress that is being made. Because earlier the prenatal genetics is possible only through invasive techniques like doing a chorionic villus sampling or an amniocentesis, which themselves carry a small percentage risk of initiating a preterm delivery or an abortion. But right now, as the techniques of getting a fetal DNA from the mother's blood sample, the free circulating DNA, which can be obtained from the mother's blood, can be used to diagnose important conditions like trisomies, even some targeted, some microdeletion syndromes. It may not be an absolute answer. It is not possible to construct the whole DNA from the amount of circulating DNA, what science is working on it. Maybe that may come tomorrow. But right now, even though we can't just get the whole DNA, for many important genetic conditions, if you want to screen the fetus, it is possible, and it is possible to do this test non-invasively without the risk to the fetus and the mother. That is a big advancement happening. We all know now with even in India, especially centers Chennai, Hyderabad, Bangalore, so many cities or so many genetic laboratories are available. Even at the time of birth, now we do have lots and lots of genetic screening methods available, which includes endocrine and various metabolic conditions as well. And this is very interesting. Again, even though this is not related to the gene of the baby, but it is related to the field of genetics. So we can just try, we are working on, seem to be working a lot on identifying the gene of the bug. Because one of the major problems what we face is that in diagnosing sepsis, our culture results are horribly around 30 to 40%. We get the culture positivities. The rest all are culture negative sepsis. So lots and lots of tests which are based on the genetics of the bacteria are available right now, where within a very short time we'll be able to identify the bacteria, and most importantly, we'll be able to identify the antibiotic resistance pattern. What is the kind of antibiotic which might work against this bug as well. Such wonderful results are available in a matter of hours. That is the beauty of these tests, not even a day. So the turnaround time is less than a day, the various genetic tests for diagnosing sepsis. And lastly, rarely we came across conditions which look very common, like a persistent respiratory distress syndrome, a chronic diarrhea. Don't forget babies with hearing loss, cardiac arrhythmias and cardiomyopathies. So there's lots and lots of scope for genetic diagnosis right now, improving every day. And this is very, very crucial, more so that not only for giving the prognosis from the perspective of the family, where is the finances involved in a country like India, and it is available in India. That is the point that we want to say. Gone are the times where we are taking samples and sending it abroad, waiting for a lot of time to get results. This is available in India with the turnaround time of around 2 to 3 weeks. You should be able to get the results right now. So, Dr. Suman, shall we deliver the baby now? No, from antenatal. Yeah, I think so. I think you are a very again a flag bearer for implementation of delayed cord clamping. So, what is your take right now? Even for we are talking about preterms, there is always a concern about practicing delayed cord clamping. It's okay for bigger babies; people are ready to wait, but they're worried about practicing this when a baby is a preterm. So, what's your view or takes on implementing delayed cord clamping?
So yes, I've always wondered why, if it is good for term, why shouldn't it be good for preterm? And therefore, even in the past decade, we had one of the studies, which is a part of the meta-analysis, where initially we showed that delayed cord clamping is good even for preterms. And then my next question was, if it is good for all preterms, then it should be good for babies who require resuscitation. And why are we keeping them out? How can we do it? So in fact, one of the DM theses we gave was on delayed cord clamping was not possible in babies who needed resuscitation. So can we do cord milking? And I was very skeptical that, you just do this 3 times and that the baby improves. But we had a very small sample size of around 20 in both the groups. But even in that group, we found that there was significant benefit. And so since then, we have been doing delayed cord clamping for all preterms, but for those who require resuscitation, we have been doing cord milking. Having said that, I think it's important that we know that research from across the world has shown that cord milking less than 29 weeks is not good. And therefore, we have changed in our unit that we are now going to be doing cord milking for babies who need resuscitation only for who are more than 29 weeks. And yes, the big challenge is to get the obstetrician to do it. Wait for that 1 minute, which seems so long. And I would love to hear from you, because there are 2 ways of doing delayed, placental transfusion for babies who need resuscitation. One is cord milking of the cut umbilical cord. The other, which sounds even better, is resuscitation on the intact cord. And I know that you have been, you are the innovator man of India, I would say. You have been working very closely with engineers, and I'm sure you would like to share your, what you have been doing on placental transfusion with the intact cord.
Yeah, thank you. So this concept called resuscitation with intact placental circulation. So actually, the idea came to us because actually, going by the principle, all that we learn is that just see the placenta is the main supplier of oxygen and the various nutrients to the fetus. When the baby is having difficulty at the time of birth and the baby is not initiating a birth, there seems to be still a continuous supply of oxygen and the nutrients that is coming from the placenta through the umbilical cord. So if you just clamp the other source also, baby is also not able to take oxygen, baby is not able to start its own breathing. At the same time, whatever supply is coming from the placenta in terms of blood, RBCs, various substance and oxygen also, if it gets cut off. So these babies seem to be at facing problems at both ends. People have shown that actually whenever a baby starts breathing well, and then we go and clamp the cord, that means the breathing has to come, establishment of a respiration has to happen before you start clamping the umbilical cord. This has been shown in animal experiments, even in well babies. There are graphs, you don't have time to go through it. All that I can say is that the first priority is the baby has to establish its own respiratory efforts. Then only we should proceed to clamping the umbilical cord. We do have enough evidence to support this concept called physiological based cord clamping. People call it as PBCC. The challenge in this will be more beneficial in babies who are asphyxiated, as rightly pointed out by Professor Suman. The challenge is in, okay, how do we practice this in a baby? Because the standard recommendation is whenever we think about timing the umbilical cord clamping, we exclude these babies. The moment if a baby requires resuscitation, even now the NRP recommendation is very clear. For a baby who is requiring resuscitation, just do an immediate cord clamping, or maybe as it has been tried by Dr. Suman's group, we do milking of the cord in those situations. It is not possible to wait because the priority has to open up the lungs of the baby. So the challenge, people have worked on this earlier. We came across studies from UK where people have devised equipments which have been specially designed to cater to these needs. But with our resources, we are not able to import such a device. We are not able to buy one also. That's where we worked on starting having our own. This is the device available in the West, LifeStart. One more device has come now. What you see here is a device called Concord. It is from Holland. It's a wonderful, and a lot of work has been happening on this device as well. So this is the device what we have developed with the local help from engineers here. And very glad that after going through a little bit of a piloting trial and all, we have completed a large feasibility trial, starting from babies of 24 weeks of gestation up to term. We have nearly more than 300 babies who have been received on this warmer and had undergone resuscitation of all the various steps, including endotracheal intubation and up to administration of drugs, umbilical venous canalization. And we're glad that this has been accepted for publication in Journal of Perinatology. It should be coming out soon. It has been accepted. We'll be reading this paper. This seems to be a direction. I'm not saying that this will be a standard of care, but we are moving in this direction of trying to practice intactness of the cord and the placenta, maintaining placenta circulation, even in babies who are requiring resuscitation. Why not do this simple intervention in the other cases where they don't require resuscitation, small babies, sick babies, who will get the maximal benefit out of this intervention, practice the delayed cord clamping. I think, okay, apart from this,
and congrats on that, Mangala. I didn't know that. And are you doing this with Phoenix?
Yeah. They were very helpful. They were the technical partners in developing this machine.
So I think that is really good. And I also saw on your slide that there were so many things which are specific for preterms. Maybe we can actually either go back to that slide where you had, you are not only looking at resuscitation and placental transfusion, you're looking at integrating it with T-piece resuscitator, which now we know that 2020 guidelines has said you should consider PEEP when you're resuscitating. And again, oxygen blender and air compressor. So important because in preterms we need the recommendation. You must have heard from Somshekhar in the morning that it is still 21 to 30% in preterm. Resuscitation start with 21 to 30%, but at the same time it's important that we are able to increase it as needed. Only thing I couldn't find on your thing was a pulse ox, so probably you're going to attach that separately. So that's the other thing which is absolutely needed. Moreover, I think we need to have some sort of a cling wrap or any such thing which can be kept on your RIPC warmer so that we can receive the baby on this thermal wrap, because these are the specific things which have been there in the past 5-6 years, but it's reinforced in the 2020 guidelines. And it is important for all the delivery rooms which cater to any baby less than 32 weeks to have this in place. I think that's absolutely vital, and we will wait for your warmer and hope that we can use it soon.
Sure. Because definitely now the last module is an integrated one. This is the latest module which has got even an inbuilt pulse ox. This is the latest version what we have. Yeah. And just to add to what you have said, because wonderfully you have listed the various interventions which are of importance in the delivery room when we talk about care for preterm. And I think in the morning, people would have listened to Dr. Nimbalkar and the various experts about the changes that have been happening in neonatal resuscitation. We don't want to repeat that. At the same time, so I just want to, being recent advances, I thought we'll just show you a little bit some of the devices which seem to be very crucial. And I'm talking about devices which are available right now. Forget about our device, which is more often still in the research phase. So we all know about TP's resuscitator and its benefits. Most importantly, it's very crucial for administration of the positive end expiratory pressure, PWP. People have, we do have even modified ambu bags available with the PEEP valves attached to it. We had concerns about the consistency of a PEEP delivered through such devices. Obviously, they are not the number one choice. This is something like a poor man's TP's resuscitator. But one good thing that is happening to these devices is that even these devices do come with a manometer attached to them right now, where you can just see the bubble, even it's in the form of a mercury or something which is moving up and down, where you see the peak inspirator, a bead, not a mercury, sorry, a bead which moves up and down to indicate what kind of pressures do you reach during inspiration and expiration. So that is seems to be beneficial. And sorry, I think the picture doesn't seem to be very clear. This is wonderful. We do have, from the perspective of an asepsis, even in my unit, I feel that we are not able to practice proper asepsis when we are talking about TPs, because that is a device which is being, just like an ambu bag, when in a hospital where hundreds of deliveries happen every day, sterilizing that equipment between babies becomes a big task, especially when we talk about preterm babies. So this is just a disposable TPs restorator, use and throw. Use a TPs and then throw it. This might be very handy. This is not very costly, not going to cost more than $5,000. Considering the cost involved in the care of a preterm and considering the cost of managing a sepsis in a preterm, I think such devices are worth investing. You would have heard in the morning that now for heart rate monitoring, apart from auscultation or even above auscultation, the most reliable method is an ECG monitoring. But it will be very clumsy to attach an ECG leads quickly in a resuscitation scenario on a baby. So such devices are just like plug and play. This is just like a clamp which is easily just put across the baby's chest, and then this works on the principle of ECG. This is available from Lateral, Neobeat. Such devices are coming up, and the most common problem or the most difficult thing to teach in a bag and mask is always the seal what we make. That is where the most of the problems happen. People failing to sustain the seal, even though they start with a good seal. So modified devices like an upright bag where the axis is straight. So as the bag and the mask are in the same direction, so as there is no tilt. When we use a normal bag and mask, these two are in different directions. So a tilt can happen and it leads to loss of leaks. And the same principle again is used in, this is an innovation from India from AIMS, and where you can use both your hands to have a good seal across the mask. It's a foot operated device, and with wonderful both delivery of PIP and PWP. So all these devices are available right now. Please look for these devices which can be incorporated into your labor room. And don't forget this device that we have done a lot of work on this, but still LMA seems to be a wonderful device for resuscitation. It is being made available, disposable ones, small ones for preterms are becoming available. Maybe I won't be surprised if this device replaces the endotracheal tube in the...
Absolutely. I totally agree. Even we have done, and we have found that even experienced people are able to use an LMA much faster than an ET. I don't know why we are still saying it is, not needed and all in our NRP kit. I think that should change, and we should be training people with LMA. We hardly have another 5 minutes to wrap up, Mangala.
Okay.
So maybe we can just go through a few things. Yeah.
Yes, I think, surfactant, please, just like...
surfactant, maybe now it's more like a, rapid fire. The main recent advances, I would say, is about how to give surfactant. We know surfactant is beneficial, but you don't have to rush in with surfactant. You first start CPAP, and with CPAP, if the FiO2 is more than 0.3, only then surfactant is indicated. Routine intubation is out, even for the smallest of the small babies. And if you can give surfactant with CPAP in place, like the less invasive surfactant therapy or the minimally invasive therapy, that would be good. And a lot of work, including in WHO, is now going on aerosolized surfactant, because the skill of intubation itself is going down. We know that even among our postgraduates, and therefore, can we give surfactant, the aerosolized surfactant, some sort of dispenser with nebulizer, which can do it very well, is what is being seen. So that would be about surfactant therapy.
Thank you. I think just a word on oxygen. We know it is a drug. It can be harmful. It's both good and bad. All that I just want to insist upon is that I think a lot of trials were done, very good trials, but we were not able, despite the availability of such wonderful randomized control trials, the answer remains elusive. We are not sure what is the exactly appropriate oxygen saturation for a preterm neonate. But having said that, that doesn't mean that we should be either be liberal or restrictive in giving oxygen. Right now, just please use oxygen with love, what is called the OWL principle. So keep a saturation target of 90 to 95. That is based on the current evidence. and keep your alarm limits 80 to 88 to 85. And most important, just make sure you avoid saturations more than 95%. And this is again one area, I'm not going into the details, to help this an automated loop of oxygen, just like you don't need to do it manually. The machines nowadays help in titrating this oxygen automatically. Yeah, your favorite area, KMC.
Yeah, this is something I'm really, really happy to share because this has not yet been published, but it's going to come out soon. That is, we used to now do kangaroo mother care for only stable babies. That is going to change with the new trial which has been completed at WHO. And in India, Safdarjung Hospital was the partner. And these things show that as soon as a baby is born, the preterm, even if the baby requires respiratory support or CPAP, we need to keep the mother and the baby together. So zero separation in whole, where this study was a large trial with more than 3,000 participants in Africa and India, which has shown where compared immediate KMC for all preterms versus standard KMC. And in both these groups, the kangaroo mother care was of really high quality with more than 17 hours average in both the groups. So it was not KMC versus no KMC. And the immediate part, when we start early, even for the sick babies, it is able to improve survival much more. Many more lives are saved. And the major thing which reduces is infection, and it improves breastfeeding, even as compared to KMC. So the whole scenario for NICU should be changing in the near future, where it's no longer an NICU, but a MNICU, Mother Newborn ICU. Anyone who is interested in seeing this, please visit Safdarjung Hospital. I'm sure Professor Chelani would be very glad to host you to show off their wonderful ward. And here we really need to partner with obstetricians because they need to come and do rounds for the mothers who are in the MNICU, because you know that sick babies are usually born to sick mothers. So immediate KMC and MNICU are going to be the two new concepts, which is going to ensure zero separation even for our preterm babies. Yeah. Yes,
Wonderful,
Mangala.
wonderful. We were also in the process. We have applied. I hope we get the sanction from the government.
Wonderful. That would be one of the best things to happen to MMC.
Just an extension, just to add, I think this will be the last one that we'll be talking about. So we all know the importance of KMC and the various developmentally supportive care measures, especially when we talk about preterm. But that looks like the ramifications are still even more deeper right now. So people want to, we all know what is a family-centered care, where just, okay, we don't want to cater only to the baby, we need to cater to the mother and the family as a whole. So the designs are nowadays being made where the same room, the mother can be taken care and the baby, and the place for the family also to take rest and be available. We want the family to be there. But now people are moving more towards what they call as a family integrated care, which is an extension of this family-centered care. The only difference is that actually in a family-centered care, the family at the maximum, the mother does only KMC or just helping in feeding. So here, just taking the family along, just like this involves training them. It is a structured training program for the parents and the nurses. So the nurses keep on handhold and teach, monitor, supervise the attenders. They start doing various things like even tube feeding, temperature measurement. So a lot of things apart from just diaper change and doing KMC. So, and they are involved in day-to-day decision making. They are being discussed, especially pain assessment, getting, so this, we all have done this, I think, in a non-structural way. Our mothers have always been our nurses because we don't have people. We always have relied upon our mothers to support us a lot of way. But when it is done in a structured way, they have shown it brings wonderful results. So that is again one direction where we can extend the role of a family involved. That has been shown by even Dr. Naveen's paper. People have clearly shown the more you involve the family, actually the infection rates come down, rather than to the contrary belief, like if you allow more people to come into the NICU, the infection rates will go up. So we can work across. These are, I think, some of the areas that we thought, given the short time limit of 30 minutes, we'll just touch upon certain aspects which might be useful or practically implementable. Over to you, Dr. Suman, for the final words.
Yeah,
I think Dr. Suman and Dr. Mangal, it is time. I think one or 2 minutes you can.
We are done, sir.
Yeah, we are done.
We are done.
Just respectful maternal care making the mother welcome, having her in the NICU, I think is going to really improve the preterm babies' outcomes. In addition to all these great innovations, but for basic level, I think the mother is the one who is going to make a big change in her baby's life. We are done. We respect time. And I know there are some questions on the chat. Probably we will chat back the answers to you all. So thank you all for having us. And it has been great, Mangala, to interact with you.
Thank you. It was great. Thanks NNF for the wonderful opportunity, and thanks Professor Suman.
Thank you, Dr. Mangala Bharati and Dr. Suman Rao. Before handing over to my co-chair, Dr. Srinivasan, my one question to Dr. Suman Rao or Mangala Bharati. We are talking about the LMA, large mass carrier, for a long time, but we are not much using it. What is maybe the reason? Because we are talking means so why it is not very commonly we are not using it.
I'm sorry, I didn't get it. Mangala, if you got it, please.
Yeah, so if I understand right, the question is that what are the reasons why LMA is not
LMA
is not being put into use. The main reason so far has been the availability, first of all, of the device. It is not widely available of the neonatal size, and more so when you talk about babies who are less than 34 weeks or less than 1.5 kg. Even our earlier trials, what we've done, were all done in babies who were more than 1.5 kg. We didn't have a device, and we did not have disposable devices available like an endotracheal tube. In our study, the same LMA was used. It has to be autoclaved. It was a reusable device what we had, and that device only. So now only people have started, because this is a very small area for a manufacturer also to produce these devices in a larger scale. There has to be an usage. But now we do have disposable LMAs available, and LMAs available which can be used for preterm babies also. I think that will pave the way for widespread use. But technically, this is much easier than teaching intubation to somebody. It will work very easily compared to an endotracheal tube.
So can you stop sharing screen?
Yes, please.
And over to Dr. Srinivasan. Dr. Srinivasan from Amala.
Thank you. That was a wonderful, even though the time was very short, it is a wonderful eye-opener from both of you, sir. Especially very glad to know that in our, even in our centers, we are doing so much of good work, such as this RIP, farmers and all. Thank you very much, sir. Thank you very much.
Thank you.
If there's no further questions, we will wind up the session. Thank you, Dr. Suman Rao, and thank you, Dr. Mangala Bharati. And also, I would like to thank NNF State Office Base for giving this opportunity to chair this session. Thank you.
Thank you, ma'am.
Over to Ronnie.
Thank you. Thank you, sir. So now from recent events, we go into the challenges. What are the challenges we face in preterm care? We've got a panel discussion now. I welcome Professor Dr. Babu Francis, sir, to moderate the session. Sir is the head of department of Manjeri Government Medical College. Welcome, sir. So kindly welcome the panelists also. Please unmute.
Am I audible? Am I audible?
Yes, sir. Yes, you're audible. Yes.
So at the outset, I thank the organizers for giving me this opportunity to moderate this session. So today we have okay. Okay, I'm sorry, there was some technical. Okay. So today we have, am I audible? Am I audible?
Yes, sir. You're audible.
Yes, audible.
So after a very brilliant discussion on the recent advances in preterm care, now we come to the challenges we face at a less privileged centers where we are supposed to look after preterms. So we got a lot of deficiencies and how we can improve upon this. So today we have with us Dr. Priya, Associate Professor, Department of OBG. She is an infertility specialist of Calicut Government Medical College. And Dr. Sijayas Pradeep, she has got considerable experience in neonatology. She is Assistant Professor, Department of Pediatrics, Calicut Medical College. And we have Dr. A.K. Jayendran, who is a lone soldier, doing considerable work in neonatology services, working as consultant Neoblast Moylan Hospital, Perindalmanna. And I am really proud to say that Dr. Shabir, or maybe I feel privileged or I boast myself that I am teacher. To Dr. Shabir, who is a consultant neonatologist, Ikra Hospital, Calicut, and Dr. Sumida Arun, consultant neonatologist, Believers Church Medical College Hospital, Tiruvalla. And our own staff nurse, Sindhu PS, she is our backbone of our NICU at Government Medical College, Manjeri. So welcome you all. So at the outset, it is always prevention is better than cure. So it is true for prematurity as well. And Dr. Priya being an infertility specialist, and we have got precious, she's dealing with precious pregnancies. So from neonatology point of view, we would like to have babies as mature as possible. And from the obstetrician side, they want to terminate the pregnancy as early as possible so that they can entrust the baby to us. So how to strike a balance between these two? So with this, a few queries in mind, over to Dr. Priya.
So thank you very much, sir, for giving me an opportunity to present in this neonatology forum. First of all, let me thank all the organizers for giving this opportunity. So I just want to you might all be knowing what are the causes for most important causes for prematurity. So the majority of the cases are due to spontaneous onset of a preterm labor. A majority of the time, we might not even know the cause, what is the reason for the spontaneous labor, and the rest of the causes, the other causes, that is a preterm, pre-viable rupture of the membranes, that comes to around 25% of the cases, and only 30% of the cases are iatrogenic induction of either iatrogenic cesarean preterm or inducing labor, or either maternal or fetal indications. Like maternal indications, most common will be hypertensive disorders, and the most common fetal indication would be an intrauterine growth restriction. So, what are the steps we take to prevent a preterm labor? Of course, like any patient coming with pain, we give the tocolytics. The most common things which we use are progesterone, vaginal progesterone, as well as injectable progesterones are being used. But even then, as we know, our premature rates are at around, say, 10 to 15% of our babies are born preterm. So, what are the steps which we take to protect the infant from the problems of prematurity? Sir, can we have the next slide? So the interventions which we commonly follow in IMCH, which is a tertiary care center, is mainly these things. That is, one is the antenatal corticosteroids. Recently, for the past 1 or 2 years, we have switched over to dexamethasone. So we give dexamethasone sodium phosphate. 6 milligram is given every 12 hours for 4 doses. And previously, what we used to give was betamethasone, that is a betnazole, which contains sodium metabisulfite, or betamethasone sodium phosphate, which is given 12 milligram 2 doses, 12 hours apart. That was the dose which was given. So for the past 2 years, we have been giving dexamethasone most often, that is which is available. And of course, many of the studies show that like beta-methasone acetate, which is less soluble and which gives protection even with a single dose, is maybe as effective as this. That is maybe as effective as dexamethasone or beta-methasone sodium phosphate. But because it is not available, we are continuing with the beta-methasone or dexamethasone. And recently, some studies which I go through had shown that dexamethasone has got some protection, better protection against intraventricular hemorrhage than beta-methasone. But whatever steroids we are using, it should be like the minimum steroid exposure to the fetus, and the minimum dose should be given to protect the fetus. So then for chorioamnionitis, the regime which we are quite following, and it has been proved that giving antibiotics delays the delivery and also prevents all the neonatal complications. So which is the one which commonly followed is we give is ampicillin plus erythromycin. So ampicillin parenterally is given for 2 days. 2 gram is given 6 hourly for 2 days, followed by erythromycin, 250 milligrams 6 hourly for the total of 10 days. So erythromycin, as you know, is not like easily available. Sometimes it is not available. And ampicillin plus azithromycin for 5 days has been proven to be equally effective as ampicillin plus erythromycin. So nowadays we are using the second protocol also. And magnesium sulfate for neuroprotection is also being routinely used. And we have huge experience by using magnesium sulfate in the case of preeclampsia. So it is not a new drug for us. So the dose which we use is like 4 gram is given, intravenous loading dose is given, followed by 1 gram per hour maintenance dose up to 24 hours or till delivery, like whichever is later. That is the common protocol which is followed. And it is said that we need not even continuously measure the urine output or the serum magnesium levels are not required. The patient's clinical status need to be monitored, and the contraindications for magnesium sulfate, of course, has to be ruled out. So that is something which we are routinely following. And for early preterm, like say 26 to 32 weeks, the timing of delivery ideally should be based on ductus venosus Doppler. Like later on, after 32 weeks, we are basing the timing of delivery on umbilical artery Doppler and cerebroplacental ratio. But for early preterm, like 26 to 32, ideally it should be based on ductus venosus changes, and ductus venosus changes precedes the CTG changes. And when the A wave in the ductus venosus, that is, it is either 0, before it is reversed, the delivery would be ideal. So these are the interventions like which we are commonly following at present. Sir.
Okay, thank you, Dr. Priya. And this already now that we have already done, I have just included it. Okay, thank you, Dr. Priya. So we have got time constraint. So we'll move to Dr. Sija S. Pradeep. And here we usually say that well begun is half done. That is very true about neonatal resuscitation. And if you go through NRP or any resuscitation program, everything is within seconds, as if we are like machines. So in reality, many things do not happen within this time frame. And many recommendations really are not practiced in reality. But one thing which I have seen, that by continuous training, we can improve the services in the labor room. So it's the golden principle, at least do not do any harm, is very true about neonatal resuscitation. And probably we know that in those days, olden days, when we never had any protocol for resuscitation, babies survived not because of resuscitation, but in spite of resuscitation. But now we have got evidence-based guidelines to go by. So what are the practical tips how to start the preterm care from the labor room? As I said, well begun is half done. Over to Dr. Sija.
Thank you, sir. Am I audible?
Yes, yes, you're audible. Yeah.
Thank you, sir. A very good afternoon to all of you. So regarding the delivery room management and stabilization of preterm baby is concerned, as we all know that preterm babies are more likely to have additional interventions during birth, and they are more vulnerable to injury during resuscitation during birth also. So that is mainly because they are immature, and for example, they have got a thin skin or decreased subcutaneous fat, which make them more prone for heat loss. They have got poor respiratory effort and immature brain control, which make them more prone for asphyxia. Like that, immature respiratory muscles and lung, which make them more prone for respiratory distress. So like that, they are more prone for all the injuries, and they are at a higher risk while resuscitation. So we have to find a correct balance between the initiation of resuscitation without any delay and avoiding unnecessary interventions. So the management during the initial few minutes, as Sir said, it improves the both long-term and short-term outcome. So can you get the next slide? Okay, so as per we are following the same NRP protocol for term and preterm babies. So we should have an additional resources when you attend a preterm delivery. We have to have some additional things which has to be kept ready during resuscitation, like your plastic cling wrap, as Madam said, and you should have additional preterm bag and mask. A laryngoscope with preterm blades 0. Optionally, we can keep 0. Smaller size ET tubes like 2.5 and 3 millimeter tubes, and smaller suction catheters like 8 and 10. We can keep for all these things ready for resuscitation. An important part of in the initial part is counseling the parents and talking to the parents regarding the, depending on the gestational age of the baby, gestational birth weight, expected birth weight of the baby, regarding the risk factors, long-term and short-term risk, which we are going to face. All that things to be communicated to the parents well before the delivery and immediately after delivery. And during the resuscitation, we are following the same newborn resuscitation protocol for term and preterm babies. And as per the current recommendation, the babies, preterm babies, without having any resuscitation indication, we can practice delayed cord clamping. That is the current recommendation. So the current recommendation does not support the cord milking of the cord at present, especially in less than 29 weeks. And the second important thing is thermoregulation, which is very important, especially in all the preterm babies are concerned. So apart from the usual things which we keep ready for the thermoregulation, like the room which is very warm, close the windows, switch off the AC, all that things. Along with that, preheated radiant warmer, preheated towels, which for additional things like polyethylene bags or wrap has to be ready with the, especially if you're resuscitating a baby less than 32 weeks. You have to receive the baby without drying in the, you have to, you have to cover the baby, especially without drying the baby, and you can keep a hat also on the head so that the baby can, there is minimal heat loss. Another important thing is, that is the most important part of neonatal resuscitation protocol, that is assisting ventilation. The now current recommendation recommends spontaneously breathing preterm babies. With respiratory distress, you can support by early CPAP. That is, you can start with a 5 centimeter of water. And those who need positive pressure ventilation, the indication being same for term and preterm babies, like if the baby is apneic or gasping respiration, if the heart rate is less than 100, you can give PEEP and PEEP using TP's resuscitator with oxygen blender. That is very important, that oxygen blender is also should be there along with the TP's resuscitator. If the
Dr. Sija, what is your, Dr. Sija, can I interrupt? No, what is your impression about the availability of TP's resuscitator in our centers? Like, at least, how do you think it is it important to have it in many centers? We don't have it.
Yes, sir. At present, we in our center and most of the centers, we have TP's resuscitator, but that oxygen blender availability of the oxygen blender is little problematic. So especially if you don't have resource poor settings, like if you don't have central oxygen supply, you can have compressed air along with the TP's resuscitator instead of the blender, and you can use a Y connector and you can titrate the oxygen according to the mixing. So it is actually actually very important, especially the NRB guidelines tells us, especially less than 35 weeks, you have to initiate the resuscitation with 21 to 30% oxygen. To titrate that FiO2, you should have a blender. That is a very important thing. And initially, you can start with an inflation pressure of around 20 to 25 centimeters of water and PEEP of 5, which is adequate for most of the preterm babies. And the latest 2020 NRP, it is not recommending the use of initial sustained inflation more than 5 seconds. So can you just, yeah, this is the picture of a TP is resuscitated. The right side, you can see that resuscitated with the blender. And this is a resource poor settings. You can use this thing. This is a compressed air where you can use the Y connector and you can connect with the oxygen and the compressed air, and you can titrate the FiO2 with this oxygen dial. So can you just show the next? Okay. So if suppose if the preterm baby is having respiratory distress, if in any case you have to intubate the baby, you can administer surfactant also through if the baby is intubated. But the recent recommendation is, as Madam said, we have start CPAP early. So the basic principle is you have to.
So do you think laryngeal mask airway is very handy in a resuscitation scenario?
Yeah,
many of us do not use it, but I think that is very handy equipment which can be used very widely, even at the peripheral centers.
Yeah, especially in the peripheral centers, especially if you have got any difficulty in intubation. So you can keep it as a very handy and it is very useful instrument, laryngeal mask airway. You can use that. The basic principle is that you should avoid excessive pressure during giving positive pressure ventilation and early use of CPAP, and you have to handle the baby very gently also. So another important aspect of newborn resuscitation is important after the initial resuscitation, you have to transport the baby to NICU. So that is another important aspect. So for that, you can use a transport incubator. See, like that, you can see here, it has to be kept in a corner where easily accessible charging and all should be there. And here you can see that for phase changing material of embrace, which is being charged here also. These two modalities, you can transport the baby with a thermal protective environment to the NICU. So once you transport the baby to the NICU, you can continue the ongoing care, that is thermal protection, euglycemic, and you can continue the respiratory support of the baby so that baby can be nursed properly.
Thank you, Dr. Sija.
Thank you.
Now I welcome Dr. Jayachandran, and it's a very important area where most of us ignore, because in late preterm babies, we think that babies are almost mature. So this is a usual mistake which is committed. More often mistakes are made, and it affects the quality of the survival. So over to Dr. Jayachandran.
Thank you, Babu sir, and thank you, NNF Kerala. Hope I am audible.
Yeah, you are audible.
Okay.
Yes.
So, thank you once again and good afternoon. As Babu sir said, it's a very important topic and it's a very challenging area, especially in our situation. Late preterm babies are babies who is born from 34 to 36 plus 6, so 34 to 37 weeks. It's one of the commonest reasons for admission to any NICU school, and the data ranges between 30 to 35%, so roughly 1/3. And I have done twice study with 1 year data of our admissions in NeoPlus, and is matching with 1/3 of admission is late preterm babies. It's a 7-fold increase in morbidity compared to term babies, 7-fold, not the double. So we have to be very careful with these babies. And it's alarming to know that at birth, the brain mass of late preterm baby is only 65% of that of a term baby. And the myelination is markedly underdeveloped, which resulting in significant long-term neurological sequelae even at the school age, especially in academic performance and the other behavioral issues. And another major area to look here is they are born before the pulmonary maturation and hence at very high risk of respiratory distress syndrome, needing different forms of breathing support, including oxygen, CPAP, HFO, or even ventilation. If you are looking at each 1 week extra in the uterus, almost reduces the risk of severe radius by 50%. For example, from 34 to 35, if it is 30%, if you go to 35 weeks, it will be 15%. So 50% reduction for each 1 week of stay in the uterus will prevent severe RDS. So each week or each day is very important. And the common problems of any neonates are much higher. Here we say twice more common. The problems of jaundice, the problem of hypothermia, hypoglycemia. They haven't developed the full immunity yet, and that high risk of neonatal sepsis, and more issues in establishing feeding and gaining proper weight. If you're talking about hypothermia, the single commonest factor in determining the neonatal morbidity and mortality is hypothermia. So in all these parameters, which can cause problems to a newborn, is much, much higher in late preterm babies. And if you are looking at readmission rates, it's almost 3 times higher compared to a term baby. That's a very important problem. Next slide, please. So what we can do about it? The whole topic, we have to do at least 30 minutes talk. I'm just mentioning the nutshell solutions here. The most important thing is avoiding elective delivery or LSES before 39 weeks without a definite indication. So the indication shouldn't be a soft indication. It should be a medically valid indication agreed by the obstetricians and the pediatricians or the neonatologists. Okay, they're not simple babies. They're not just the miniature form of a 3 kilo baby, because according to the parents, it's just 500 gram less or a few 100 gram less, and that may be sometimes the same perception by the obstetric teams. They're very tricky babies. They are at risk of multiple neonatal problems, which need more attention, more care, more input by the pediatrician, neonatologist, even by the nurse. Many of these babies are born in level 1 centers where the attention may not be as good as we expect or supposed to be. Many such babies need short-term admission to NICU and SCUBA. So we should be telling this very clearly to parents and also to obstetricians. In my hospital, I done 2 sessions with our obstetricians, about a 1-hour session just to talk about preterm babies. And still, we have reached the ideal situation yet. So it needs more education and more message to spread to our colleagues. Increased awareness need to be with obstetricians about the morbidity and including the mortality, and we need to involve in good counseling to family. In our center, all the preterm, including late preterm delivery, I will counsel them before taking to theater unless it's an emergency situation. Because I have to tell them that these babies may need admissions at least for a short period and need immediate newborn care. Because they shouldn't be thinking that baby is 2.2, they're straight away given to mom. And we don't want to separate baby and mom, but many of these babies need actual care. And always regarding the antenatal steroids, we know it's very indicated less than 34 weeks, between 34 to 36. Also studies are done, even though American Society recommended it, I say it need to be taken on an individual and case-by-case basis, considering the benefit and the risk of steroids. All this baby need immediate follow-up soon after delivery. Even if they cannot come to your center, you have to advise them to go and meet the pediatricians available near to their home. It need to be seen after a couple of days, and also definitely they need to be seen by between 10 to 14 days to make sure that the weight gain, feeding, and jaundice, all these issues are looked into. They will need long-term follow-up. We all are good at having long-term follow-up for extreme premature babies, but all these babies need long-term follow-up because studies have shown concerned school performance, concerned with their respiratory problems, especially asthma needing medications. The respiratory and neurological morbidities are prolonged even in their childhood. So they all need long-term follow-up. And the single solution for all this is to have a strong perinatology forum with obstetricians, radiologists, neonatologists sitting together and have a clear action plan in our state. Thank you.
Thank you, Dr. Jayachandran. Now we move on to Dr. Shabir. So here in neonatology, compared to adult ICU, NICU is different, that you are deciding a future, not just an individual. Or maybe you are right in saying that you are treating for generations. For example, if you make a good quality survival for a female baby, that female is going to give birth to a healthy child. So by treating or with an outcome, aim of our outcome should be a quality outcome that has got implication for generations to come. So now we have so many problems associated with the prematurity, and two important areas are, one is BPD, other one is ROP. So now older generation, we dealt with old BPD. Now the new generation neonatologists are facing the what is known as the new BPD. So with this, like we'll have some more insights to these issues, how to prevent this in the first place from Dr. Shabir. Over to Dr. Shabir.
Thank you, sir. Good afternoon to everyone. As all of you know, the neonatal intensive care and the general supportive care in the field of neonatology has improved a lot in the past few decades, especially in India. So we are seeing a lot of new problems in the neonatal neonates who are surviving the NICU stay. So the two important aspects are, one is BPD and another one is ROP, and both these issues are considered as a quality indicator of your level of care. So if you're giving good quality care, the more and more premature babies are supposed to get survived, and on parallel to that, you will expect to see more of these complications, and your aim should be to minimize these complications. In fact, you may not be able to avoid it entirely, but you should try to minimize it. So BPD is one condition in which you cannot treat the BPD once it is fully established. The more focus is on its prevention. So there are a lot of factors which can predispose these premature babies to develop BPD. So as Priya ma'am initially told, the obstetrician has got a big role in preventing BPD. Actually, the biggest risk factor for the BPD is the prematurity itself. So anything which you can do to prevent premature birth will in turn prevent BPD. So the prenatal interventions, like the interventions to prolong the pregnancy whenever there is an imminent preterm labor, such as tocolytics and antenatal steroids to improve the lung maturity, will in turn surely reduce the incidence of BPD. When you go to the studies, you may not find that with the use of antenatal steroids, there may not be much reduction in BPD. That may be due to the better survival of more and more premature babies. So when you look at the statistics, you may not find it very significant. Even if you give steroids, there may not be much of difference in the incidence of BPD, but it's actually due to the better survival of more and more premature babies. Another important aspect is the proper identification and treatment of chorioamnionitis. All these inflammatory mediators are supposed to have a big role in the development of bronchopulmonary dysplasia. So the prompt identification and treatment of chorioamnionitis with appropriate antibiotic is of great importance to prevent the development of BPD. After birth, even the delivery room itself, you should consider this disease, and you should try to prevent the BPD in future. So you have to use appropriate resuscitative measures like adequate PEEP and appropriate PEEP when you resuscitate the baby whenever they require a positive pressure ventilation, and you should consider early delivery room CPAP. So you have to prevent the lungs to go for atelectasis, and if you start delivery room CPAP appropriately, many times you can prevent intubation and mechanical ventilation. So in that way, it is of paramount importance to start the delivery room at the right point. And whenever the baby is having distress, and baby is a premature baby, you should consider CPAP sufficiently early. When it is fully developed, the RDS, afterwards, if you start CPAP, they may tend to have more severe disease, and they might most likely require intubation and mechanical ventilation. So similarly, when the baby is on CPAP, and if baby's FA2 requirement is more than 30%, you should consider surfactant treatment sufficiently early. This also, when you do it late, the effect is not much, and baby might require intubation later and might require prolonged mechanical ventilation. So you'll have to use it, whenever indicated, you have to use the surfactant in the right moment. That is at least within the first 2 hours of life. And whenever possible, you should try to avoid mechanical ventilation altogether, but that may not be possible. Many of the babies who are stabilized on CPAP might eventually require high FiO2, and we may have to resort into mechanical ventilation. But as far as possible, you have to try to avoid it. And whenever your baby is on mechanical ventilation, you should always consider to minimize the duration of mechanical ventilation. So you should always assess the baby for readiness of extubation. You should try to minimize the ventilation as short as possible, and ideally you should try to minimize. You should try to extubate babies within 72 hours, if at all, if possible. And regarding the surfactant administration, there are a lot of evidence which are coming up in the past decade that whenever possible, you avoid intubation altogether when you are giving when you are administering surfactant. The newer methods like less invasive surfactants and aerosolic surfactant are all having are showing the lesser chance of BPD when compared to the traditional way of giving surfactant by endotracheal intubation. So you have to consider that as a priority in the next few years. And there is some hope in the non-invasive ventilation. Altogether, whenever the baby requires mechanical ventilation, considering NIV as a bridge to intubation, the studies are having some mixed results. So, whenever possible, you should resort to NIVs, that is CPAP, NIPP, or HFNC. And when you compare these three different modes of non-invasive ventilation, the results are often mixed. So you can consider CPAP and HFNC as a primary mode of respiratory support is showing more chance of failure, and there is more chance of intubation in HFNC group. So as of now, CPAP or NIPP you can consider. HFNC is as good as CPAP for post-extubation care, but not as a primary mode. And you should definitely have an oxygen targets. From the large neoprom studies, we now know that the most likely the babies will be benefited from preterm babies will benefit from saturation targets of 91 to 95%. So you should strictly implement this. We know the theory, but we should make sure that it is being implemented, and your nurses know the targets and they are following it. So that is the most important part to prevent the oxygen free radical mediated injury and the later development of BPD. And coming to the ventilation, mechanical ventilation per se, now it's the era of volume targeted ventilation. You should not use ventilator mode other than the volume targeted mode in the conventional ventilation. So you should always make sure that you are using volume targeted ventilation, and that tidal volume you have to set appropriately. So for each gestational age and weight, there is a set tidal volume band, and you have to use it correctly in order to avoid the volume trauma and the resultant BPD. And there are some studies which says that the HFOV may be beneficial in BPD. That is mainly there are differences between the individual units. There are certain European countries they are using HFOV as a primary mode, and they are having there are some studies which shows that HFOV as an initial mode may be beneficial in preventing BPD, but with most of the other part of the world, we are using conventional ventilation as an initial mode and HFOV as a rescue mode. So still we need larger trials to make a final conclusion on that. And postnatal nutrition and growth are another important aspect. The studies have consistently shown that whenever there is a postnatal growth restriction, that is extrauterine growth restriction, there are more chance of BPD. So you have to correctly monitor the growth of the babies, and you have to make sure that they are having they're getting adequate nutrition from the day one itself. That you have to have an aggressive total panel nutrition or parallel nutrition approach in the initial days, and then as quickly you have to convert into enteral nutrition, and you should have an aggressive enteral nutrition approach also. And judicious and moderate fluid restriction may be beneficial in preventing BPD. And the role of PDA, the early PDA treatment might reduce the need for prolonged mechanical ventilation, but studies have not shown consistent results with the PDA treatment and the BPD incidents, but that is maybe other confounding factors may be there. So the treatment of hemodynamically significant PDA should be considered at the right time. And coming to the postnatal steroids have been tried as a preventive as well as a treatment modality for BPD, and the results were always mixed, and we have concerns over the neurodevelopmental outcomes when we use steroids, especially when we use dexamethasone in higher doses. So, but some recent trials like Premilox trial have shown that the early use of hydrocortisone within the first week of life, if you start it, that might result in better results as far as BPD is concerned. There are less BPD in that group, and even some follow-up studies have shown that they have got a better neurodevelopmental outcome when compared to those who have not received the early steroids. So the early low dose hydrocortisone is having some hopes regarding it, but in other cases you may have to individualize it. The late treatment with the dexamethasone, you may have to individualize it. And regarding caffeine, is again has shown that the early use of caffeine, that is within first 72 hours, if you use caffeine, that has resulted in lesser BPD. So caffeine has multiple actions. It reduces the chance of apnea, and it may reduce the days of mechanical ventilation. It has other actions like a diuretic as well as anti-inflammatory action. So that might also cause a lesser BPD in the, whenever you use it sufficiently early. And vitamin A, it's been there in the textbooks for the past few decades, but actually the studies, the evidence is not very strong, and only a modest influence also only we expect when we give vitamin A. So still you can try it. And infection prevention, the inflammatory mediators are the biggest threat for the neonatal lung. So infection prevention and all the strategies, you know, that the adequate hand washing, having a dedicated antibiotic stewardship program, and all those things are of importance to preventing BPD. So can I have the next slide? So coming to the next condition, that is prevention of ROP. Most of the strategies which are implemented for BPD prevention holds true in the ROP prevention also, that is prevention of premature birth. The evidence of antenatal steroids in preventing ROP is many of the trials have not studied this aspect as such, but since antenatal steroids will increase the survival of more and more premature babies, the reduction in ROP per se by the steroids would have counterbalanced. So we may, in the studies, you might not find the difference, but still it might have some role. And similarly, the surfactant also, whenever you use early surfactant, the more and more premature babies would survive. And so in turn, you will have more and more babies with ROP. But actually, it might be beneficial, but in studies, you may not find such a result. And as in PPD, the strict regulation of oxygen supplementation and oxygen targeting is of paramount importance. You have to prevent both hypoxia as well as hyperoxia. In the past few years, you have a lot of papers on intermittent hypoxia in UNICE uses. Previously, we did not give much attention to this aspect, this problem, and that intermittent hypoxia has shown that it is another risk factor for ROP. So we know that both hypoxia and hyperoxia will result in ROP, so that both should be avoided, and you should act immediately whenever there is hyperoxia or hypoxia. And postnatal nutrition as in BPD, it is of paramount importance in prevention of ROP. Whenever baby is having extrauterine growth restriction, that baby is at risk for developing ROP. So you have to optimize their nutrition, and you should monitor their growth appropriately. And prevention of infection as in BPD, it's again it's a risk factor for the developing ROP. And the most importantly, you should have a screening protocol, you should have a unit protocol for screening ROP. When you follow the Western guidelines, you might not screen many babies. We know that in low and middle income countries, more and more mature babies, that is late preterm babies, are also at risk of ROP. So you should follow the Indian guidelines. We have an NNF guideline for screening and early treatment of established ROP. Whenever there is a ROP which requires treatment, it should be treated promptly. Otherwise, it will result in severe complications like retinal detachment, and that might result in a permanent blindness. And even the pain management is also important for ROP prevention. Whenever you are not addressing this issue, baby might likely to experience more and more hypoxic episodes during those procedures. So you should think of the pain management also as a part of ROP prevention strategies. Thank you.
Thank you, Shabir, for the elaborate highlight on this. Now we come to Dr. Sumita Arun, consultant neurologist, Believers Church, Medical College Hospital, Tiruvalla. We often, like, if you see the literature, we find the survivors, say 23 to 25 weaker, extreme preterm, very extreme preterm babies. If you see the developmental outcome of those babies, around 50 to 60% have got some sort of neurodevelopmental disadvantage. So a country like ours, probably we can't afford to have this many babies surviving with the poor neurodevelopmental outcome. And another aspect of in our country is, as a developing country, so our preterm babies, the incidence of the small for gestational age among the preterm babies is around 7 times compared to the developed countries. So we have got so many additional, as Dr. Shabir said, we have got additional risk factors for ROP. Babies being born with small for gestational age. So they have got additional risk factors. And they have proved that, even our own studies, that the preterm babies who are small for gestational age, they have got worse neurodevelopmental outcome later. So we should strike a balance between a leave to nature attitude on one side and other side, a robotic type dehumanized approach. So we have to strike a balance between these two. So how the developmental outcome we have to improve, what we have to do for quality improvement. So not just survival, but quality survival is important to us. And many of the studies who are addressing the neurodevelopmental outcome by various scales which we employ. And you may find the incidence may be deceptively lower. That is, less number of babies, less percentage developing neurodevelopment, abnormal neurodevelopment. But if you do the study again when they start abstract thinking and all by age of 12 years, you find these children, when they grow up, they can have subtle intellectual disabilities. So in fact, the real incidence of neurodevelopmental disadvantage is really much more than what is in studies. So it is very important to have a neurodevelopmentally supportive care during the in your nursery stay. So over to Dr. Sumita Arun, how we can reduce or improve the quality survival, but by improving the neurodevelopmental outcome of these small babies. Over to Dr. Sumita.
Thank you, sir. Am I audible, sir?
Yes, yeah, you are audible.
So definitely most NICUs now have intensivists who are always on the go. So they have their skills, they have their equipment, and they're all set to save their tiny preemies, like you mentioned, or the critically ill infant. So I don't think skill is the one factor that needs to be questioned anymore. And definitely there is a lot of focus on intact survival than just survival. So can I have the next one? So the NICU environment is definitely intensely rich in different sensations. You can see the tiny baby, a lot of things going wrong right there. If you look at the baby, the picture definitely does not show too many ideal things right there. If you look at the baby, there are a lot of interventions happening with respect to the ET tube or with respect to the lines that has been secured. So even though the first picture looks very dramatic, like it says 11 on a pain scale of 0 to 10. So even though it sounds very dramatic, it's fairly safe to conclude that this preemie or any preemie for that matter in any NICU who was sick and required a lot of NICU interventions undergoes a lot of pain while they are in the NICU. So definitely pain is a factor that needs to be addressed. Coming to the procedures, as already mentioned, a number of procedures that we tend to do, whether it's with simple procedures like heel lungs, venipuncture, securing lines, securing the ET tube in position. An average of at least 15 procedures these babies do undergo during their NICU stays in the first 7 days. That's what the studies show. So next one. And because we are all set on the saturation that needs to be achieved, we're all talking about 91 to 95% saturation. So we're very proud of setting our alarm limits. We teach our nurses to set alarm limits. So there is no shortage or no dearth of sound in the NICU. So whether the sound is going to come off your pulse oximeter or the warmer because the probe has gone off in the servo mode, or because of the minute ventilation settings that you have set on your ventilator. So a lot of sounds coming off the different machines that you use in the NICU, not just the machine, even from the personnel or the healthcare providers. And of course, feeding, there is nothing very natural about giving a baby IV fluids, TPN, whether it is aminoven or lipid, nothing very natural or beautiful about it. But under the setting that we do have, this is the best that we've realized that we can do. So it's fairly good or fairly certain to conclude that in the NICU, the babies do undergo a lot of stressful things, which needs to be addressed in addition to our focus on saving their baby with all the skills that we've managed to acquire. Next slide, sir. So neuroprotective strategies definitely needs to be adopted. And I think over the course of the day, we've listened to most of the neuroprotective strategies. So I'm just going to list them like that. Whether it is the use of antenatal corticosteroids, magnesium sulfate, the use of antibiotics in mothers who had PPRO, mercuriamnitis, the proper delivery room management, using gentle ventilation, early nutrition, proper TPN use, the use of caffeine. So these are the neuroprotective strategies that can be used to improve neurodevelopmental outcome. And developmentally supportive care is just one tiny portion, but a very relevant portion, I would think, of the neuroprotective strategies that we can use. Pain, as I mentioned, it is important to identify to address it and to treat it. So important to have a valid assessment tool, a validated tool that you use in the NICU, whether you want to use the PIP score or the NIP score or the CRICE, whatever is the score that you're comfortable using. It is best to have a policy which says that in the NICU, I use the PIP score, and a written down policy which says that if the score goes above a certain number, say it goes above 6, I'll start using non-pharmacological measures. And if it goes above 12, I'll start using pharmacological measures. So if you have a written down policy, and if you can score it, and if you can train your staff to score it, say once every shift, this problem can be addressed. And of course, for sustenance, it is good to have a nursing pain champion who will take it up as a project to make sure that this procedure, this practice is sustained. As we know, pain can lead to adverse neurodevelopmental outcome. It can also alter their pain thresholds for later life. So that is again a very important parameter that we need to address. Sleep is something that we need to protect. So it's good to cluster the care that we provide. There is no point in going every half an hour and poking the baby or trying to put the NG tube down the baby. So it's good to cluster care, good to plan your day, and good to be cube based rather than protocol driven. So rather than going by the doctor's order in order, it might be good to assess the baby's behavioral state, wherein as the baby gets more wakeful, let's respect the baby for being more wakeful and provide care during that time. So you can developmentally support their activities of daily living. KMC, again, I'm sure most NICUs practice KMC. So if the question is, do you practice KMC? Absolutely, yes. That's the answer that we'll all come up with. But again, it's good to practice quality KMC. So whether it is with respect to the duration. So like ma'am was saying, some of the studies have shown 17 to 21 hours of KMC. So even though that does sound very high offhand, but at least it's good to increase your duration of KMC than to say that I give KMC twice a day, 1 hour per day, and I'm done, and that's my protocol. So the duration of KMC is important. The IKMC trial result, as ma'am was saying, that also sounds very interesting. As of now, what we're doing is 1 to 1. When the babies are stable, that's when we start KMC. That's what the recommendations are based on. So IKMC, like ma'am was saying, is between 1 to 1.8 kg, where they're starting it right away. So it is good for us to just watch where the literature is going, either read up on literature or attend these workshops that are conducted, or just follow ma'am or the leaders in the field so that we know what to do and we can keep up. And of course, the healing environment. So like I was talking, there is no shortage of alarms in the NICU at all. And once your NICU grows bigger, you get more jaded about it. And you're like, yeah, alarms are corrugated, and you don't really react to all the alarms. So there's something called alarm fatigue that happens. So quite a few QIs that I came across on alarm fatigue, which I thought was very interesting, and probably a very good study if we can design something like that, and it will be very useful also if we can address alarm fatigue, whether it's because of the inappropriate settings that we used, or it's because the nurse did not respond, or the healthcare professional for that matter did not respond, or was it a machine malfunction. So those are things that you can address in the QI and make some difference. So any average NICU has a sound decibel between 60 to 100. So even though the recommendations would tell you something like 45 decibels, very easily you will clock above 60 in the NICU. And even for the lighting, very clear recommendations on what the luminance must be at, but even a simple procedural light shoots up on where we must be. Cycling of lights are definitely better than to have continuous bright lights, but I don't think too many ICUs use continuous bright lights anymore. So if we can help it, it's good to cycle lights and try to achieve that near dark aquatic abode that the baby was supposed to be. And we've pulled the baby out any which ways and exposed the baby to a lot of sound and noise. The least we can do is probably cycle lights. And of course, family centered, or like Mangala sir was talking about family integrated care. So even in the universal model, the baby is at the center of it all. And I think for all of us, the baby is definitely our prime focus. So we would place the baby at the center of everything for sure. And then for some reason we put ourselves. So if you have a baby who's about to deliver, the questions are how preterm is the baby? Can the baby make it? How good are the Dopplers? What is the growth like? Any anomalies? So if you think your baby can make it, you give a thumbs up and you say, okay, let me go ahead. And the next question you often ask yourself is, are you capable of dealing with it? Like, are you as a person or as a unit or as a team, are you capable of dealing with it? That's often the second question we ask ourselves. So very nicely in the model, it has been very clearly put as the baby in the center, the family around the baby, around the microenvironment, and we as healthcare providers, we're just around that. So our job is just to support and not to become the hero in the story. So next slide, sir. So coming to evidence about developmentally supportive care, I don't think this is the most easiest intervention to study, because there's so much of heterogeneity in it. There are like 10 to 20 parameters that you can enlist to study this intervention, and to prove that it has benefit in neurodevelopmental outcome is a bit of a challenge. There's a whole bundle of interventions right there. But even then, there is a decent body of evidence which says that it does improve motor outcome as well as cognition at around 2 years of age and even till preschool. Not too much evidence after towards the school age, but then I guess that's the story of neonatology. So thank you, sir.
Oh, thank you, Dr. Smita, for elaborate this thing. And I think that's the most important area in the NICU, which we are not much bothered. As Dr. Sumita said, the alarms, it's a usual thing. Use pulse oximeter alarm, warmer alarm, all alarms sounding, and we tend to ignore those. And we may ignore the desaturations. And as Shabir put it, the frequent desaturations can be very detrimental. And I remember one of our family friend, one professor of English, he used to sing English poems like even Shakespeare and Keith, Wordsworth, and like for his newborn. So people were really making fun of him for reciting very correct English pronunciation with the poems. What is the use? But now we know that the more language interaction with the baby, in preterm baby, in the NICU, in the newborn period, can have better language acquisition at 18 months. There are studies proving that. So we should encourage the mothers giving kangaroo care to softly speak to the baby in good language, sing to the baby. Those things are very important. And before any procedures, the nurses, as rightly she said, like nurse pain champion. So really nurses are the champions in the NICU. So we bank upon them. So they are the backbone of NICU. So now over to Ms. Sindhu, our neonatal nurse. Hope she's there. Sister? Sindhu. Yeah, okay. You can start.
Okay, sir. Thank you, sir.
Audible,
sir?
Yeah, you are audible.
Okay, sir. Thank you, sir.
Okay.
Preterm babies facing main problem is thermoregulation. Hypothermia is the main challenge in our preterms. Due to lose more heat due to large surface area, so cause hypothermia. They have subcutaneous fat is less. They have also less brownie fat. So we can
കാണുന്ന പ്രോബ്ലം ആണല്ലേ സിസ്റ്റർ ഇത് നമ്മൾ എപ്പോഴും ടെമ്പറേച്ചറിന്റെ കാര്യം പറയും വലിയ ഹൈടെക് കാര്യങ്ങളൊക്കെ ഉണ്ടാവും പക്ഷെ ബേസിക് കാര്യങ്ങളിൽ ചിലപ്പോൾ വീഴ്ച പറ്റാറുണ്ട് എനിക്ക് തോന്നുന്നു എനി ന്യൂബോൺ കെയർ ഏരിയ with a lot of equipments, lot of personnel, this is one area which is usually left out, the temperature maintenance. Often we find, especially in bigger like government sector where we have got less personnel to monitor. So commonest arrow. ഇല്ല സിസ്റ്റർ അങ്ങനെയല്ലേ ടെമ്പറേച്ചറിന്റെ പ്രോബ്ലം അല്ലേ കൂടുതലുള്ളത്
temperature problem is main. Sir, next slide, sir.
Okay, continue.
Managements from delivery room itself maintain the temperature. While transporting the preterm baby to NICU, it is very important to keeping the baby in cling wrap and use incubator, thermal mattresses. The cling prevent the evaporative losses of heat. Positioning of probe vital to prevent hypothermia and hyperthermia. Check temperature at each shift. Keep the baby in a polythene, plastic bag or cling wrap. Then provide nesting and swaddling is very important to preterm care.
നമ്മളെ സിസ്റ്റർ ഒരു ടച്ച് ചെയ്ത് നോക്കുന്നതല്ലേ by manually seeing the temperature, is it not important? Because sometimes you find the warmer may be malfunctioning. So you may see some readings, but the warmer may not be functioning properly. നമുക്ക് അതും കാണാറുണ്ട്. So you need not blindly believe the whatever is displayed. You have to clinically assess by touching the baby occasionally, and you have to record the temperature also occasionally, manually.
Sir, next slide. That is the second problem is sepsis. In our NICU, hand hygiene is the most important aspect of preterm care. Before all procedures, follow aseptic non-touching methods are following here. Then starting men as early as possible reduces the risk of sepsis. Avoid formula feeds. can prevent NEC and initiate EBM as early as possible. Practice minimal and gentle handling of preterms. Provide exclusive breast milk to prevent NEC.
നമ്മള് എക്സ്ക്ലൂസീവ് ബ്രസ്റ്റ് ഫീഡിങ്ങിന് സിസ്റ്റർ എന്തൊക്കെയാ നമ്മൾ അവിടെ ചെയ്യാറുള്ളതെന്ന് പറഞ്ഞാൽ നമ്മള് എക്സ്ക്ലൂസീവ് ബ്രസ്റ്റ് മദേഴ്സ് മിൽക്ക് ഈസ് ദി ബെസ്റ്റ് ഫോർ ദി ബേബി. സോ വി യൂസ് ടു സ്ട്രൈവ് ഫോർ മേക്കിംഗ് ദി മദേഴ്സ് മിൽക്ക് അവൈലബിൾ ടു ദി ബേബി. അപ്പൊ നമ്മൾ എന്തൊക്കെയാ അവിടെ ചെയ്യാറുള്ളത് ജസ്റ്റ് അവിടെ എന്തൊക്കെയാ നമ്മളെ പ്രോബ്ലംസ് മദേഴ്സിനെ നമ്മൾ
Secondarily, squeezing and press and release method to encourage a press and release method.
നമ്മളെ ഫീഡിങ് എസ്റ്റാബ്ലിഷ് ചെയ്തിട്ടാണ് അവരെ നമ്മള് മദർ സൈഡിലേക്ക് വിടുന്നത് ബേസിക്കലി. ദാറ്റ്സ് an important aspect. So the family centered care means they should be safe when we discharge them home. കാരണം നമ്മളിവിടെ പലപ്പോഴും കാണുന്നത് they come back in a moribund condition from home. That means they are not primed to the ongoing care of the small babies. So these babies, because we can't keep the baby for so long in a government setting, so babies are being discharged. So at home they have to be cared for. So they have to be equipped properly. They have to be trained properly to look after these small babies at home. അല്ലേ? അത് സിസ്റ്റർക്ക് ഫീൽ ചെയ്യാറുണ്ട്. പല ആൾക്കാർ കുട്ടികളും പിന്നെ വളരെ സിക്കായിട്ട് നമ്മുടെ അടുത്ത് തന്നെ വന്നിട്ടുണ്ട്. CPAP ആണ് വേറെ ഇമ്പോർട്ടന്റ് ഏരിയ നമുക്ക് പ്രോബ്ലം ഉള്ളത്.
Select appropriate size of head cap and prongs. Ensure correct position and fixation of the nasal prongs with tegaderm or velcro tape. We are using Hudson prongs is more convenient for us. Clean the nostrils with the saline drops every second hourly and suction the secretions. Ensure patency of the prongs. Avoid pressure on the columella. Prevent injury to septum by ensuring a gap between nasal septum and columella is 2 mm. FiO2 is adjusted to maintain the saturation 90 to 95% and keep the saturation 90 to 95%. Remove condensed water in the respiratory circuit. Maintain humidification chamber heat at 37 degrees Celsius.
വേറെ ഏരിയയിൽ നമ്മളെ നഴ്സസ് ചെയ്യാൻ കഴിയുന്നത് FiO2 സ്ട്രിക്റ്റ് കൺട്രോൾ ആണ് ആൻഡ് ടു മെയിൻറ്റെയിൻ ദി target saturation. And as the baby matures, the target can be slowly increased to 95. So that should be our aim. So 90 to 95 means the younger the baby or the first day, probably you target 90, and slowly as the baby matures, you can slowly build up the target to 95. So it is very important to avoid frequent desaturations to keep the saturation within that safe interval of 90 to 95. So that is an important task with the neonatal nurse. Okay. Feeding,
less than 28 weeks baby, parenteral nutrition initiating. 29 to 31 weeks baby, orogastric feeds, EBM as giving. 30 to 34 weeks baby, pallidary feeding, EBM is giving. More than 34 weeks baby, direct breastfeeding establishing. The next point is feeding intolerance. Abdominal distension, vomiting, and increased pre-feed aspirate more than 25% as noted as feeding intolerance.
And we monitor the abdominal girth measurement also. We take abdominal girth measurement.
Yes, sir. Abdominal girth measurement 2 centimeters.
Okay.
More than the normal size.
Okay, sir. Thank you. Thank you all panelists. Okay. So we are, I think, number time and day and so thank you for all the panelists. So there is nothing much to conclude because in fact all the roles were in fact conclusion. We did not elaborate on one point. So the take home message is it is important to prevent prematurity in the first place because we are not as a well equipped to look after especially preterm babies. Okay. എന്താ കേട്ടില്ല?
Nothing. It was just an error, I think. By mistake, I didn't സംസാരിച്ച.
ആയിക്കോട്ടെ. അല്ല ഇനി എന്തെങ്കിലും interaction ഉണ്ടെങ്കിൽ you can interact. Can ask anybody has got any doubt or anything to share. They can come up.
I think we need to wind up this session. We're already running too much late.
Yeah, too much late. Okay, thank you. Thank you once again. We'll wind up the session.
Thank you, sir. Thank you. So now coming up to the penultimate event of today's talk, we have a quiz, All Indian Nurses Quiz. I call upon Muriliraj sir, the quiz master for today. He will introduce the rest of the talk. Thank you.
Yeah. Thank you. Thank you, Ronnie. Thank you, Ronnie. Very good afternoon and welcome all of you to the most awaited program of today. That is the All India Nurses Quiz. Actually, we are running out of about 2 hours late. We are supposed to start by 1:30. Now it has reached about 3 or 3, more than 3. So I have added all the participants into the panelist group. And the outset, I'd like to welcome my judges, Dr. Devendra Verma from Mother Hospital Thrissur and Dr. Tony Mamballi from Lisi Hospital, I think, yeah, Lisi Hospital, Kochi. I think Tony sir is there.
Maybe I've been.
Yes, sir is there. Yeah.
I am here. I can hear, but my picture is not seen.
Oh,
yeah. Thank you.
Right.
Thank you.
Now it's there.
No, yeah.
Yeah.
Fine,
Yeah. Now you are seen. Now you are seen. Yeah. Now I would like to welcome Dr. Manjusha, who is the quiz coordinator. She'll be keeping the scores and she'll be announcing the scores also. And in the last, but not the least, I would like to welcome my co-quiz masters, Dr. Anand M.R. from MIMS Hospital, Calicut, and Dr. Anand N. from KIMS Hospital, Trivandrum. Dr. Anand M.R. is there. I am not seeing Dr. Anand N. Dr. Anand, KIMS, Trivandrum. I think, yeah. Yes. Both of the mask you are there. Okay, fine. So, Manjusha, are you ready with the scoreboard, everything?
Yes, sir. Yes, sir.
Yeah. And I will call out the names of the participants. Sister Harida TK, participating as Ikra Hospital. Is there? Harida, Ikra Hospital. Not there, huh? Yeah, Team Ikra is there. Unmute yourself.
Yes,
Team
sir.
Ikra, please. Yes. Shanti Hospital. Yeah, it is there. Febna TC. Febna. Yes, it is there. Maisha is there. Maisha.
Yes, sir.
Yeah, Maisha is there. Yeah. Christina.
Yeah, hi, sir.
Christina is there. Yeah. Regila V. Regila.
Yes, sir.
Yes, you are there. Okay, fine. Okay. We have 6 teams, and as I have already communicated earlier, we will be conducting this quiz competition in the Zoom platform. Okay. There will be 6 teams, and there will be 5 questions. Sorry, 5 rounds. And in the first 2 rounds, it will be a single response round. And each question in the single response round will carry 10 marks. Okay. If you are not able to answer the question will be carried to the next team. If team A is not able to answer, it will be carried to team B. If team B is not able to answer, it will be carried to team C, like that, in the first 2 rounds. And third round is a multiple choice question, and you will be given the question and 4 options will be there. You have to select one of the option. And these questions will not be carried to the next team. Okay. And the 4th round is a visual round. If you are not able to answer, it will be carried to the next team and the mark will be 10 marks. And the 5th round will be a rapid fire, in which you will be asked 4 questions continuously. You will get 1 minute to answer. If you don't know the answer, you can pass. But at the end of completing all the 4 questions, if 1 minute is remaining, you can answer. But if you answer wrong, you will not get a chance to re-answer that question. Okay, I think you are okay. Got it? Okay. Now, I have got a lot. Okay, I will take the lot. First, I have numbered these small chit papers A, B, C, D, E, and F. So I would like to first, who wants to take the note? Harida, Ikra team, shall I take the note for you? Okay. You will be team E. E for elephant. Manjusha, please note. Team Ikra is team E. Next, I will take the lot for Shanti Hospital. Oh, Shanti Hospital is team F. F.
Okay, sir.
Next, I will take the lot for Febna. Febna is team C. C. Next, I will take for Sister Maisha. Maisha is team A. Next, I will take for Christina. Gone down. Christina has jumped out of the box, so I will see. Christina is team B. Team B. And the remaining is Regila, Sister Regila V, and Regila V will be team D. Okay. Now team A is Sister Maisha, team B is Sister Christina, team C is Febna, team D is Regila, team E is Ikra, and team F is Shanti Hospital. Is it okay?
Yes.
Any doubt? Do you want to have a trial round? If you want to have a trial round, I will do. I have some funny, some cooling off questions, everything, like we did yesterday. If you want to have, I will do it. Want to have? Or we directly go to the quiz? Because we are.
If they are okay, then we start directly to the questions. Then.
Okay. Is it okay with you?
Everybody seems okay.
Okay. Manjusha will be keeping the time. I will start share my screen because first 2 rounds, it will be a single response round. And you will be getting 1 minute to answer the question. Okay. And at the end of 1 minute, I will read out the answer. If you are correct, you will get 10 marks. And if you are not able to answer or if you are wrong, it will be passed on to the next team. Okay. So we'll start. Shall I start?
Yes, sir. Hi.
Sorry. Yes. So we will go with the round 1. As I already told, it's a single response question. And my first question is to team A, that is Sister Maisha. What is compliance regarding respiratory physiology? What is compliance? Maisha.
Volume pressure. Delta volume, delta pressure.
Okay, fine. So unit, if you are correct, you will get 10 marks. So unit volume change per unit pressure change. Very good. Then the next question is to team B, that is Christina. Which surfactant protein deficiency is lethal in the neonatal period? Your time starts now.
I don't know.
Pass. It goes to team C.
Lecithin, sir.
It's wrong answer. Goes to team D.
Inguamylin.
No. It goes to team E.
Protein.
Protein. No. Goes to team F.
Phospholipid.
No, you have to name the surfactant protein name. Okay. You go to team A.
Surfactant protein B.
Yes, you are correct. Your surfactant protein B is the answer. SP, surfactant protein B is the answer, which is lethal in the newborn period. So team A gets 5 marks. Manjusha, please note. Team C, what is cold stress? What is the temperature? Mention the temperature of cold stress. Team C.
36
Yes.
to 36.5.
Okay. Okay. Almost correct. That is 36.5, 36.4 to 36. You are correct. You will get 10 marks. Manjusha, please note. Next, the question to team D. A 2-day-old female baby is found to have conjunctival and retinal hemorrhage. What is the most common cause for this finding? Question is to team D. Speak up. I not hear you. If you don't know the answer, you can pass. No problem.
Time up. 1 minute is up.
Yeah. Question goes to team E. Ikra.
Difficult
The second
labor.
is. Pardon?
Difficult labor.
Yes, you are correct.
Delivery.
That is due to the time of labor, due to the time of delivery, the pressure, it causes the congenital hemorrhage and retinal hemorrhage. That is the force of birthing process. Team Ikra gets 5 marks. And the next question is to Team Ikra only. The desired relative humidity of a ventilator circuit is how much percentage of relative humidity is needed in a ventilator circuit?
Twenty to 30%.
Wrong. Goes to Team F.
100%.
Yes. Shanti Hospital got it right. F, team F gets 5 marks. It's 100%. Okay. Ikra, you may be thinking of absolute humidity. It's not, actually I asked about relative humidity. Okay. Now, it's a question to Shanti Hospital. What is the theme of World Prematurity Day 2020? You don't know the answer, please pass.
Pass.
Pass. Goes to team A. What is the theme of World Prematurity Day? Yeah.
Born too soon.
No. Tell me the full theme. What are you telling?
Right time.
Yeah. Next team B. Christina.
Importance of parental care.
No, it's wrong answer. Goes to team C. Febina.
Born too soon, providing the right care at the right time in the right place.
Okay.
Providing the right care at the right time in the right place. Born.
Okay, it's almost correct. I'll give you 5 marks. It is actually the correct theme is Together for Babies Born Too Soon, Caring for Future. But I'll give you 5 marks because you're told Together for Babies Born Too Soon. Because you are heard that talk by Dr. Vivek Singh. He has clearly mentioned this theme today morning's program. Okay. Now we have come to the end of the round 1, and now we go to second round. In the previous one, please, the answering team gets 5 marks. Okay.
Can we say the scores before we go on to?
So after the, okay,
right.
You want to? Okay. Manjusha.
So after the first round, Team A has 15 points on their scoreboard.
15.
Team 15, 1-5.
Okay.
Team C has 15 points.
Team C. Okay. 15.
Team C. Team E and Team F with 5 points each. Team B and Team D are yet to open their scores.
Okay, fine.
I would also request all the participants who are not answering to keep their mics muted.
Yeah. And also, if you are thinking that if you don't know the answer at all, you can pass. You can say the time. Okay. Now we go into second round. Second round, first question is to Team A, Maisha. According to the May 2020 samples registration system, what is the IMR of India? Indian IMR. How much it is in? You have to tell this figure in 1,000 live birth. I cannot hear you.
28.3.
Wrong. It goes to Team B.
33.
Shall I ask Febina, Team C?
$23.
Team.
23.
Wrong. Team D, Rajila.
8.
I am asking the IMR of India. Wrong. It goes to Team E, Ikra.
32.
Yes. Ikra has got it correct. 32. Christina has come to close, but if nobody has answered, I have given you 5 marks. But but Ikra has corrected it correct time that 32. So 5 marks goes to Team E, that is Ikra Hospital. It is 32. Now the next question goes to Team B, please expand RBSK. Christina, please expand RBSK. If you don't know, please pass.
രാഷ്ട്രീയ
ക്രമം തെറ്റിപ്പോയി. Okay. That's wrong, and the goes to Team C. Febna.
രാഷ്ട്രീയ ബാൽ സ്വാസ്ഥ്യ കാര്യക്രം.
Yes, good. Febna gets 5 marks. It is Rashtriya Bal Swasthya Karyakram. Actually, MKC sir has in oration has mentioned about this program 2-3 times, I think. Okay. The next question goes to Team C. That is Febna. CINAHL. What is it? Something which is very important to nurses.
Index of English language.
Index of English language. It's more than that. And it goes to Team D. Rajila.
Cumulative index to nursing and allied health literature.
Yes, you are right. I just want to know the previous team member. Who was it? Team C. Are you using any references?
No.
Sister Febna, are you using any references?
No.
Okay, fine. I have a doubt because you are told that cumulative English literature, something like that. Okay, fine. And the answer was done by correctly given by Team D, Regila. That is, it is actually a nursing journal database. That is a cumulative index to nursing allied healthcare literature. Okay. Next question goes to Team D, Regila. What is perinatal mortality rate? You can tell me the definition or tell me the formula. What is perinatal mortality rate?
It is the rate of stillbirth per 1,000 live birth. Rate of stillbirth per 1,000 live.
Okay, almost correct. Okay, I'll give you 10 marks because it is the stillbirth by total number of live birth in that year. That is into thousands. Okay, I'll give you 10 marks. Now the question goes to Team E. As per FBNC guidelines, SNCU is mandatory in any facility if the number of deliveries is more than how much? Team E, ICRA Hospital.
Thousand.
Wrong. Team F.
Pass.
Team A.
Pass.
Team B.
More than 5,000.
No. Team C. There's a clear-cut recommendation in FBNC.
3,000.
Yes. Who has answered it? Febna. Febna has answered.
3,000.
Team C has answered. Yeah. 3,000 is the correct answer. So Team C gets 5 marks. Now the question to Team F, Shanti Hospital. What is FIMNCA? Or yes, you can expand it, or you can tell me what is FIMNCA.
Pass.
Team A? You will get only 30 seconds if you are getting a passing question. Team A.
Time up, sir.
Facility-based integrated management. Facility-based integrated management child neonatal child illness.
Yes. Good. The team gets 5 marks. That is correct. That is a facility-based integrated management in neonatal and childhood illness. Actually, it includes birth asphyxia management and also the care of the sick babies at the healthcare providing level. That is from 2009. There is no IMNCA. There is only FIMNCA. The team gets 5 marks. Now, before going to the next round, we will know the scores.
I'm sorry, Murli sir. Sir, Murli sir, can you please check your chat box, sir?
Chat box, if you want to check.
So the end of second round, Team A has 20 points. Team B is yet to start. Team C has 25 points. Team D, 15 points. Team E, 10 points. And Team F, 5 points. So Team C is leading with 25 points, closely followed by Team A with 20 points.
Okay. Since I am conducting the quiz, I will be seeing the screen. Majority of the time, I will not be able to see your face. But there are people who are seeing your face. But if you are answering, you have to look at your camera of your mobile or laptop, whatever you are using. Okay. We have some doubts. That's why I have expressed one doubt about one team. But if you are answering, please have a proper eye contact with the team. Okay, with the team and also with the quiz master. Okay, there are people who are watching you. Please be aware of that. Okay. I didn't hear the scores, but I'll go to the next round. So this is a multiple choice questions. And please note that this questions, if you didn't answer or didn't know, it will not be passed on to the next team. Okay. First question to team A, that is Maisha. MAA, that is Mother's Absolute Affection, was started in the central government in August 2016 in an attempt to promote breastfeeding. Who is the brand ambassador of this program? Juhi Chawla, Kajal, Madhuri Dixit, or Manisha Koirala?
Option C.
Yes, you are correct. Yes, you are correct. You are getting 10 marks. Madhuri Dixit is the brand ambassador of MAA. Now comes to question team B, Christina. The World Breastfeeding Week was first celebrated in which year? 82, 86, 92, 98.
C. 1992.
Yes, it is first celebrated in 1992. So team B gets 10 marks. Now the question to team C, Febna. The Innocent Declaration 1990 was followed by Baby Friendly Hospital Initiative, Infant and Young Child Feeding, International Code of Marketing Breast Milk Substitute, World Alliance of Breastfeeding Action.
Baby Friendly Hospital Initiative.
Yes, you are correct. Team C gets 10 marks. It's BFHI. It was followed by BFHI. Now goes to next question to team D. This enzyme in breast milk kills amoeba and giardia. PABA, amylase, beta disaccharidases, bile salt stimulated lipase. Question is to team D, Regila.
Beta disaccharides.
Wrong. This goes to, the answer is wrong. And the answer is BSSL, that is bile salt stimulated lipase. It will not be carried to the next team. Okay. Now the question goes to team E. That is coordinated sucking and swallowing reflex developed by which week of gestation? Team E, ICRA. 32, you can see the
Option
options.
B, 32 to 34 weeks.
Wrong. It's actually coordinated sucking and swallowing that I specifically written in the question. It is by 34 to 36 weeks. Now the next question to team F. BFHI, sorry, the first baby-friendly district in India. Ernakulam, Bombay, Ahmedabad, or Kottayam?
Ernakulam.
Yes, you are right. Shanti Hospital gets 10 marks. It is Ernakulam was the first baby-friendly district, and Kochi was the first baby-friendly city in India. Yeah. Now we come to the end of the third round, and Manjusha, please have a look at the score.
So at the end of the third round, Team C is leading with 35 points. Closely on the heels are Team A with 30 points, Team D and Team F with 15 points each, and Team B and Team
F 15. Okay.
15. And Team B and Team E with 10 points each.
10 points. Now we go to the visual round. You'll be shown some pictures and you have to answer the question. And if you don't know the answer, it will be carried to the next person, next team. Okay. Team A is ready? Yeah. This bag is used to dispose what?
Needles, sharp.
Yes, correct. Yes, you are correct. Yes, you are correct. You get 10 marks. It is you to dispose sharps. Then the next question to team B. Who is this person? What was her specialty of practice? It is divided into 2 parts. 5 into 2, you will get 10 marks if you answer both the questions.
Pass.
Team C?
Edward Ray.
No. Team D?
No.
Team E? Ikra?
Theodore Escheris.
I didn't hear you. What?
Theodore Escheris.
No. Team F? Shanti Hospital.
Armida Fernandez.
No. Team A. Armida Fernandez was there in today's program. Kangaroo. Is Team A is answering?
Kangaroo Mother Care. Team A.
Team A. No, who is this person? Kangaroo Mother Care means, what do you?
Practice. Person name. I don't know.
First you have to name the person and what was the specialty of practice. Anyhow, Kangaroo Mother Care is not the right answer. Anyhow, I am not wasting time. And this is a person, in your day-to-day practice, you will be at least using her name at least once if you are working in an NICU or a labor room. Okay, it is none other than Virginia Abgar, who invented the Abgar score. Okay, actually, she was not a pediatrician or neonatologist. She was an obstetric anesthetist. Okay, very good. Now the question to Team C. What is this? Identify this equipment.
Exothermic mattress.
Yes, correct. You'll get 10 marks. Team C gets 10 marks. The question to Team D. What is this equipment which is used in the NICU to measure humidity of NICU? That is the humidity of the air in the NICU. What is the name of this device? Team D.
Pass.
Team E,
Pass.
Team F,
No.
Team A, Team A,
Humidity controller.
humidity controller. No. Team B,
No. I don't know.
Team C.
Don't know.
Okay, this is a null question. It is known as high growth term. It is used to measure the humidity of the NSU environment. Okay. Now the next question is to team E. What does this symbol stands for? Ikra.
Development and support.
Yes, very good. You'll get 10 marks. It is development supportive care. Next, the question to team F. What is the pathological diagnosis in this X-ray?
Pneumothorax.
No? Goes to team A?
Upper load consolidation.
No? Goes to team B?
Pass.
C? Team C?
NEC.
Oh, no. It is, what is team D?
Carbonate.
It's not tamponade. Okay, anyhow, tamponade cannot be diagnosed by an X-ray. Anyhow, you can see that air around in the mediastinal part. It is pneumomediastinum. Somebody has taken away with the star which is put in that area. Actually, the star is put on the thymus, which is normally seen in newborn. So this is a X-ray of pneumomediastinum. So now we come to the end of the fourth round. Just we'll have a look at the score. Manjusha.
10 seconds.
Yeah.
So the end of the fourth round, we have team C leading with 45 points. Again, closely followed by team A with 40 points, followed by team E with 20 points, team D and team F with 15 points each, and team B with 10 points.
Okay, fine. So this is actually one of the most interesting rounds in the entire quiz. You can score a lot of marks, and okay, there will be the difference in the scoring will also be decided by this round. In this round, you will get 1 minute to answer 4 questions. Okay, there will be 4 questions. I'll be asking one by one. You will get 1 minute as a total for 4 questions. And if you don't know the answer, it is better to pass the question. And at the end of considering all the 4 questions, if some time is remaining, you can go back to the question which you have passed. But if you have answered it wrongly, you will not get a chance to re-answer it correctly. Okay. So I will start with the team A. Team A, your first question comes. Your time starts now. Intubation of trachea humans to support respiration was first described by?
Pass.
Very preterm means gestational age.
Less than 28 weeks. Less than 28 weeks.
Wrong. What is severe hypothermia?
32, 30.
32? 32?
32 to 30.
No, no.
32
Tell
to
me.
30.
It's not clear.
30.5.
No, no.
32 to 33.5.
No, 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 no. Expand FBLM. FBLM.
Pass.
Okay. You want to attempt first question?
Time is up, sir.
Time is up. Okay. The intubation trachea to human support respiration was described by none other than Hippocrates. Okay. Then very preterm is 28 to 32. Then when core body temperature is less than 32 degrees Celsius, it is called as severe hypothermia. And FBLM is facility-based lactation management. I think team A didn't get any marks from that. Now the turn of team B.
Okay.
Continuous skin-to-skin contact was first practiced in which country?
America.
Wrong. Approximately what percentage of newborns require extensive resuscitation at birth?
5%.
Extensive.
5%.
Okay. Now, anyhow, it is a broad range. I will give you 2.5 marks for that. Ponderal index less than 2 means.
Pass.
Expand ANTT in infection control practices.
Time is up, sir.
Okay. Didn't get okay. One almost correct question. One response was there. Any continuous skin-to-skin contact was described in Colombia, and about 3 to 5%. That is in old NRP books, it is given as 1%, but around 3 to 5% of newborns may require extensive resuscitation at birth. Ponderal index less than 2 means it is malnourished IUGR because it is more than 2.5, it is normal, and 2 to 2.5 it is hypoplastic one. And ANTT is aseptic non-touch technique. Okay. Now team B gets 2.5 marks. Now comes team C. Death of Patrick Bowyer Kennedy, son of John F. Kennedy, focused world's attention to the importance of neonatal care. What was the cause of death?
Pass.
What is Dine's formula? Either you can tell me the formula or... Okay.
Pass.
What is the strength of alcohol used in hand rubs?
2%.
Wrong. Expand PIVKA.
Sorry. Okay, pass.
You have some more time left. You want to attempt any of this?
They have
Time's up, sir.
Okay. Patrick Bowyer Kennedy died of respiratory distress syndrome. And Dine's formula is a relationship between length and head circumference. 70% ethyl alcohol. That you might have got correct, but I'm pretty sure that you confused with the Clorox rate. And yeah, 70% ethyl alcohol. And then PIVKA is protein induced in vitamin K absence. So you're not able to score anything. Now the question to team D. Team D ready?
Yes.
George Gregory's invention is 71 revolutionized newborn care all over the world. What was his invention?
Pass. Pass.
What is T? What is T in latch score?
Pass.
Redman syndrome is a side effect of which drug?
Injection vancomycin.
Yes, true. Papile breeding is used for which condition?
Pass.
You have enough time. Some more seconds are waiting. You want to answer first, second, or fourth question?
First one, kangaroo, KMC.
No. Now second and third, fourth remaining.
Time is up, sir.
Yeah. George Gregory was the person who invented CPAP. And T is type of nipple. Vancomycin, you got it correct. And Papile grading is for IVH, intraventricular hemorrhage. Okay. Team E. What is the name of the scientist who invented oxygen? Team E. You don't know the answer, you can pass.
Respiratory distress.
Name of the scientist who invented oxygen. That you passed, huh?
Pass.
Okay, most common cause of infant mortality in India.
Respiratory distress.
No. Expand ILCOR.
Pass.
Thomson score is used for the assessment of.
HI.
Yes, correct. Yes, you will get 2.5 marks. You going to attempt first 3 questions?
IMR.
Time is up, sir.
Okay. You just want to tell something?
Pass.
Okay. Scientist who invented oxygen is Joseph Priestley. And the most common cause of IMR is prematurity or low birth weight. What comes together. And ILCOR is International Liaison Committee on Resuscitation. And they have got a committee that incorporates different bodies. And Thomson score is for HIE, that you have got it correctly. Now the next is goes to Team F, that is Shanti Hospital. Ready?
Yes, sir.
To bring the uniformity in practice, American Academy of Pediatrics started NRP program in which year?
Pass.
Breastfeeding decreases the incidence of NEC by how much?
Pass.
Which is the drug which is given as intravitreal injection for the treatment of ROP?
Pass.
Expand JSSK. It's a program, national program.
Pass.
There's still time, you can think. 4 questions, all 4 questions are remaining.
Fourth question.
Time is up, sir.
Yeah, I'll give you some. 4th question.
Janani Suraksha Samyojan Karikram.
Janani Suraksha Samyojan Karikram.
Yes, sir.
No, it is not. It is not that. Okay. So the AAP started NRP in the year 1987, and there will be 2/3 reduction. That is about 66% reduction in the NEC. And bevacizumab or anti-VEGF, it is the drug which is given inside the given as intravitreal injection for the ROP. And JSSK Janani Shishu Suraksha Karikram. Okay. Now we have come to the end of the session, and Manjusha will tell you the final scores.
That was a real treat at the end of today's summit. And congratulations to Murli sir for the perfect set of questions and all the teams for participating. So here we have the final scores. At the third
Just
position.
I want to know.
Yes, sir.
Just I want to know, is it going to tie break?
No, sir. No, sir. It's not tie break.
Oh, not yet.
At the third position, we have Team E from ICRA with 22.5 points. Congratulations.
Third position.
At the second position, we have Team A, Maisha, with 40 points. And bagging the first prize today in the Nurses Quiz is Team C, Febna, with 45 points. Congratulations to all the teams.
Good.
I'll just announce the other scores. At the fifth position, we have, at the fourth position, we have Team D, Regula, with 17.5 points. At the fifth position, we have Shanti Hospital with 15 points. And at the sixth position, we have Team B, Christina, with 12.5 points. Congratulations. Thank you, sir.
Yeah. Anyhow, you are all performed well, but some of the questions were difficult. I know that, but as far as possible, I tried to diffuse that difficulty factor to everybody. Okay. Anyhow, congratulations to the winner. And just I told yesterday, it is just a question of, it's just a matter of some few questions. It is not an assessment of your ability or your knowledge, but it's for fun. Take it as a fun. Okay. Thank you. Thank you for participating. And I would like to thank my team, that is Dr. Anand R and Dr. Anand N from MIMS Calicut and KIMS Trivandrum, because actually they were the people who were the backbones of this program, because they collected all the questions and forwarded to me. My job was just to prepare the PowerPoint or just to load the Kahoot yesterday. And Manjusha, and she was a quiz coordinator and has done the excellent job. I very well know that calculating this marks, everything is not a simple job, and also she has to monitor the delegates also. Now, jury was there, Tony sir and Varma sir, but in case of any dispute, we were ready to approach both of them, but they were acting as a mentors to this program. Thank you very much.
Thank you, Murli sir. Thank you
Manoj,
once
sir.
again.
Ronnie.
Varma sir.
Thank you.
I think it was a wonderfully conducted quiz program. And Murli has done, Murli and Manjusha and all the rest of the team has done an excellent job in conducting the quiz in a very fair manner. And I think all of them have got the right amount of difficulties and right amount of easy questions. So congratulations to the winners. Doesn't mean that the others are bad. All have done well and do better in next time. Thank you.
Yes, as Varma said, it was a very well conducted quiz. I could not take part in yesterday's thing, but today I think it was well done. And I think my congratulations to Murali and both Anands and Dr. Manoj, who has conceived the idea and did everything. So I congratulate the winners, and I sort of tell the losers that it, like Murali has told, it is just not a test of knowledge, but just to sensitize you to the common things in neonatology. Thank you.
Thank you all. Yeah, thank you, Murli sir. Yeah, before we end, I would like to just call our president, NNF Kerala, Manoj sir, to speak a few words.
Well, respected seniors and my dear friends, so we come to the end of the newborn summit this year. Hopefully, this is going to be an annual affair every year from now onwards, a conclave of nurses, doctors, and all other healthcare professionals working for the cause of newborns. The last program especially was very exciting. As I was mentioning yesterday to the participants, in fact, we had 93 registrations. 93 teams are registered, and 32 of them turned up yesterday. 33 of them turned up yesterday for the preliminary rounds. We had a lot of difficulty in shortlisting 6 teams from them. And like as we all know, luck factor plays a big role in quiz, especially when you have the technology aspect also, the technical issues also playing. So it is purely by luck that we get winners. it doesn't mean that others are losers. All are winners here. All those who dare to participate are all the 33 teams I would like to congratulate. However, we are issuing special certificates of participation to all the 6 teams and cash prize. The team, the first prize gets a cash prize of rupees 5,000, and this is just a small amount. A token of appreciation from NNF Kerala side. The second team gets a cash prize of rupees 3,000, and third team gets a cash prize of 1,000 rupees. To claim this money, I would request the teams to write an email with your bank account details to nnfkerala@gmail.com, and we will send you we'll transfer the money to your accounts. The certificates will be, each certificates will be issued to all the winners. For that, again, you need to write your correct name and all, again, email in that address. Having said that, this is not the end of nurses training. As we said in the morning, today is the beginning of newborn week celebrations, the first in the series of 10 programs we are going to have. We are going to have various programs like symposia, case discussions, parent interactions, and the nursing training modules all going on simultaneously in the next 7 days. So thank you all. I would request all your support and blessings for all the programs. I would again urge all the branches which are not planned programs also to conduct programs, and especially the backbone of this program, the nurses. They are the ones who who have been with us since September in the online module. A big number of them. We planned with a number of 500, and now we have 1,800 nurses in the Telegram group who are interacting. Some of them are silent listeners, but silent people are not just sitting silently. I am getting feedback from people. People are happy with it. The only thing they are not interacting. And some 40, 50 of them are very actively interacting in the group. So it's so satisfying. And we hope that these efforts will translate into actual benefit for the babies of our country. With those words, now we would end this session. Before I end the program, I would request NNF Kerala Secretary Vishnu, Dr. Vishnu Mohan, to propose official vote of thanks, after which we will close the session. Vishnu.
Good evening to all. So as I was telling, all good things have to come to an end. So on behalf of NNF Kerala and the organizing team of IAP and NNF Pathanamthitta, I thank our chief guest for the day, Dr. Rati Balachandran, for being with us today and inaugurating the function. I thank our guests of honor, Professor MKC Nair, Dr. Armida Fernandez, and our dear President-elect of CIAP, Dr. Ramesh Kumar sir, for being with us today and gracing the occasion. I thank UNICEF representative for the program, a consultant to the UNICEF, Dr. Vivek Singh, for addressing us today. Our senior IAP leaders, Dr. T.U. Sukumaran sir and S.S. Kamath sir, who has always been a mentor for us, for being with us and sharing their views today. I also thank Dr. M. Narayanan, President IAP Kerala, and Dr. D. Balachandran, Secretary IAP Kerala, for partnering with us for this initiative. Also thank Dr. T.P. Jayaraman, Dr. T.V. Ravi, and Dr. Santosh M.K., our IPP and President-elects of IAP and NNF Kerala. I thank all our dear eminent faculties for their excellent sessions today. To name a few, Dr. K.K. Divakar, Dr. Mangala Bharati, Dr. Suman Rao, Dr. Kishore Kumar, and Dr. Sushma Nangia, and all other dear faculties who have been with us today. A special thanks to Dr. Murli and team, Dr. Murli Raj, Dr. Anand Amar, Dr. Anand N, Tony sir, and Dr. Ravindra Verma for being for excellent organization of the nurses quiz. And last but not the least, I thank all dear and all our dear nurses who has been with us, all dear delegates who have been with us today. Thank you all.
Okay, now we close this session. Thank you. Hope to see you again.
Thank you.
Thank you, sir.
Thank you very much.